Please come Dr. KP Kudu, Dr. Ashish Nagpal, Dr. Ashish Bhojak, Dr. Paras Mehta, Dr. Monica Jethani, Dr. Ankur Singh. May I request Dr. Swati Rawani for her first lecture? નથી તો પછી કોણ બોલાવશું? ડોક્ટર પ્રફુલ્લા કે મહારાણા. અભી છે પેલા क्या बोलो क्या मुख्य प्रफुल्ल महाराणा क्या क्यों मोबाइल अब जो मोबाइल क्यों मुख्य क्या मुख्य
This is mine. Yeah, Paras Mehta. Co-chair.
Good morning, everyone. Thank you, AGOS. Thank you, Dr. Jagdish Rana, sir, for inviting me here. So I'll be discussing about lubricants, which are the drugs available and how one should choose it. Myself, Dr. Prafulla Maharana, I'm an additional professor at RP Center, AIMS, New Delhi, and current secretary DOS. So I'll keep it brief. I won't go into the details of each and everything. So why this is important? Why lubricating drops are important? Why pharma MRs are after your life? Why every 1 month one company launches a new drug? Because it's a huge market. If you check it in USA, this is the amount that is being used per year for dry eye patients. That includes your R&D also. So that's why it's a very important topic. Why? Because when so many people come to you and they have so many products, then it's very confusing. At times we often write something because somebody has said us this is working, but we may not know the basics behind it. So what is a tear, artificial tear or tear substitute is? So it has some basic structure to which you keep on adding certain things like composition, like presence and demulcent, preservative, ions, buffers, gelling agent and oil, so that you finally get an electrolytic solution that presumably going to replace your tear film or supplement the tear that is deficit. However, so far we don't have any ideal molecule that has everything, but one should know what exactly the tear film contains. So the most important component in any teardrop is your demulcent. And demulcent is, we all have such cherries in our childhood, I guess, right? Slimy sort of thing. So a demulcent is something which is mucilaginous preparation, and that coats the mucous membrane of your cornea or the ocular surface. So it forms a protective film and then it prevents further damage. Then few molecules, they have some another property that is called humectant property. What is a humectant? It not only stays in the surface, but it also absorbs water. So they prolongs the effect of your tear film. So these are the 4 commonly used base formulation in tear film existing today: CMC, HPMC, propylene glycol and polyvinyl alcohol based, and then sodium hyaluronate. So the property, if I remember, there may be some overlapping. There is nothing like clear cut. CMC has only mucoadhesive property. It may have some other property. The primarily CMC has demulcent property. HPMC demulcent plus some humectant, it absorbs some water also. Then when it comes to your propylene glycol based formulation, not only they have humectant demulcent property, they have a tendency to have some lipid restoration also. Then comes your sodium hyaluronate, now is very commonly used. So it has all these properties plus some corneal epithelial protection properties also. Okay, not only it enhances the proliferation, but also it felicitates the healing of your epithelium. So sodium has all these properties. Okay. To this we add something that changes or alters the tear film so that suits us in some certain type of specific dry eye disease. For example, you can add this carnitine, erythritol, sorbitol, glycerin, trehalose. What they do is they alter the tonicity of your teardrop, and then they take care of the hyperosmolarity that is thought to be the main cause for ocular surface damage. So they become osmoprotectants. So if you think that hyperosmolarity is causing the damage, choose something that has all these things. Antioxidants and vitamin D. Well, there have been several literatures showing that yes, oxidative stress is probably the common culprit in dry eye diseases, and like adding vitamin A, vitamin E, coenzyme Q10 and lipoic acid, they may help in reducing that stress. Similarly, vitamin D, as several papers have come up, it has also similar antioxidative property and some anti-inflammatory property that can help you in specific dry eye diseases. Oily agents like castor oil, flaxseed oil, when they are added to those basic tear film composition, they are helpful in cases where there is a lipid layer deficiencies. For example, cases of meibomian gland dysfunction. There is a talk on MGD. I think Dr. Lakhotia is going to cover that, so I will not go into details of this. Then there are few electrolytes that is added to this basic tear film. For example, boric acid, potassium, and a lot of electrolyte people are adding nowadays. So what they do is they not only alters the osmolarity of the drug, but also they maintains the pH. So if you maintain the pH, then all the side effects of drop installation like irritation, redness, that can be taken care of. So come into contact, converted into water and carbon dioxide, that is non-epithelial toxic. So they are called soft preservatives. Absolutely preservative-free drugs, yes, there are few, yeah, but I think the cost factor is a major problem with those drugs. So preservatives, don't take this concept that preservatives are bad. They are good, but the selection has to be proper. When you feel that there is a surface damage, avoid preservatives in your drops. But if ocular surface is fine, normal routine cases, you just need to be panicked about that. So I'll conclude with this slide. You can see this slide. So we have some agents, just wetting agents, supplement the tear film with some extra property. We have some agents who has some surface protecting properties like HPMC with vitamin D, antioxidant, trehalose, and then there are some drops that claim they cover all the above things. So I would suggest either go for this or this. Don't go for some drops if a company claims it has everything and it can. So if the patient is only having symptoms, it is not bothering his day-to-day life, CH drop is good enough. If symptoms are there and some signs are also abnormal like T-bird summer, then CMC plus, you have to go for that. If level 3, if there is objective signs, subjective symptoms, and some signs like conjunctival staining, SPKs, then go for something which is surface protectant like HPMC plus, trehalose, vitamin D, coenzyme, all this thing. For level 4, where there are signs of advanced dry eye disease like filamentary keratopathy, only lubricant is not going to work. You have to use immunomodulators and some other drops like acetylcysteine, all this thing. With this, I'll conclude here. Thank you so much. And I'm currently the secretary DOS. Our annual DOS is in 24 to 26 April. Please come there. Please support me for the AIS election as member Northern ARC. And thank you.
Thank you, Dr. Praful. It seems we would be taking the questions later. Can I ask Dr. Pooja Kamar to speak on what's new in dry eye disease 2026? Dr. Pooja.
वो क्या है ऊपर सर? A very good morning to all, and I would like to thank the entire AGOC committee, Dr. Jagdish Rana sir, and the whole team for giving me this opportunity to present. So, Dr. Praful has led the ground very well on why dry eye matters and the lubricants and when to use what. So, we do have to understand that like every disease, sometimes we are going towards a pandemic like myopia. Dry eye is also on this. And now we do have evidence that at least 18 to 32% patients in urban settings, especially in India, in higher IT populations and screen-heavy users are developing dry eye. And not just that, but the major drivers are also the climate changes, the environmental changes, the food habits, also the new lifestyles like contact lens uses and many other things. Dry eye disease is on a rise, and we need to treat it differently. And, it does impact your work and the quality of life. It impacts not only your day-to-day activities, but it makes you irritable. It impacts your psychological status. So you do have to deal with it, not just with a lubricating drop, but on a different thing. And it also affects your economics of dry eye, because one lubricating drop bottle a month can cost patient something. So that also impacts a lot. So if we have a customized treatment for these patients, it goes a long way, and it also, helps to reduce the burden of the disease. Now, it is not just the dry eye. Now, if a patient, especially the young patients, are coming for refractive surgery, or now the elderly patients who are coming for cataract surgery, sometimes if we take this disease lightly, if there is a pre-existing disease, or if the patient is a chronic contact lens user, if you do a surgery on them, then post-operatively, there's a tsunami of complaints which starts like pain, itching, irritation, glare, halos. Then the surgeries went perfectly fine. The outcomes are fine according to the clinician, but the patient is not happy when it comes to the quality of vision and quality of life, and it is not related to the surgery, but a subclinical disease which may have been missed. So, Praful very clearly said that, it is a little difficult, but we do have to understand that the classification and the definitions change. And DUCE 2 was only about the foundational definition and the framework, stage-based management, but then DUCE 3, they do emphasize the impact of diagnose and treat precisely, basically identified driver for every patient, match therapy, and go towards a personalized evidence-rich therapeutics. That is what DUCE 3 teaches. So when it comes to diagnostic algorithm, you do have questionnaires. Apart from just a Schirmer's and a fluorescein stain, if you do know that this is a patient of dry eye who may not only work with a CMC-based drop or a normal lubricating drop, it's always good to add a questionnaire, because a questionnaire will give you a lot of information about what type of dry eye disease we are dealing with and what should be the treatment. And based on it, it will give you a detailed classification, not only about evaporative or aqueous deficient, but much more than that. So incorporating those tests go a long way, and that's why we go from just a basic treatment, a blanket treatment for all, to a guided management pathway. Now, it's not just about dry eye disease. We just think it's dry eye disease, but there are many other factors related to it, and it can be eye-related disorders, it can be conjunctival-related disorders, non-ocular surface, mixed and miscellaneous ocular surface disorders, or corneal-related disease. So dry eye is not just about the tear film, but any of these conditions, if they're existing, then also it can impact, or patient may come across as a dry disease. So we have to go across and do the differential diagnosis for it, and this is a beautiful chart which helps us to do the same. When it comes to management, this is a very busy chart, but if you dissect it, there are tear film deficiencies, there are eyelid abnormalities, there are ocular surface abnormalities, and based on what happens, what condition you have, there is a very clear guideline given on what kind of treatment you you should be giving to the patient, whether it should be just tear film deficiency, evaporative, ocular surface inflammation, or it's a blink related disorder, and it gives you what treatment should be given for each. The lubricating drops have been covered very nicely by Dr. Praful, but now there is a role of immunomodulators, which is on a rise, and we should, whenever there is a patient which may benefit from immunomodulators, we do have to think about it, because that not only helps in good neural protection or reduce neuroinflammation, but it also helps in good epithelial remodeling, good healing after refractive and cataract surgeries, and because of that, patients can have better visual outcomes. So if you have a patient who can benefit from either cyclosporin, the two kids on the block are cyclosporin and lifitegrast, if you have one of it, you can use the same, because cyclosporin is going to calm the immune cell activation, which has already started. So if the tsunami of inflammation has started, then you give cyclosporin. But if it's a subclinical inflammation or just a start of dry eye disease, but not improving with a normal lubricating drop, that's when you give, because that prevents the immune cell arrival. And you do have therapies like IPL therapy, Meboflow, and Lipiflow, which also benefits patients for a late onset disease. So to summarize, yes, we are going towards a precision medicine where we have to move from one size fits all to a tailored therapy where every patient is given an individual therapy based on their signs, symptoms, and the diagnostic tests we do. Thank you.
Thank you.
Thank you, Dr. Pooja. As we decided that we would be taking questions in the end of the session, I would request Dr. Sharad Lakhotia to come over the stage and deliver his talk on MGD update.
Friends, today I'm going to talk to you about MGD update, and it's important to know that the number one reason why a patient visits an eye specialist anywhere in the world is because of the dry eye, and it's so important a topic. Today I think most of the speakers, earlier speakers, have already mentioned and clearly made the things they made it very clear that what is dry eye. So my specific point would be to make it aware to all of you that dry eye is not a disease to be only seen by the specialist. Everybody here present and every general ophthalmologist can be a dry eye specialist. As per the TFS DUCE 3 classification, they have narrowed down all those investigations into very simple thing. A fluorescence staining, that was enough examination of the eye with mebography or meibomian gland checkup by everting the lid, and little bit ocular and adnexa feelings and pressing on the lid margin to see how's the mebum secretion. All the small things, you don't require very high gadgets and sophisticated instruments to diagnose and treat a dry eye. But it is a very big revenue earner. Maybe you can increase your practice by 25 to 50%. That is why it is very important. And also patients' comfort is immense, and the patients are going to stay for you for long, because most of the dry eyes remain chronic because they're chronic inflammatory disease. So they have to consult regularly. So what are the I have to highlight things I'm going to mention to you. Yes, friends, let's understand what is dry eye. A chronic diffuse abnormality of the meibomian gland commonly characterized by terminal duct obstruction, qualitative, quantitative changes in the glandular secretions. And you can understand the incidence is so high of all the cases. Around every second or the third person is having dry eye, and 90% of all dry eye because of MGD. So MGD treatment has to be understood very well. And how is the MEBO score? It's grade 0, 2, 0, 1, 2, 3, 4. And according to American Academy, now they say 0, 1, 2, 3. That means 33% loss is 1, and then 33 to 66% is 2, and and the rest, other one is the free. So whichever way you decide, that understanding is very important, and you don't require sophisticated instruments. Even an autorefractometer, you can just invert the lid and examine the meibomian glands. You will get all this thing. MGD staging can be, they have already been explained earlier, that there is a 0, 1, 2, 3, again, depending on the meibomian gland secretions and corneal staining, we are all aware. Meibograde again is another way, gland distortion, shortening, and gland dropout, 0 to 3 marking, and 0 to 9 score is possible for each lid. Now let's understand the fundamental things. The low delivery state and the high delivery state by the MGD is classified as. The most common form is when there is a hyposecretion. Hyposecretion could be hyposecretory MGD because of gland atrophy, because of other things, and that obstructive, which is main thing, and secretorial and non-secretorial. Among the secretorial, commonly caused by influence of sex hormones, topical medications, aging. We have to understand that in a USA, 70% of the individual above the age of 60 are having MGD. So MGD is not so uncommon. So you can understand very well how much is the possibility in population, and the treatment is simple and it is rewarding both for the patient as well as for the surgeon, eye surgeon, because you can charge very well. High delivery state is characterized by release of meibomian in large quantities in seborrheic dermatitis and rosacea. We are all aware of the meibomian glands, how the normal morphology is there, and when there is obstruction, the acini became dilated and on all. Obstruction due to increased hyperkeratinization of meibomian glands affecting tear film stability, aging process, alteration, because all these things are very important. It's a multifactorial disease with a lot of possibilities in hormonal changes and nutritional status, reduced blinking, even medications, patients taking hypertensive medicines, hypercholesterol, cholesteremia medicines, all these things patients, they always have. Even putting topical drops, they can lead to MGD, meibomian gland inflammation. So MGD loop stasis of meibum, bacterial proliferation, this is a basic thing. Lipases, stresses secreted, melting point increased. Tear osmolarity has been very well explained that 308 is the cutoff point beyond which it is considered to be hyperosmolar, and difference between the two, if more than 8 is there. Not very important for every general ophthalmologist, because these are for those people who are in research and other activities. It's important, but for us to know, tear lab can be a very good tear expressions, lid expressions, another way. Diagnostic tests, all these things are the blink rate, very important, meniscus height, very important, 0.2 mm, and osmolarity, staining. Tear film breakup time is the most important thing that you would like to know personally, that tear film breakup time is normally, it is considered 10 seconds if the fluorescent staining time is there, but it is considered now 0.5 seconds for severe cases as far as TFOS deuce 3 classification. So they have narrowed down, so that unnecessarily labeling of a lot of cases of dry eye is not there. They are now telling that symptoms are more important than actually the signs. If there are symptoms, then you consider it dry eye, otherwise not. Schirmer test, other things we are all aware, not necessary, but breakup time is important. And the other measures of osmolarity, lid margins, vascularity, all these things have been. DEQ is very important, and OSDI, I just want to mention that now they have simplified, that deuce 3 has simplified that it is now only 6 questions. You don't have to have 12 questions. It's too long. So you can ask this for 6 questions, and the score, if it is more than 6, yes, you can consider it this way. So this is very simple. They have made things simple so that you can diagnose, level the case of dry eye and start treating it. LLT, blink rate, 60 nanometer is the height. If you have LipiView system, why not? Topical lubricants, very important, LipiFlow devices. It's a huge topic actually, but I just narrow down to lubricants already been mentioned, LipiFlow, intense pulse light, very important. Thermal pulsation and IPL and IRPL, they are the alternative treatment which we have to define. They have to be sometimes mixed and matched. But thermal pulsation is one thing which you can always do for patients. They may require repeated thermal pulsation, and it is a rewarding both for the patient. Patient is so happy that they will like to come back again and again. They ask for the thermal pulsation. So you should have the system, and it's cheaply available. It's not very expensive. So these things we have to understand. LLLT and other things are other modalities. Intraductal probing has also been tried. Azithromycin, doxycycline, they are all adjuvants. And then vitamin omega and B, all other vitamin D is very important. Vitamin D, B12, all these things have the components which are very important. So application now, The Deuce 3 basically is emphasizing the same things, and Mibo is the only drug which is approved first time for the MGD condition. That is in 2025. That is important for us to understand. And there are a host of drugs which are lubricants. They have to understand it's not the treatment. Most of the people, they think that this is treatment. This is not treatment. This is basically a palliative. Like if you have a fever, you give crocin. It's not the treatment. Treatment is the underlying cause. We have to find out the underlying cause and treat it. That's the most important thing. So we have to understand that, see, melting the mebum is more important, and thermal pulsation and IPL are the two mainstays, and now CGHS is also giving you, they are reimbursing money also. So it's becoming a very, very profitable proposition. And at the same time, very important for the patient, because half of the patient in the OPD, they have major problem of dry eye, which is causing. And before doing a refraction or a contact lens wear or even a refractive surgery or even a cataract surgery, it's so very essential to find out whether the dry eye element is there or not. And it has to be treated before you undergo any other procedure, other patient undergoes any other procedure. So with this, I thank you very much and make you aware that dry eye is a disease which is not to be treated by anybody except every ophthalmologist who can treat it, and you have the armamentarium within view, and it's not expensive. Thank you very much for your kind favor.
Thank you, Dr. Lakhotia, sir. Now I request Dr. Monica Zethad to come.
So good morning, one and all. Firstly, I would like to thank AGOS for giving me this wonderful opportunity. And my job has been made very simpler by the previous speakers. So I would not talk what's talked about. I would go directly into the neuropharmacological management of dry eye. So why do we need neuropharmacological? As Lakhotia sir clearly said, that lubricants are just symptomatic relief. They do not target the root cause, which is inflammation and neurosensory abnormalities, and thus there is the need for advanced agents. So in newer agents, we have anti-inflammatory agents, immunomodulator, neurostimulation, hormonal agents, growth factors and regenerative agents, and we also have some novel delivery systems in place. So cyclosporin was always available in the market, but what is new is the newer strength. It is now available in 0.09%, so it felicitates the absorption, and it enhances the delivery and quicker action of So trehalose is a very, very important molecule which is now there, and I would like to tell you an interesting fact regarding that, which is not related to ophthalmology but organ transplant. So when liver and heart is transplanted, it is kept in trehalose. So this was to let you know that how important it is in maintaining the tissue stability. If liver and heart can be kept, so how well it maintains the tissue integrity of our cornea. Lactoferrin was always there in gynecology, but it has got renewed interest in ophthalmology because of its antimicrobial, anti-inflammatory, nutritional and immunomodulatory properties. So it also works very well in treating dry eye. It's available in form of tablets. This is one of my favorite molecule, which is extract of makai berry. So what does it has? It has got delphinidines, which have very good affinity for the lacrimal gland acinar cells. And what it basically does is it enters the acinar cells and quenches the free radicals. So once the free radicals are out, it enhances the tear fluid production. Lifitegrast, when we used to take lectures 4-5 years back, we always used to say it's available in foreign countries but not in India. We are fortunate enough that now it's available in India and also at such an affordable cost. It's hardly anything, peanuts, what we are paying for Lifitegrast, and the mechanism of action is very good, and it starts its action in 2 weeks. The only problem with this is the bitter taste, which is very bad, and I think companies should work over it. And Reproxol, it is actually a novel reactive aldehyde species inhibitor. We will be seeing this molecule in future because this is in late stage of clinical development. And we know that evaporative dry eye is a very important cause of dry eye. So we have this Novo-3, which will function as an evaporative barrier. And so this will be very, very helpful in evaporative dry eye. But as of now, it is not there in the market. We will see it shortly. In regenerative agents, we have thymosin beta and autologous serums we already, all of us know. This is something new that till now we have been treating dry eye only with eye drops, but in future we might treat dry eye with nasal drops also, which will stimulate the intranasal, which will stimulate the trigeminal parasympathetic reflex, leading to increased natural tear production. We all know that perimenopausal and menopausal women experience dry eye. And so because the hormones are involved in that, in future we might also have androgen eye drops, estrogen receptor modulators eye drop in market. And there's also research going on into IL-1 inhibitors and matrix metalloproteinases inhibitors, aiming to block the specific inflammatory pathway in dry eye disease. Thank you so much for your patient listening.
Thank you, Dr. Monica. Now I request Dr. Paras Mehta for the talk.
Outset, I would like to thank the organizers and the scientific committee for giving this opportunity to me. Since there are overlap topics on this subject, I would be just, running through the slides. My topic is evaporative dry eye, current perspective. Since the previous speakers have talked about DUSE 2 and DUSE 3 guidelines, I would just restrict myself to definition of evaporative dry eye. And evaporative dry eye is currently understood as a multifactorial loss of tear film homeostasis, where tears evaporate too quickly despite often normal production levels. And it is the most common subtype of dry eye disease. Almost more than 80% of the patients do suffer with this. If we look at Indian data, 4 out of 5 dry eye patients have some form of evaporative or lipid deficiency dry eye. So modern understanding centers on the vicious cycle of inflammation. So if there is a lipid layer deficiency primarily caused by meibomian gland dysfunction, that can lead to hyperosmolarity of the tear film, and it can also lead to rapid evaporation of or increase in the salt concentration in the remaining tears, which triggers an inflammatory response, which would damage the ocular surface. And there is a mixed etiology. It is now recognized that evaporative dry eye and aqueous deficiency dry eye often coexist as continuum. Aqueous deficiency can actually cause evaporative symptoms and because thinner tear layers break up faster than the regular tears. This schematic almost explains the similar thing, that when the evaporation happens, the tear hyperosmolarity would increase and the surface would have more inflammation and the whole vicious circle would go on. So according to DUSE 3, it has divided risk, concentrated on risk factors for dry eye. Like if we consider other factors like evaporative dry eye is recognized to include both the lid-related problems and ocular surface related causes. Lid related would also include MGD and blink related causes. And they have further divided, subtype them into meibomian gland disease, systemic dermatosis, ocular surface related, and other causes. If we don't go into the details of that, the risk factors would be increase in the prevalence of evaporative dry eye increases with age, as with aqueous deficiency. Ocular risk factors are anterior blepharitis, contact lens wear, eye makeup, cosmetics and demodex and infestation. While systemic risk factors are androgen deficiency, menopause, rosacea, atopic dermatitis, seborrheic dermatitis, hypertension, smoking, alcohol consumption, benign prostatic hyperplasia,
Some of the systemic medications we have to consider in mind is anti-androgens, HRT, therapy for BPH, and antihistamines, antidepressants, and retinoids. Higher screen time in current time, exposure to visual display units are also risk factors for development of MGD, primarily due to reduced blink rate. Even incomplete blink is of a very significant risk in these patients. So how do we diagnose this? It's very important to diagnose dry eye disease and its subtypes for a clinician. The symptoms may be common or non-specific for the underlying etiology. One should also go into occupational history, ocular and systemic drug history to be noted, especially use of isotretinoin for acne and HRT treatment. These patients do present with at times asthenopic symptoms as well. And the questionnaires would be very helpful. And according to DUE's 3 guidelines, now the questionnaires have been reduced to almost just 6 questions. That makes it very easier for a clinician to implement it into the clinical practice. Following that, a good clinical examination followed by specific tests may be helpful. And which are those tests? Look for the presence of debris on the tear film, greasy lid margins, presence of flakes or cylindrical dandruff-like flakes, examination of the lid margin for any irregularities like thickening, telangiectasia, vascularity, changes in the mucocutaneous junction, collarettes, presence of frothy secretions collected over the lid margin, distichiasis, trichiasis, keratinization, cicatricial changes, and notching is essential. Examination of the meibomian gland orifices, like whether they are blocked, missing, or they are truncated, expressibility of the glands, in addition blink rate, extent of lead excursion. This is very important to understand, and presence of incomplete or partial blinks are also important determinants of the tear film spread and stability of the tear film over the ocular surface. So these are classified into the etiological driver tests in DUE's 3 guidelines. So when you look at the meibomian glands, look for the expression and the areas of gland dropout, or there are any, which should be looked on the slit lamp. Meibum quality and expressibility. Usually all gland adequate clear fluid should be expressed. It'll take a minute or so. Changes in the meibomian lead composition can lead to abnormal lipid behavior, like a higher meibum melting temperature resulting into a thicker meibum, ductal plugging, capping, stagnation, and pouting of the meibomian gland orifices. In addition to the ocular and lead features, it is important to look for features of dermatological diseases, like especially rosacea. In pigmented races, it is very easy to miss that. So in our population, the mainstay of diagnosis of, as you can see here in clinical pictures, the staining would be especially in the inferior part of the cornea, is against aqueous deficiency, where the staining would be more either spreaded all over the cornea, or it may be limited to the interpalpebral fissure. These are very classical pictures of blepharitis leading to inferior staining and changes onto the ocular surface as well. Chronic, in terms of the outer bronze ring talks about simple treatment, simple management. The middle silver ring talks about moderate treatment, and inner gold ring talks about complex treatment. And this schematic diagram has almost simplified reaching to the clinical diagnosis and the management part of it, which you can probably implement into your clinical practice. This is the same thing, and there are some, in current times, there are lipid preparations which are available, which was talked about by the previous speakers, but we should know about emulsions, nano-emulsions, and liposomal sprays and ointments, which are available for managing the evaporative dry eyes. The management guidelines would have, the maintaining of the lid hygiene, tear supplementation, local and systemic antibiotics, especially when you are dealing with rosacea, anti-inflammatory management, which was talked about in detail by the previous speaker, like cyclosporin, soft steroids, or maybe levetiracetam, management of associated conditions or systemic diseases, lifestyle modifications. This is very, very important to stress upon in current times. Blink exercises and other, adjusting the screen lights and 20-20-20 rule, which we have to explain to the patient. Other treatments like device-based managements are also house severe, which talked about management of evaporative dry eye, and they concluded that a lipid-based nanoemulsion of PG, HPG helps in improving the objective parameters and symptoms of dry eye disease. Additionally, it also supports improved meibomian gland function. So to summarize, management of evaporative dry eye due to MGD remains challenging. It is not unusual for a treating ophthalmologist to become perplexed by the variety of diagnostic tools which are available and therapeutic options which are available. Hence, these 3 guidelines are an effort to simplify the diagnosis of the subtypes and its management. So it is imperative to distinguish an evaporative dry eye and its subtypes and to customize the treatment for each of the patients instead of a blanket therapy to those patients. Additionally, one should spare adequate time to emphasize on prevention and lifestyle changes on the subtype of the evaporative dry eye. Thank you for your kind attention.
Thank you, Mehta ma'am, for this wonderful talk. For the keynote of this session, I would like to invite Dr. Raman Mittal, sir, who would be joining us from Amritsar. He's an par excellence oculoplastic surgeon. Over to you, sir.
Good morning, ladies and gentlemen. First of all, I would like to thank the organizers of AGOS, my friends Dr. Brahmbhatt and Dr. Rana, for having me here. And especially thanks to them for having accommodated my talk here today. Otherwise, it was yesterday, but due to my flight schedule, they used it here. And to break the monotony, as Dr. Mehta said, from dry eyes, I am talking something different from dry eyes, which is variations in ptosis. Ptosis is a very common entity which you all see in your clinics, and any drooping of the eyelid, whether it's one eye or both the lids, we call it as ptosis. The general things which we know is 2 variants, congenital as well as acquired. So we have all these workup which we all mostly know about the ptosis. Apart from these, there are a few more things which you should understand and do in your clinic so as to differentiate about the whatever you're dealing with. And these are the procedures you go along in case you have a ptosis patient. I will not dwell into the details of ptosis because here I am to tell you about the variations we encounter. This is a very common entity, congenital ptosis. If it's a poor LPS action, you go with the tarsofrontal sling. If it's a good or moderate action, you go with LPS plication or resections. Another important thing is the aponeurotic ptosis or the senile aponeurotic ptosis, which is the commonest in the older age group. The sudden and the slow drooping of the lids are there, and doing LPS exploration with the advancement of the LPS muscle, you have wonderful results. Bilateral entities generally, and you can do both the eyes at the same times. Coming to different type of you can say variations in this, you see that it's a congenital ptosis with a hypotropia. So there is squint underneath, and you should evaluate the child whenever he or she visits in your clinic and see if there is a hypotropia or squint. So first entity is the squint to be corrected, and then the ptosis is to be corrected. This is to be kept in mind. Sometimes because of the drooping lids, even the parents would not have noticed the squint underlying. Then ptosis with Marcus-Gunn phenomena. Ptosis is there, but there is a Marcus-Gunn phenomena. So either you have to correct the Marcus-Gunn phenomena or counsel the patient in a way that correcting the ptosis will reduce the Marcus-Gunn phenomena, and the patient will have a better cosmetic outlook as well as reduction in the Marcus-Gunn. Blepharophimosis is a slight variation of ptosis, I would say, because here it's not only the vertical fissure height which is decreased, but it is the horizontal fissure width also is decreased. So you can do it in 2 stages, firstly increasing the fissure width and then increasing the fissure height. So that is what you can achieve finally from a very thick and a small eyes to very nicely presentable this thing. In some ptosis, what you see is the inferior scleral show. This has to be documented well in before, because if you correct the ptosis, like in this lady, the ptosis is well corrected, but the inferior scleral show, which mostly gets corrected automatically, is not corrected, and the patient may complain that now the eye is looking larger. So then you have to correct the inferior scleral show by doing another procedure. So here I did a lateral tarsal strip correcting the inferior scleral show, and now the patient is cosmetically happy. So if you would have documented and counseled the patient pre-operatively, surgery, he or she would be fine. Otherwise, they will blame you even after doing a very good surgery. Then these variations you very well know, the myogenic and the neurogenic and the traumatic and the mechanical. I'll go one by one. Myogenic are one of the commonest mistakes we may make in our clinics, myasthenia gravis and CPEO, which is chronic progressive external ophthalmoplegia. Both needs to be differentiated from each other. In myasthenia gravis, we have weakness and fatigability of limbs sometimes, which are included along with the LPS muscle, which are weak, and the patient may present with purely ocular signs or even have a generalized fluctuation of the weaknesses as the day progresses. So that causes the worsening of the ocular symptoms while reading, watching television or driving. So the patient may present to you with ptosis or squint. Here you see it looks like a simple case of ptosis or an neurotic ptosis, but actually on a careful history and examination, the patient has myasthenia gravis. An eyes test in the clinic is a very simple tool you can evaluate and do with. And then you can treat the patient conservatively on myasthenia lines rather than going in for surgeries. Patient may present to you with diplopia apart from ptosis and orbicularis oculi weakness as well. These are the few diagnostic tests which you can perform to rule in the myasthenia. Epsilon test and anti-acetylcholine receptor antibodies are the most common. Eyes test is the very simplest one. You have to differentiate it from the CPEO, or I would say even multineuropathy. Here you see that the patient gives a sudden or sometimes a progressive history of drooping of the lid, and sometimes they may give you a history of diabetes and all. So you have to wait and watch till the pathology is gone by giving some crutch classes to the patient. CPEO is a relative contraindication, or chronic progressive external ophthalmoplegia is a relative contraindication for doing ptosis surgery because of the risk of exposure keratopathy. So here crutch glasses makes the life easier till the pathology goes off in multineuropathies, but in CPO that's the only thing which you can do. But if it is severe, you can do an undercorrection, just exposing the pupillary areas and rather than just giving it a full correction. Again, a very common entity is the third nerve palsy, where you see it's not only the droopy, but the movements are also restricted. So here you do again a conservative management and the patient gets resolved. Doing nothing but just hand holding of the patient is important. So these are things which we may miss in our busy clinics in day-to-day practice. Now this patient comes to us with a sudden history of ptosis, but then referred to me as a ptosis patient. But if you see the patient had some inflammatory changes, and on ultrasonography and MRI you see a cystic lesion in the muscle in the LPS-SR complex, which is a case of myocystic sarcosis, and treating on the lines of myocystic sarcosis by albendazole and steroids, patient resolved. Similarly, a young girl in teens, she again had a similar presentation. Her scan showed the thickening of the muscle as well as the cyst in the scan. You see here the scollex is seen in the scan. So treating on the lines of myocystic sarcosis, within 1 week she responded so very well. Another thing which we may miss otherwise is enophthalmos. Patient looks like a ptotic patient, presents to you with ptosis, refer to you for ptosis, but actually has enophthalmos. She had a congenital enophthalmos, and the scan showed that there was muscle atrophy as well. There was no muscle movement also. So in this case, first I treated the enophthalmos and did the residual ptosis correction, so giving her a good cosmetic appearance. But if you would have missed the enophthalmos, probably the correction would not have been sufficient. So you have to have that in mind, that the pseudotosis can be presented by a patient of enophthalmos. Mechanical ptosis, if there is some lesion in the lid, can present like this child, simply can be said to have a congenital ptosis. But if you invert the lid and see that patient underneath had a capillary hemangioma, on treating with Ciplar or propranolol, the patient or the child resolved well. No surgery was required. Again, another case looks like a simple case of ptosis. It is not a ptosis, it's a pseudotosis, because if you do not do your complete examination, just lift the lid and see, there is some lesion lying underneath. It was a salmon patch appearance, a very pathognomic sign of lymphomas, so you need to treat the underlying pathology and not what she is presenting with. बुखार को treat नहीं करना, बुखार क्यों हुआ है उसको treat करना ज़्यादा ज़रूरी है. Similarly for this child, gives a history of ptosis and a trauma. So thought was a traumatic ptosis, but lifting the lid showed this lesion, and treating this lesion, the ptosis was corrected post-operative. Ptosis was not corrected, but the lesion was corrected. Again, microcornea sometimes can present with ptosis because of the drooping of the lid, or the support of the lid is gone because of the microphthalmos or microcornea. Again, it comes under the pseudotosis category. So in all these entities, what I'm trying to show and present and convey is that you just don't jump into the conclusion of ptosis by just seeing a patient having a droopy eyelid. Rather, you should investigate and find out what all could be the other possibilities of patient presenting with a ptotic eyelid. Thyroid orbitopathy, again a very common entity. Here again, patient may present to you with ptosis but actually has a retraction of the other lid, and then you have to treat the thyroid, and the patient has to be treated properly so as the inflammatory signs are gone and the patient will be resolved. Sometimes patient comes to you for ptosis, but you have to actually treat the retraction which is there, which is causing pseudotosis in the other eye. This gentleman was operated for the retraction surgery, and after doing the session had a wonderful result. Before I end my talk, I solicit your support and vote as I am a candidate for member scientific committee. Thank you again for the organizers for having me here. Thank you. I hope next time you see a ptosis patient in your clinic, you would be thoughtful of all those entities which I have gone through in this presentation. Thank you very much, the panelists.
Thank you very much. I request all the speakers to come on the dais for the photograph.
Do we have any questions from the audience for any of the speakers, please?
A very, very interesting program, and I must appreciate the organizers for a wonderful program on dry eye and other things. With Dr. Raman Mittal, I would like to say he has highlighted very well about ptosis, and one of the very important things associated with ptosis for every ophthalmologist, and in fact every doctor to know in the country, is that there was a case in 2024 decided by Supreme Court of India on a case of ptosis, where an NCDRC asked for a big compensation. The patient got big compensation because ptosis increased and the vision dropped. And this was case again in Chandigarh. It was at PGI, and then Supreme Court reversed the decision, saying that the treatment no doctor can guarantee, and if he has gone through the same line of action proper, which is normally done by ophthalmologists, then it is no negligence, and they reversed it. So it's important that whatever the terms he is explaining, that whenever you are treating a case of ptosis, it's very essential that you must manage those steps, so that nobody can say that you did not do something which was needed, like in myasthenia gravis and other things to understand. So very well highlighted. So I appreciate it, and I just correlate with that case that is happening. So that is my point. And second point, which I lost during my discussion, I did not say one important thing which was missing, and that I am also standing for Joint Treasurer AIOS. So please do vote for me. Thank you.
Thank you, sir. I would like to request Dr. Shashank sir to felicitate Dr. Raman Mittal sir. Okay, sir, Divang sir, Dr. Anna sir, please come on dais. Jethani sir, please. Kakade sir, please come on dais. हाँ सर Thank you all. I would like to request Dr. Divyang sir to felicitate Dr. Paras ma'am. Ma'am, please. Now I would like to request Dr. Sharat sir to felicitate Dr. Pooja ma'am. Sir. I would like to request Dr. Ankush sir to felicitate Dr. Monica. Please all for the group photography, ma'am, please.
Sir, Dr. Anand, Dr. Kankaria, please.
So now we are concluding this session. Thank you. We are moving forward to the biotech session. I would like to request to come on dais Dr. Amit Shah sir, Chairman, Co-Chairman Dr. Namata ma'am, Moderator Dr. Shail Vasavda sir, Co-Moderator Dr. Bhavik Jala sir, Convener Dr. K.P. Kudlu sir, Co-Convener Dr. Anand Pathasati sir. Those who have please come on dais. Divyang sir, please come on guys. चालू कर फोटो I would like to call upon stage Dr. Santosh sir for his speech.
इसमें आ नहीं रहा, इसमें स्क्रीन पे फुल शॉट स्क्रीन।
Good morning, friends. Dr. Santosh Hunar sir doesn't require any introduction, but still he is a dynamic secretary of the All India Ophthalmological Society, is an excellent oculoplastic surgeon, and his talk is on minimally invasive orbital surgery.
Good morning. I thank you for the opportunity. I'll be speaking on minimally invasive orbital surgery, like minimally invasive glaucoma surgery, minimally invasive cataract surgery, etc., or even VR surgery. We have minimally invasive orbital surgery as well. Mainly we talk about certain diseases such as eosinophilic granuloma. Like this lady has venolymphatic malformation, and unfortunately her lesion is all around the optic nerve, SRLPS complex, lateral lacrimal gland, and the medial rectus. So intracorneal space, a diffuse lesion is very difficult to deal with surgically. Invariably, it will leave some complication and stigma of surgery. And the patient is only symptomatic for the proptosis that she has and recurrent periocular and subconjunctival hemorrhage. In such a situation, we would prefer injections. Injections as Picibanil delivered directly intracorneally by using image-guided techniques can help clear the lesion completely from intracorneal as well as extracorneal spaces, and the patient gets the cosmesis that she wanted. This is a straightforward use of Picibanil, which is a much better drug than bleomycin, but is difficult to get. Bleomycin is also used very commonly, and it is used in mainly macrocystic venolymphatic malformation where there is intralesional hemorrhage. We aspirate the blood within the lesion, that's the chocolate cyst, And we used to inject equal quantity of bleomycin right into the lesion. Currently, we use about one third to half, even that is sufficient. This is one patient where somebody had done an attempted biopsy with abandoned because of bleeding, but that was a microcystic venolymphatic malformation, and that could also resolve with intralesional bleomycin injection. So for microcystic, we use a much lesser dose, whereas for macrocystic, we use half the amount of the aspirate. This was an acute hemorrhage in a venolymphatic malformation. It was a clotted blood, so we had to clear it with an incision and then inject bleomycin. What about this patient? This is a patient we clinico-radiologically believe has eosinophilic granuloma. The roof of the orbit and the dura are involved. Curettage is not possible because of risk of CSF leak. In this situation, we go by the safe approach and biopsy from the center of the lesion, not close to the dura at all, confirm the diagnosis that it is indeed eosinophilic granuloma, and inject triamcinolone right into the lesion under visualization. 3 months later, you can see partial remodeling of the bone, and 6 months later, there is complete remodeling of the bone without any stigma of the lesion. This is minimally invasive because we did not do major orbital surgery. We relied on diagnosis, which made us do this particular step effectively. One more example where there is a breach completely remodeled following triamcinolone injection. Now, what about dermoid? Dermoid is a surgeon's delight. Every one of us excited about surgery. But what if a patient refuses surgery because of the fear of scar? Now, she has a lesion which is on the lateral side and it is adherent to the periosteum. So obviously we cannot approach it by the lid crease incision. We have to go by a direct incision right on top of the lesion, and the patient is not keen on it. In this situation, we use what is called foam sclerotherapy. This is a dumbbell dermoid where we have used foam sclerotherapy. Cetrol is easily available. It is used in varicose veins management. We inject this right into the lesion after aspirating. We mark the perimeter of the lesion. We obviously already know on MRI and CT scan that the content is fluid and is aspirable. Then only we attempt this procedure. We aspirate the lesion completely, and then we foam sodium tetradecyl sulfate. Tessari technique is used for foaming, where we use 2 syringes and foam STDs into 5 cc. 1:5 is the volume that we create. It has to be a stiff foam. It should not be a loose foam. And it is injected right into the lesion. And you can see nice results after SDTS. About 2/3 of the patients respond to 1 to 2 injections of SDTS. Not all patients, I must confess. And those who have residual can easily be excised. One more example of a patient where there was a forehead dermoid, and that responded to sodium tetradecyl sulfate injection. Coming to minimal access surgery. Earlier, orbitotomy was a surgery by skin approach with obvious scars, etc. That was Berkey in 1888 who attempted lateral orbitotomy. We shifted on to much less visible stellar right and lid crease incisions, but currently the approach of choice is transconjunctival approach for a majority of lesions. Medial, inferior, lateral, all these are accessible transconjunctivally. What is not possible is the superior orbit, where LPS comes in the way. This is a patient with orbital teratoma with a tumor on both the sides of the optic nerve, medial as well as lateral. Transconjunctival approach, lateral cystic component, that's the optic nerve seen clearly between the 2 parts of the lesion, and that is the medial solid component. This was the area where optic nerve was passed. That view was possible by transconjunctival approach. Now, this is a young lady with cavernous hemangioma of the orbit where we have used this approach. I'll just quickly forward the video. We begin with a small lateral canthotomy and inferior cantholysis to get egress to the inferior fornix. That's the cantholysis that's being performed. Then we make a transfornical incision, which is just short of the inferior fornix all across. Ledge the inferior orbital margin with a lid spatula. Expose the periosteum. Make a periosteal incision as close to the orbital margin as possible. Periorbital dissection until we visualize either the apex of the inferior orbital fissure or the infraorbital nerve. Those are the structures that are not to be damaged. And once that is done, cauterize all the perforating vessels and then make an incision in the periorbita, retract, visualize the tumor and dissect it until it becomes ballotable. this approach, we also have intraoperative navigation for precise approach with a much smaller incision that is useful for incisional biopsies. In conclusion, I would say that rapid new strides and paradigm changes are happening in the realm of orbital surgery. Many strides and paradigm changes are happening in the realm of orbital surgery. Minimal excess surgery is precise, better outcomes, and fewer complications. Thank you so much.
Thank you, Dr. Santosh. Now I invite Dr. Vanathi to deliver talk on the recent advances.
विधानी है नहीं, वो तो एक बार उसको फीड कर दिया ना, तो जहाँ चेंज होता है कि आगे चेंज हो गया, कैसे विधान में आया पता है।
Yeah, okay. Good morning, all of you. And at the outset, many thanks to the organizers for having me in as a speaker in the AIOS symposium here. So the next 7 to 8 minutes, I'll just walk you through this new concept in keratoplasty. It's not new, but that probably we're just revisiting it again, vis-a-vis the tissue replacement keratoplasty, which are commonly used to. So this is tissue addition keratoplasty, or what we call as lenticule addition keratoplasty. No financial interest in the mention of any procedure during the course of my talk here. So this is a busy slide here, and this almost compasses all types of anterior segment interventions when we look at this disease of keratoconus or corneal ectasia here, and we pretty much manage it with glasses, with the contact lenses, with a variety, with the ectasias, with collagen cross-linking, and surgical interventions in form of penetrating keratoplasty or deep anterior lamellar keratoplasties here. But we do have problems when we do penetrating keratoplasties, and again, DALTs are not free of rejections in these cases here. So I think whenever you talk about keratoconus, the talk never gets complete without looking at a DALT video here. So that is a big bubble, a Descemet sparing big bubble captured on the intraoperative OCT here, and the roof of the big bubble chamber being de-roofed and divide and conquer, and then you proceed to put on a lamellar graft here. So deep anterior lamellar keratoplasty has been conventionally the methodology of managing those which do not improve with contact lens wear here. But rejections do remain a concern here vis-a-vis what we taught earlier, but probably not as frequent as penetrating keratoplasties here. So in comes the concept, or in comes revisiting lenticule addition keratoplasty has been described way back as 2006 here, and comprises of making a lamellar pocket in the ectatic cornea in which the lenticule, the donor lenticule, is implanted here. So this is a lenticule addition keratoplasty vis-a-vis the one which we commonly do, which is a tissue replacement keratoplasty. So we looked at a subset of patients of progressive ectasia who are not suitable for conventional accelerated collagen cross-linking because of the extensive corneal thinning here. So we took a subset of patients who had just about 350 to 400 microns and were not improving beyond 618 on spectacle and contact lens wear, and those who wanted to participate in the study. And we looked at these cases and subjected them to the technique of lenticule addition keratoplasty. So the lamellar dissection can be done manually as well, but the femtosecond aided dissection always helps you to get a uniform dissection of the host bed here. You do need to make certain modifications in the laser settings, whichever machine you are using for the intrastromal lamellar dissection here. So that's the lamellar dissection created here. This is the donor cornea, and it's mounted on the automated microkeratome to make the donor lenticule here. The epithelium is debrided earlier, and the anterior lamellar button is made. The thickness of this button depends upon the amount of ectasia you're dealing with here. And here we did a uniform thickness with a cut with a 200 micron blade here for all our patients. The lamellar cut is made at a depth of about 180 microns here. And we go back to the host cornea here and open up the lamellar dissection, which has been with the femtosecond laser here. Which helps open up the femtosecond aided lamellar channel we had already made earlier. You could see the IOCT, you could see the depth of the lamellar incision which has been made earlier here. And once this is opened up, we just go in and insert. It's a simple insertion here, but take care we do not put in the, we do not insert in the epithelial cells, because then epithelial ingrowth will become a major concern in these patients here. So this is about an 8.5 diameter in a channel, or in a 8.9 diameter lamellar dissection created in the cornea, and it is it's smoothened out, free of any wrinkles here. So it's as least invasive as it can be. And then the routine protocol of accelerated collagen cross-linking is performed on these patients here. So we looked at it as a pilot study in 10 patients, and we do now have a follow-up of over 2 years, which will shortly be hitting the hitting PubMed for you to read on how this fares in this subset of patients here. And this is just one more case. I'll just run through it rapidly. So it looks simple after you've made the lamellar dissection, and it is the insertion. And this really helps to use corneas which are not of optical grade, because you're just using an anterior lamellar lenticule devoid of epithelium, but comprises of the Bowman's membrane and the anterior stroma here. We looked at our results of these patients, and of the 10 here, none of them lost their best-corrected, uncorrected visual acuity. All of them improved on their uncorrected and retained their best-corrected, and there was improvement in about 70% of them. The 7 of the cases improved with their best-corrected visual acuity as well. There are other parameters which we did evaluate, but for the lack of time, I'm not going to into those here. It does help in improving the corneal biomechanics here, and tectonic integrity is definitely there, and it helps to stabilize. These are postoperative follow-up pictures that you can see that by around month 1 they have topographic stability, and the lenticule also thins down, because these are non-optical grade corneas, and by about 6 months to a year they are stable here, and they do bring about good improvement in visual acuity here. But then what's important is the kind of cases you need to select for them. It works best when you have a more regular irregular astigmatism, and central cones or central round cones are those cases in which it's really going to be helpful. Quality of vision, definitely I would still put DALK as on the top of the chart, because that's a single interface, and you do have 2 interfaces here which do compromise the quality of vision here. But this is good for those patients who are perhaps not ideal candidates, who do not want to go in for a keratoplasty procedure. It does work as an interim procedure. So before I close, I would invite you all to submit your quality publications to Indian Journal of Ophthalmology, and we are also going to open a new section on experimental ophthalmology to also take in publications from the extensive research work which is going on in India here. I thank you all for your support here, and for some postgraduates and fellows, I do refer you to our postgraduate ophthalmology book. The 3rd edition is just on the way here, and I would solicit your support for the term as for editor of Indian Journal for the 2026 to 29 as well. Thank you for your patient listening.
Thank you very much, madam. It was a very nice presentation. Yeah. Would like to continue second talk?
No, yes. No, I think.
Okay. So I would like to invite Dr. Arvind Moria, study comparing autofocus pro with acryl.
Dr. Sandeep Arora, please come on the dais.
Good morning, everyone, and thank you, AGOS, and my very good friend, Dr. Jagdish Rana, Divyang Brahmbhatt, sir, and everyone in AGOS. Thank you so very much for the invitation and the opportunity. So this was a study that we did and compared this Autofocus Pro, innovated by none other than the greatest of all innovator in India, Dr. Jagdeep M. Kankaria and his team, versus the ICREL Active Multifocal. So these were the aims and the methodology to evaluate and compare the visual outcome at the first and 6 weeks after implantation of these two IOLs. That is the ICREL Active Multifocal IOL versus the world's first progressive polyfocal Autofocus Pro IOL, and Jan 2020 and Jan 23 with bilateral implantation of one of the either presbyopia correcting IOLs and preoperative astigmatism of one diopter or less. And we compared the residual refractive error, contrast sensitivity, reading speed, depth of focus, and patient satisfaction, of course. And all these were the uncomplicated temporal phacosurgery. And the different statistical analysis when and where needed. So demographic factor, there was no significant p-value difference. Now coming to the gender, again there was no significant p-value difference. It was equally distributed. Coming to the improvement in the distance visual acuity, so in both the groups, it improved to 6/6 with no significant p-value difference in either group. Now coming to the intermediate, so it was as expected because the multifocal has only bifocal for the distance as well as the near point only. So it was I6 and I8 in the Autofocus Pro, and it was poor in the multifocal group. Near visual acuity, again significant p-value difference. As the 92% improved to N6 with the autofocus, and 8% had an 8 vision, whereas 85% N6 in the multifocal, and 11.3 had an 8 improvement of vision. Coming to the depth of focus, it is different from the defocus curve. What is depth of focus? So this is the IOL ability if the biometry is wrong. So we compared it. So in the ICREL, it was 1 diopter. And in this Autofocus Pro, it was between plus 1.5 diopter to up to minus 3.5. So even if our biometry goes wrong by this much of diopter, the patient distance vision remain in the range of 6/6 or 6/6 part. Reading speed, again, it was better because there are no refractive or diffractive zones in this IOL. And contrast sensitivity also, again, pretty good in the Autofocus Pro with significant p-value difference. So this is how you can calculate this depth of focus. It's a simple chart, just like a fogging you can do, and it has a range of just like a teenager accommodative power. Photic phenomena, dysphotopsia. So these are because of the rings. So it is ring free. So therefore there is no halos and glare. And dysphotopsia, why it is happening? Because most of these IOL have 6 millimeter of the optic. So in the highest of the mesopic condition, the pupil dilates more than this. So there is 10 to 20 degree of the aphakic area on both the side, and that leads to dysphotopsia. So it's at larger size, 7.5 horizontal and 6.3 vertical. That's why it is free from dysphotopsia also. And the patient were satisfied more in this polyfocal progressive IOL group. And this is how it looks. So you can see there are 2 holes that needs to be dialed in the superior part. These are position indicator also. If you misaligned by 35 degree, it doesn't matter. If it is more than 35 degree, we need to realign it because it works on GRIN technology, gradient refractive index. In the superior part, the refractive index is 1.42 and gradually it increases to 1.54. And this is how it has the ability to correct the distance intermediate as well as near visual acuity. This is how it looks as we compare with the other premium IOLs. So in the conclusion, this is the world first study, already more than 5,000 read in the clinical ophthalmology, and it highlights the superior clinical outcome and the patient satisfaction associated with autofocus pro IOL as compared to the multifocal IOL. And it is an ideal ringless and novel premium IOL at a cost of the EDOF with no negative dysphotopsia, halos, glare, progressive polyfocal pupillary independent PCIOL, correcting all types of vision and fit for night drivers with crisp and clear vision with excellent depth of focus and most economical. And I request for your humble support for my candidature for the post of AIOS ARC South. Thank you so very much. Now I request the innovator Kankaria sir for his comment on this study. Just one.
Thank you so much, Dr. Moria, for conducting this study at AIMS, Hyderabad. And more than any of these study, I would like to inform the House that Dr. Moria has selected eyes of his own mother, as well as his aunts and all relatives. So, more than this fact selected by own mother, he is affected himself, which shows your confidence. The lens looks like monofocal, it works like multifocal, and if you over-refract the patient, anything from +1 to -4, the vision will remain the same, 6.6 or 6.9. So I request you all to try, at least in 1 or 2 of your normal category patients, put it in both eyes and see the results, and you will get hooked to this lens. Thank you. And I request the Gujarat Ophthalmological Society delegates to support Dr. Moria for the ARC, because he's one of the most prolific.
Thank you, sir. Thank you so very much, sir.
Thank you, sir.
Thank you so very much, sir.
Dr. Moria, just a question. What do you target for these patients, emetropia or myopic side?
0.25 higher, little bit higher.
Yeah. No, I was just going to announce the next speaker. Should I call Nanda Madam? Prashant sir. So after listening to this wonderful innovative talk, I would now like to call Prashant Bavankule sir for his talk on iris repair. Welcome, sir.
Audio, sir. Huh? Audio है? हाँ नहीं, no audio.
I invite Dr. Namrata Sharma ji. Please come on the dais.
क्यों?
Please.
नहीं आ रहा? दूसरे इसमें लगाओ. HDMI? नहीं क्या HDMI? अरे चल रही चेंज कर नहीं you all know
for the same post is my near and near friend, and we all know is very much capable of for this post and very much suitable for this post. So I will also request for the Dr. Prashant Bavankule to vote in favor of him, as well as Dr. Arvind Moria is also my near and dear friend. Thank you.
हाँ नेक्स्ट ले लो नहीं आ रहा है देखो देखो नेक्स्ट ले लो
Doctor, ma'am, are you ready? Acha, please. Aji, ma'am. Thank you, ma'am. Dr. Namrata Sharma is a very well-known figure in our Ophthalmic Society, but right now is elected as a treasurer of APAO. I congratulate Dr. Namrata ma'am.
Thank you so much.
And she's also contesting for the post of Chairman Sanitary Committee. I request our delegates to vote for her. Dr. Namrata ma'am.
फुल स्क्रीन करना करते हैं Okay. So thank you, and I would like to thank the organizers, particularly Dr. Divyang Brahmbhatt, Dr. Jagdish Rana, Dr. Sandeep Arora for having me here. Always a pleasure to be here at Gujarat and particularly at Ahmedabad. And I would be talking to you about intraoperative OCT guided phacoemulsification surgeries. So when you make this typo to actually know what level you are making it, if you are making a uniplanar or a multiplanar decision, you know the letter which is made. When you do the capsular exercise, you focus on the anterior capsule, and this is especially helpful if in those cases where and you lose the edge of the rays. And then when you do hydrodetection, one can see a clear wave of fluid which is there between the cortex and the posterior capsule so that it separates. And again, it is going to be useful in posterior polar cataracts. And then as you make a crater, you notice that you can see the depth of the crater and also the amount of the plate which is left underneath. And as this nuclear is done, subsequently see how the whole posterior capsule moves up actually, and there is a bulge, so you can put viscoelastic so that the PC actually becomes a concavity, and then the foldable intraocular lens is implanted, followed by the hydration. Now, important thing is when the posterior capsule and the lens, there will be a space, but once you aspirate the viscoelastic, the space would decrease. And again, this would have a use on a lens to calculate bars. Hydration which can be seen here, or lip is open or closed, and again this helps you to see the wound properly and completely. Essentially, if there are any wound side detachments which can be seen here, can be seen because of the hydration, one can address them right on the table itself by putting in an air bubble. Now, the posterior subcapsular cataract PC is quite intact, and there is no problem with this, but this is a posterior polar cataract, and once the posterior polar cataract is there, then you have to see whether the PC is intact or not, and here there is some amount of distance which is present. Then subsequently, when you look at the white cataracts, if you see these black fluid or black spaces, which means that when you give a nick in the anterior capsule, the fluid is not going to come out because the pressure is not that much, and so one can complete the case. But in case where you don't see those black spaces, such as this, which is completely shell-shocked, there are no fluid clefts at all. As soon as you give a nick, the blob of the fluid would be there, as can be seen here. So one can plan the surgeries accordingly. Now, this is again a posterior subcapsular cataract, just to show the fluid of hydration, how it separates the PC from the overlying cortex, and this gap can be seen. And this is a posterior polar cataract to show the distance and the posterior tear which is present here, and subsequently the defect which is also present here. So one can plan the surgery on the table itself. We did publish our study on the gap between the PC and the IOL with the various type of IOLs. Then there's what is I called as a butterfly antenna sign, and this is again published. So if you have an anterior capsular tear which is there because of the injuries, notice how, like a butterfly antenna, the anterior capsule is going to scroll up. And this especially happens with the pre-existing one, and this is what we published in JCRS. And then when you have a posterior capsular tear, you have what is called as the posterior scroll sign, and especially in those cases where you can't make out whether posterior capsular tear has occurred or not. If you look at the scroll sign, you know that the PC is deficient. So this is the scroll which can be seen here on the intraop OCT microscope itself. So the surgeon essentially sees this, but this part comes only in a small inset like this, so you don't get disturbed by it. And look at the scroll and the deficient PC that is there, because there is no PC here, and the PC is only here, which is scrolled down, which is characteristic of the posterior capsule, and this has been described as the scroll sign. Now, I think very useful for desmetopexy with air. For instance, you have a desmet membrane detachment. You've injected the air bubble and you think you're done, but you're actually not done, because there is a gap which is present between the PC and the overlying stromal layers, and as this gets clearer on the table, the desmet membrane will get attached. So the message is that you have to put the air bubble, hold on to it for about 5 to 8 minutes, just like we do for DSEC and DMEC, and then wait for the clearing right on the table itself to see that it is attached. And when you come out, then it is important that you place the 2 swab sticks or a blob of viscoelastic so that the air or the gas doesn't come out with you. So this is the endpoint of the same. Now, this was a case which was referred to us for endothelial keratoplasty, and we injected the gas, and we found that the cornea became clear. So we deferred a corneal transplantation procedure. Again, a complicated case, post-DALC desmet membrane detachment. We put air, but again, it's not got attached because there's a gap which is present here. So we have to give venting incisions from the anterior side, and once you give venting incisions from the anterior side, the air escapes or the fluid escapes from here, and then you inject the air bubble. Now it is pretty much attached. So on the table itself, it helps you to make the decisions which you would otherwise have to take the patient to go out and then do it. And of course, these are more complex cases, post-PK graft, DSEC graft, which has been there. And then as you do the surgery, you realize that the graft is actually not moving, which is good because it should not move. But as the intraocular lens is injected, the graft has moved a little bit and there is a gap between the DSEC lenticule and between the overlying cornea. So you can immediately address it because it was referred. The whole disc of the desmet membrane of the patient came out. The surgeon pushed the desmet membrane in and hydrated the wounds and sent it back to us. Biceps scroll is upward. Survey of ophthalmology on IOCT guided anterior segment surgery. So to conclude, it helps to refine the steps in phacoemulsification surgery, but it helps to understand the intramix better. And I'm sure the indigenous companies who are now coming up, we had, and center, in fact, the Asia we had, and center, in fact, the Asia's best center with 13,500 delegates, with 5,500 plus international faculty, with 1,300 international delegates and 900 plus education hours. So it had almost everything, the posters, and I think the highlight, the crowning glory was the wet labs. And we were called Asia Pacific Academy of Ophthalmology just last week to hold the wet labs there because they'd never seen the wet labs like that. And of course, our fun sessions. And incredible comments that we got, that it was just outstanding and it was just magical that we had at the Asia Pacific Academy of Ophthalmology. So I think Indian ophthalmology has arrived. We have the best of techniques, the best of technology, the most severe pathologies, the maximum number of patients. And I think it is time that the Asia Pacific, Europe, Americas, they look down to India rather than we looking up to them. So thank you very much for your kind attention. And I would like to invite all of you to Jaipur conference, and I would also seek humbly for support for Chairman Scientific Committee elections. These are some of the books by my junior colleague, Dr. Praful Maharana, for the postgraduates. Thank you again for having me. A word about the sponsors, because this is a sponsored session. So we did a study which was funded by CIPLA, moxifloxacin versus no moxifloxacin intracamerally in cases of phacoemulsification cases to prevent endophthalmitis. And we found that cases where we used moxifloxacin, the endophthalmitis rate was 2.5 times less. Also, this was a multicentric study which involved 60,000 subjects. And this is the first ever study, never reported so many cases, which won the best paper of the session award in ASCRS 2025 and was also published as a randomized control trial in JCRS. So thank you again. Thank you.
Thank you very much, madam.
Yeah,
it was a very nice presentation.
Madam, welcome to Ahmedabad, world's first heritage city. Jai Jai Garvi, Gujarat. Madam, you really refurbished the memory of Asia Pacific Conference. You know, it was like neighbors' envy and owners' pride. I did attend, and people out here should really appreciate, and those missed, they just missed it, you know.
Thank you so much.
It was just appreciated by international faculties. They could not believe they were in India, and they should know what is India now.
Thank you. I know we shouldn't have sadistic pleasure, but still, I would mention this, that in India we had 13,500 delegates, whereas in American Academy of Ophthalmology we had this year 5,500 delegates. So you should not, you can only feel better at your own.
Madam, it was seeing is believing. Just
Thank you.
Those who didn't remain there, they just missed it.
Thank you so much.
And one more thing, your presentation reminded us of Star Wars and Star Trek. And it was really, I was sitting and wondering what's all going on. But lastly, you did mention that indigenous companies are coming with microscope instilled with OCT. So thank you for that, madam.
Thank you so much.
Thank you very much, madam. Gujarat is always with you. So I will request all of you, all of AGS members, to vote in favor of Dr. Namrata ma'am for Chairman Scientific Committee. So big round of applause for the madam. Thank you, madam. So I will request Dr. Prashant Bavankole sir for this topic on iris repair.
Oh, thank you, AGOS and Jagdish Bhai and everyone in the team for this kind invite. Well, friends, after such a, as Sir said, Star Trek movie, now it is going back to the very basic tissue, that is iris, which is usually a neglected tissue. Well, when do we repair an iris? Basically, whenever you have a loss of iris tissue, it causes a glare, visual disturbances, photophobia, and importantly, loss of cosmesis. And this is one of the prime indications of iris pupillary repair. Nowadays, newer indications are about managing a corneal astigmatism or malignant glaucomas, and in floppy iris to get the pupillary diaphragm back to its place. So let's see through this video bouquet the importance and how we manage these cases. If you have these cases, this is just not a demonstration of the skill, but just to incite everyone to do practice these cases. Well, this is a case, young boy who was presented to us with 180 degrees iris root disinsertion with a traumatic cataract. We wanted to do not just traumatic cataract referred to us, we wanted to also create an iris pupillary diaphragm for this 10 years old guy. So the surgery begins before by preserving the iris tissue which is dangling over there, otherwise it will come active ports of phacoemulsification and all. So first is I'm using an iris hook to get it away. Now after completing the phaco, here I decided to anchor the iris tissue at 9 o'clock meridian. So I create a scleral tunnel, and through that goes a tenoprolene suture, comes out through the side port opposite, again goes back, and it is looped and anchored back to at 9 o'clock. But the pupil was big, and therefore we decided to do a 4-throw knot pupilloplasty. So this is a combination of technique. Not pupilloplasty. Taken outside, and once the two ends are pulled, you can see the approximation, and this is the end result of this particular patient. So not only he had a traumatic IOL inserted, but he also had a good iris pupillary diaphragm reconstructed for his eye. Case 2, this is another extreme case where you have a subluxated, dislocated cataract with a vitreous hemorrhage with a detachment. So whenever we are doing vitreous surgery, we use tamponade, either in the form of an oil or a gas. So whenever we use oil or a gas, if there is no iris pupillary diaphragm, it leads to antiomigration, thereby leading to corneal decompensation and secondary glaucoma. And this is to construct an iris pupillary diaphragm. This video begins only after I have completed the posterior segment procedure. Here, with the help of an ILM peeling forceps, I am assessing how much is the iris. Well, it was luckily 270 degrees of iris insertion in this case. So my job was relatively easy. I needed to anchor at 3-4 hours, and precisely that is what we did in this particular case. This is about 7 days later, and this is about a month later. Later on, along with silicone oil removal, patient underwent a scleral fixation of IOL. So we could construct an iris pupillary diaphragm in this particular case as seen. Well, this is next step to iris repairs. Well, you can see a corneal scar, iris tissue bundled up over here. So after having done a cataract surgery, I am trying to assess how much is the iris tissue. I realize it is only up to 7 o'clock meridian, and there was an iris tissue loss of 4 clock hours, that is from 7 to 11. So my first job was to anchor so to create a, you can see this, the hammock like tissue is over here, and I have approximated available tissue. And now I do again an iris root anchoring with the hammock tissue, and you can see this is the end result of this. So in spite of loss of 4 clock hours of iris tissue, we could construct an iris pupillary diaphragm which was reacting in nature. This is about a month later. Now this is a badly macerated type of an iris tissue where you could hardly see iris over here, and in this particular case you can see previously before surgery only you have to iris. So after doing cataract surgery, I'm trying to put a lens, scleral fixation of IOL was done, and then after that the iris pupillary diaphragm was constructed. First was my job, which was a iris which was retroflexed, had to be everted out with the help of an ILM peeling forceps. Again there was 4 clock hours of iris tissue loss. I will just come to the end of it. This iris pupillary diaphragm which we could construct in spite of absence of 4 clock hours. Now coming to newer indications. Well, you have a corneal astigmatism in this particular case because of a corneal scar needing a cylinder of almost 7 diopter. Well, this was a case of a scleral fixation where a toric lens is not possible. And so how do I proceed? So you can see such a large corneal. So my job is to get the pupil into the size of a pinhole. So once you go back to optics, pinhole reduces or bypasses any amount of astigmatism or a refractive error. So after having done a cataract surgery, I will just come to how we constructed a pupil diaphragm, and multiple 4-throw knot pupilloplasties was done to reduce the size of the pupil, and this is what is being done over here. And once we do it, further reduction in the size of the pupil, but look at the Purkinje images. Purkinje images were not centered. So after that, with help of a vitreous cutter, I chewed up the iris in an effort to centralize. So this is a vitreous cutter being used to chew off the iris to centralize the pupil, those Purkinje images in the center, and this was the end result. But I could not achieve a proper reduction, so I decided to do about a month later a 4-throw knot pupilloplasty, and this is further which is being done with a 4-throw knot pupilloplasty, multiple small sutures, and with the cutter now I am further chewing off the available iris tissue and centering the Purkinje images. So once that is done, now the size of the pupil has to be brought down to 1 or 2 millimeter, and you can look, this is the end result. You could see that the pupil was brought down to 2 millimeter, and the effect of corneal astigmatism could be averted by using this pinhole technique. Another case where you had needed an 8 diopter cylinder. This eye was operated elsewhere. He had a sector iridectomy, traumatic a bad corneal scar, and there were 2 hours of loss of iris tissue because it was during primary. And so after we do a combination. I do a 4-throw knot pupilloplasty. Once 4-throw knot pupilloplasty is done, now I'm going to add the whole hammock so every 1 clock. You can see this result and the effect of this particular rate. Now this is another case which had undergone pseudophakic and with malignant glaucoma patient presented to us. We needed to do vitrectomy IOL explant. We did an SFIOL with a peripheral iridectomy. but the AC was collapsing every now and then, and AC deformation was done twice. Multiple PIs were done, but this was the end result. So we decided to do what we thought was the whole was retracting into the angle. So pull the vector of the forces into the center by doing a 4-throw knot pupilloplasty. I think we opened the iris which was crowding in the angle. This is what precisely we did with the help of a 4-throw knot pupilloplasty. And the pressures which were high in spite of a maximum 40 millimeter of mercury could be managed without, he was off anti-glaucoma, and we could avert a malignant glaucoma which was so resistant. This is another silicon cynical closure glaucoma. This was a girl who had a aphakia, state exposed lens vitrectomy detachment, myopia, with anti-temper was closed. And this is where what we did. We could hardly see any iris origin because the whole iris tissue was retroflexed. So after removing the oil, with a 4-throw knot pupilloplasty, this is the end result of this particular study. And the last is a case of iris where absolutely fine, and then the iris started, and you can realize that from this video, once the iris starts being no one can control it comes. So you can see here at the end, you can see the whole iris was all, badly mutilated. So how do I prevent that to come to the section or prevent create a PAS? So I did a 4-throw knot pupilloplasty, and this was the end result. So friends, what we learn is iris repairs can be done whenever you have an iris tissue loss. You have to compartmentalize, especially when you are combining it with a vitreoretinal surgery. You create a tissue for iris-supported IOL for future. Importantly, the beauty of the eyes lies in the iris pupillary diaphragm. So creating whatever best definitely gives a more confidence to that patient. And thereby, because of creation of pupillary diaphragm, you have less glare, less visual disturbances, less photophobia. And as I said, newer indications are corneal astigmatism, glaucomas, that is silicone oil induced cenacle closure, or malignant glaucomas. Thank you once more. Thank you, AGOS, once more for this wonderful opportunity. And I also humbly request you for support for my candidature for Chairman ARC for the forthcoming elections of AIOS, please. Thank you.
Thank you very much, sir. It was a very nice presentation, and congratulations in advance for the Chairman ARC.
No, thank you, sir. Wish me the best.
Society.
Wish me the best. I need blessings from all of you.
Oh, it is always there for you.
Thank you.
From Gujarat, sir. Yes,
thank you, sir.
I would like to invite Dr. Satyen Sinha, planning cataract surgery in uncontrolled diabetes.
अमिताभ बच्चन सर कह रहे हैं कुछ दिन आके गुजरात में तो गुजारो, लेकिन ब्रह्म भट्ट सर का, जगदीश राणा सर का हॉस्पिटैलिटी देख के मुझे लग रहा है कुछ दिन और गुजार लूं गुजरात में तो अच्छा रहेगा। और मेरा थैंक यू तब तक नहीं कंप्लीट होगा जब तक मैं भाविक, संदीप, मिहिर और खास करके पार्थ राणा को थैंक यू ना बोलूं। पिछले 2 दिनों से इन्होंने पूरे नेशनल फैकल्टी का इतना ख्याल रखा है, उसके लिए बहुत बहुत धन्यवाद सर, बहुत बहुत धन्यवाद। Respected Chair, in August gathering today, I'll be talking about cataract surgery in uncontrolled diabetes. And there are so many questions which are unanswered, and especially video chalega? And especially after the COVID which has happened, there's so many things which are unanswered, and we have the incidence of uncontrolled diabetes has risen dramatically. You may be hearing so many of people having sudden heart attacks, diabetes, blood pressure after COVID. And so many questions which remain unanswered. One of them is in uncontrolled diabetes, which is over many years, is the posterior capsule becoming thinner or something, or more fragile in the uncontrolled diabetes and more prone to PC tears. So you will see that once we have cleared the cortex in this case, there is a little remnant cortex which is remaining in the center, and I'm itching to go and clean up the remaining cortex to brush it off. And once I do that, just a little speck of that cortex, and see, I create a PC tear. So you have to be careful in these patients. Now from below, if you see the fourth last, you will see Gujarat. And in Gujarat, because this is an economically progressive state, you will have a higher incidence of diabetes, mostly uncontrolled diabetes, as compared to my state where I come from, Bihar. So post-COVID, as I said, of diabetes mellitus has risen dramatically. Diabetes, the diabetic having a high medicines, and still it's not getting controlled. Now, ophthalmology, diabetic patients who undergo cataract and LASIK are at increased risk of endothelial cell loss. While we are doing our cataract surgeries every day, day in and day out, everybody has a busy OPD and seeing so many patients. But there are several key points that in these uncontrolled diabetes, we have to keep these small things in mind, where we also need to remember about the endothelial cell loss. Several studies on the corneal endothelial cells in diabetic patients reported a decrease in cell density with polymegasism and pleomorphism. And if you do specular microscopy in these patients, you will see these shapes and sizes. Although one of the major complications of diabetic eye is diabetic retinopathy, where we are more focusing that you must get your retina checked, it's also very important to see the cornea also very carefully in these patients with uncontrolled diabetes. The findings of the anterior segment in the eyes with diabetic keratopathy are more difficult to visualize, and especially what I'm trying to say is that if you are not taking care of the cornea, especially over a period of time, it will become very difficult for the vitreoretinal surgeons also to do lasers and all. If the cornea clarity is not there, they'll be not able to manage the posterior segment complications of diabetic retinopathy properly. So one of the important things is endothelial cell loss, while other things are also happening, whereas the iris pigment epithelial fragility is there, there is increased vascular leakage, inflammation is there, fibrin deposition is there, and there is increased vulnerability to the operating microscope light injury. These are small things which we not nowadays. Diabetic neurotrophic keratopathy is a component of diabetic polyneuropathy, because diabetes is affecting the whole body, and especially diabetic neurotrophic keratopathy is affecting cornea, so that they are more prone to early segment include endothelial changes such as descending membrane folds and pigment deposits in the endothelium. The endothelial dysfunction may place the cornea at greater risk of developing endothelial decompensation and eventually, after many years, bull keratopathy also. So this diagram in our focus. Patient with epithelial basement membrane impairment, epithelial stromal interaction is there, epithelial function compromised, and itself are also compromised. The corneal disorders associated with keratopathy are characterized logically by subepithelial deposits, thickening of the subepithelial basement membrane, and altered morphological appearances of the corneal epithelium and endothelium. And why I'm telling you this is what are the measures of surgery, because diabetic affects all components of the cornea also and the tear film also. It's necessary to carefully examine the functional disorders in diabetic patients suspected for diabetic keratopathy, including disorders for permeability of the corneal surface. On the day of the surgery, it is very important that you do a random blood sugar. And most importantly, that HbA1c has to be very well controlled. That is very important. But even though if HbA1c is controlled, still do a random blood sugar on the day of the surgery. And while All India Ophthalmic Society recommends that you should not do over 200 milligram per deciliter of sugar, and it may hold you in the court of law if you're if some, God forbid, if endophthalmitis happens or something, then you'll be in a soup. But there are also reports in the American Academy of Ophthalmology that below 300, if you're doing a clear corneal phacoemulsification, you can still do it without much risk. Even on the day you are doing biometry, do a random blood sugar to make sure that the sugar is not above 250, 300, because you may have altered biometric readings if the sugar reading is 450 or 500. In these patients, especially uncontrolled diabetes, who have shown no signs of diabetic retinopathy until now, please get an Octa done if it's available to you, because there may be subtle changes in the choroid which may be seen much before diabetic retinopathy appears. And in these patients, you must recommend not to go in for a multifocal or trifocal IOL, and you should recommend simple conventional monofocal IOL for them, because over the years they may develop something in the macula due to diabetes and something in the retina which may then alter their vision, and it may be too late to do IOL exchange, and it may complicate things. So avoid premium IOLs in these patients. And especially when you're operating on these patients, do use a high molecular weight
diabetic patient, retinopathy patients. You have that study with you?
No,
why not indicate it?
No, sir. Can you highlight, sir? एक माइक दीजिए ना उनको सर.
It induces non-atretic ischemic neuropathy.
But they don't claim it, madam. They just tell we don't advise in diabetic retinopathy cases.
Yes, sir.
Companies don't admit and claim. They just say we don't advise in diabetic retinopathy cases. And it's in market booming like anything. You all know.
Yes, sir. Yes, sir.
Thank you, Dr. Satyajit Sinha, sir. It was a very nice presentation. I think we will have a question later on because we are running short of time. So I'd like to request Dr. Gopal Arora what to expect from an EDOF, my experience with ICRIL cert.
A very good morning to one and all. Respect to the chair. Special thanks to all members of AGOs and especially Dr. Jagdish, Dr. Rambhat, Dr. Jethani, Dr. Sandeep Arora, and Dr. Bhavin, and of course Parth and Mihir for the wonderful hospitality. I'm going to speak about this lens. I have absolutely no financial interest. Basically, what we look up for any IOL from the natural crystalline lens that we have is monofocal, which gives us a good distance vision. If we compare it with the bifocal, it gives us a distance and the near. With the trifocal, which gives us distance, intermediate, and the near. And if we compare it with the EDOF lens, it gives distance, intermediate, but actually there are low vision distortions, which is an added advantage to this EDOF lens. But what actually EDOF does is it creates a single elongated focal point rather than the several focal points and has a focus. That is the reason why EDOF is getting so much popular now. According to the ANSI definition, if it's more than or equal to 0.5 diopter at 0.2 logMAR, that is called an EDOF. It should be superior to a monofocal IOL, and it should be non-inferior for distance vision to a monofocal. It should serve the purpose of giving an intermediate vision as well. If you compare this monofocal with the multifocal, there's a long accommodation gap in a monofocal IOL, and if you compare it with the multifocal, the distance between the distance and the intermediate and between the intermediate and near, there is again an accommodation gap, which is being served by this EDOF lens, which is precisely called as the ICRIL cert. Because it has this unique zonal electric power distribution, it is not a ring wala lens, it has got a zone-based technology. And they are submitted for the patency also, likely in a month getting the patent also. This unique design of ICRIL cert, it has got 4 zones, and if I give you this picture, the first and the third zone provide power to provide for distance and the intermediate. The second and the fifth zone provide for the distance. So if I have to just show you the first and the third for the distance intermediate, the fourth and the fifth for the distance, and the fourth zone has actually a graded 60-degree interval for both the distance and the intermediate. So it's a totally different zone-based technology which is serving us the purpose of giving a good intermediate vision. the utilization of the energy is maximal, as close to the normal crystalline lens, and it even blocks the UV light. So it gives you the extended range of vision of 1.75 diopter, 0.2 logMAR or better, up to the distance of 57 centimeters, and it gives continuous range for distance and the intermediate vision. The added intermediate vision, it helps you without even compromising for the distant vision, which is an added advantage, because what you expect something more from a monofocal, apart from monofocal, is the good intermediate vision. Lens which has intermediate vision for up to even 57 centimeters and extended depth of focus, and even in a dim illumination it serves the purpose. This is just a comparative graph of the monofocal which achieves good vision for distance. Here it has a 2 graph which gives you good distance and a 57 centimeters intermediate vision. This chart again shows you the comparative of what you get in a monofocal versus a EDOF lens which is provided by the ICL cert. So what is basically a requirement in life? I mean, it's either you are driving, suddenly you have to look to the dashboard, it's when it's night driving, using computers, or watching television. So this is basically served by the ICL cert IOL. Just giving you the clinical data which I have for the past 5 weeks of this 49 eyes. I have selectively taken cases which had no history of glaucoma. The glaucoma, every element was ruled out. The OCT was done, diabetic retinopathy and other systemic diseases were being ruled out. And even the astigmatism to the extent of 0.5 diopter was taken into consideration. And to my surprise, I mean, for distance vision, the patient satisfaction was 95%. Within those 0.5 spherical, the diopter spherical acceptance, and rest of the patients had 0.5 to 1 diopter of acceptance. If I compare the spectacle independence, 100% patients were satisfied for far vision, which is as good as any monofocal lens, and almost 91% of the patients were satisfied for intermediate vision. Of course, there were 8% who were dissatisfied. So this is a predictable demand. I mean, it's only the addition of 1.5 diopter to 65% of the patients. Others, remaining 35% had to be given 1.75 to 2.75, but majority of the patients were happy with addition of 1.5 diopter. Just a video. I have intentionally chosen this femtocataract of a very hard cataract. Already done the incisions, just opening up the incision. The side ports have been opened by the spatula, and just taking out the already done rhexis and doing the hydrodissection, rotating the nucleus, and going ahead with the phaco procedure after you have slightly dialed the nucleus to free it from the epinucleus. As you can very much appreciate, it's a very, very hard cataract, and the phacoemulsification procedure being done, the nucleus have already been divided. I'm just separating the already divided nuclear piece, and the energy which is being used is only to eat up the nuclear pieces. As you can see, once the tip is engaging one piece, it is automatically detached from the adjacent nuclear piece because it's already been divided by the femto. And after you are done with eating up each nuclear pieces, though it's difficult, it's very hard, you have to be very cautious, use good viscoelastic intermittently, and after the nuclear pieces have been taken care of, you just take care of the epinucleus. And once this is done, intentionally I have chosen this case of implantation of this ICL cert, and as you can see, it is actually flipped. The lens was not loaded properly, so it's gone the other way around. And how comfortable, because of its softness, it can be rotated inside the eye very comfortably, and you can implant it in the bag. Just need to hydrate the wounds and the side port. So basically, ICL cert at a glance is extended depth of focus, continuous vision from distance to intermediate, very fast neural adaptation, minimal glare and halos, minimize pupil dependency, and satisfactory performances. I take this opportunity to seek your blessings and support and vote for Joint Secretary IOS. Thank you so much.
Thank you, Dr. Arora, sir. I'm inviting Dr. Vanathi for her talk on acryl phakic IOL based practice.
So I think you have to listen to me for another 8 minutes. I'll make it as short and brief as it can be. And this is a sponsored talk, but I have no financial interest in the mention of any of the products during the course of my talk here. So I'm going to talk to you over the next 8 minutes on phakic IOL, my experiences with the acryl phakic IOLs here. What are the pearls and tips when you are handling phakic IOL surgeries here? So lens-based refractive corrections for those patients who are not amenable to refractive surgery by laser procedures, by laser ablative procedures, the phakic IOL is one which comes into rescue for removal of glasses here. So let's start with a case history here. A 21-year-old female reported to us with defective vision with a best corrected visual acuity, best correction of minus 9.5 dioptric sphere in the right and minus 4.75 dioptric sphere in the left eye, which corrected her to 6/9 parts in the right and 6/9 in the left here. The rest were, and her fundus evaluation was also within normal limits except for myopic macular degeneration, very minimal here. And she had a stable refractive error documented over the last 1 year, and her refractions were again rechecked. And when we looked at her corneal topography on pentacam imaging here, you could see there is a significant amount of skewing which is seen on your sagittal curvature maps here. Though the corneal thickness seems okay, but of course the range of refractive error correction required for this person is not going to enable even the normal corneal thickness to afford a full correction here. And that's again what we see on the left eye topography as well of this patient here. The bad maps again are deranged both in the right and the left eye, and hence we did take the patient on for a phakic IOL surgery here. The first question is patient screening here. You look at the quantum of refractive error for these patients, you look at the health of the posterior segment of these patients here, and you look at the best procedure which you would offer for the best refractive results in when you're looking at refractive surgical correction for patients who need glasses removal here. So the next few minutes, I will talk to you about our experiences with the acrylic phakic IOL in comparison to what has been here for a longer period of time, the EvoVision ICL here, and in comparison to the ICL here, like the advantage here is that this helps you to afford or so you do have phakic aspherics and you do have phakic aspherics IOL and the toric ones here, which help you correct a wide range of refractive errors, both spherical and toricity in the patients who need phakic IOL surgeries here. The range of overall diameter ranges from 0.5 steps from 12 to 13.5 here, and also gives you a range of optic sizes here from 4.6 to 5.5. As you know, the myopic pupillary sizes are going to be variable when you look at these patients here. But something which is more conducive when you're using these lenses is the way the cylinders are placed in these lenses here, and it helps you to afford and complete the surgery with minimal possible rotation vis-a-vis the ICL when you consider toric corrections on these patients. So again, they have a wide range of toric corrections available here, and this picture here shows you that the cylinders are placed according to the custom needs of the patient at 0, 30, 60, 90, 120 or 150, and this allows you to place the lenses with less than 15 degrees rotation when you need a toric implantation of these IOLs. That is the ease of implantation when you consider using acryl phakic torics vis-a-vis the other available phakic torics that you have. So we did look at our results of patients who underwent, it was a non-randomized trial, and underwent both phakic IOL surgeries with ICRL and with the ICL here. And we have follow-ups of these patients for close to 2 years right here, right now. We looked at their walls, we looked at their IOPs, we looked at their change in the anterior chamber angle and the other parameters here, and all which proved that this was a non-inferiority study, and ICRL fared just as well as ICL in terms of all components which we evaluated for this particular patient here. A few more advantages when you do adopt, looking at, we do have the online calculators here which really help you to decide and put in your data and look at what is going to be the best possible or the best suitable IOL power which you would choose for your patients here, just as you would do for IOL surgeries for cataract surgery, for cataract removal as well here. This is something like how your your calculation are going to look at. It also gives you the angle of implantation here, how much you need to rotate your IOLs here. And it tells you the residual refractive error, which is also the predicted residual refractive error, just as you would do for biometric calculations for cataract surgery here. It also helps you to check their online inventory and tell your patient how soon or how long they need to wait for getting their lenses. So this is another factor which does help you when you're practicing phakic IOLs with these lenses here. And I think one which I do find this I've already discussed in terms of the axis of the implantation. Mark the axis here, and it's just a simple horizontal implantation, 180 degrees, and most of the time you don't have to rotate more than 15 degrees, and the custom made depends upon the axis which the patient needs here. So that's a huge advantage. But what I do find, which is an added advantage here, their formulas do help us to give you a predicted vault for your patients here. So we did look at the predicted vault predictions when we placed our ICRL IOLs here, and this correlates well with your 1 month vaults here. And that really helps you to decide what size is going to be apt, especially when you're pliers, and that's when you're going to probably have surprises in these patients here. And another important pearl is also look at the iris configuration and the ACA of these patients when you're evaluating the ASOCTs, because these are important parameters which will tell you that the lenses are going to be safe in such eyes or not. So I'm just quickly run you through the loading. This is a special Medicel cartridge which is provided, and this really helps the ease of implantation. Just wet it with BSS here before you fill it with viscoelastic on the surface. The lens is removed from its holder here, and it's a very simple way you place it, but this is similar to how you place your ICL, except that you'll have to place it with the convexity lower here, so that when you are implanting it, it goes in with ease here. So that's how the loading cartridge for the ICRL lens phakic IOL is here. And I'll just close with another few minutes of surgery of implantation here. It's a topical surgery. The patient's access here and simple incisions. The particular is that you take care you're not going to injure the anterior capsule, so your movement should go in very carefully, and you place in and look at how the lens is unfolding. If it's in the right direction, the leading haptic and the following haptics to look at the orientation to see if you're in the right implantation. I think I'll stop here, and thank you again for your patient listening, and I will get into soliciting your support for the Journal of Ophthalmology. Thank you.
Thank you very much, Dr. Vanathi ma'am. Now, before we move on to the next session, endophthalmitis master class, I would like to announce again regarding the AIOC election. My friends, we have come a far long way from all around our nation. So before that, I would like to congratulate the members and respected friends who have been declared uncontested one, Dr. Santosh Honawar sir and Dr. Manoj Chandra Mathur, for getting declared uncontested. Also, Dr. Kudlu, who is not there, yesterday was there, for declared uncontested as a editor proceeding. Now I would like to request all of you to vote and canvass in favor of Dr. Nirmata Sarma for the Chairman Scientific Committee. I would like to request all of the members to come in front so they can see you. Dr. Vanati ma'am for editor, Dr. Parikshit for editor, if they are here. Dr. Prashant Bhavankhule for Chairman ARC. Dr. Mohita Sarma for the Joint Secretary. Dr. Gopal Arora for the Joint Secretary. Dr. Rajan Gupta for Joint Treasurer. Dr. Inder Mohan for Member ARC North Zone. Sir, आगे आ जाइए. Dr. Inder Mohan, yes. For the Member ARC North Zone. Dr. Sarad Lakhotia for Joint Treasurer. I think he was here only. Okay. Dr. Satyajit Sinha, from Bihar, for Member Scientific Committee. Dr. Arvind Moria for South Zone ARC member. Then Dr. Raman, Member Scientific Committee. Dr. Tinku Bali for North Zone ARC member. And Dr. Kirti Singh for ARC member, North Zone. And Dr. Stalini Mohan for Member Scientific Committee. So I will request all our AGS members to vote and canvass for all these national faculties who have attended and here and enrich our knowledge in ophthalmology. Thank you. Thank you. Thank you.
Now I would like to felicitate Dr. Namrata Sarma ma'am. Dr. Jagdish will felicitate her. Thank you so much ma'am for sparing your valuable time on in spite of your very busy schedule, traveling all the way from Hong Kong to here. Thank you so much ma'am. Dr. Santosh Sonavar sir will be felicitated by Dr. Divyang Brahmbhatt sir. Thank you so much sir for coming all the way to AGS Summit 2026. Dr. Prashant Bhavankhule sir will be felicitated by Dr. Jitendra Jethani sir. Thank you so much sir. And Dr. Panati ma'am will be felicitated by Dr. Sandeep Arora sir. Thank you so much ma'am for coming all the way from here. I will ask all the speakers of this session, please come forward for the group photo.
One question, Prasanji.
And thank you.
Glaucoma specialists and retina specialists are worried.
Thank you, Gujarat Society, for having the AIOS session here. Thank you.
Prasanji, udhar hi Glaucoma specialist and retina specialist are worried that neuroindication, how they are helping. कि सिलिकॉन ऑयल निकालने के बावजूद भी आपकी ट्रीटमेंट हेल्प कर रही है और मैलिग्नेंट ग्लोकोमा में भी हेल्प कर रही है.
So the publications from Dr. Amar Agrawal, there is a publication which he has spoken about, and these are all the latest things which are coming now, following Dr. Amar Agrawal, who is a very strong proponent of all these procedures.
I would like to invite the next session speakers and chairpersons, Dr. Bakules Kamar sir, Dr. Mehul Shah sir, Dr. Kushal Dediwala, Dr. Alpesh Rajput, Dr. Mudit Bansal, and Dr. Chirag Shah.
Very good morning to all. Dr. Bakulesh Kamar sir is unavailable. I would request Dr. Ale Banker sir also to join us on the podium. Dr. Mehul Shah sir, please join the podium. Dr. Alpesh Rajput, please join us on the podium. I'm requesting all the speakers to kindly conclude their presentations in the allocated time to ensure the smooth conduct of the session. Also requesting Dr. Chirag Gohil, Dr. Akash Patel, and Dr. Deepak to come in the front seats as a part of the panelists. So I'd like to start and invite our first speaker, Dr. Urmil Shah. He will be talking on post-operative endophthalmitis, early diagnosis. Over to you, Dr. Urmil.
Good morning to all. So changing gears from anterior segment to posterior segment, thanking the scientific committee chair for the talk. So we'll be talking on one of the major nightmares for any ophthalmologist and how to catch it early. So why are we being so cautious? Why there is an entire talk dedicated just to catching end of early? Because it is preventable and the vision can be salvaged if caught early. So any infection goes through three phases. There's an incubation phase, there's an acceleration phase, and there's a destructive phase. Our aim is to catch the infection in the incubation phase.
Requesting everyone to be silent for the session has already started. We can have get together outside the halls. Requesting all to be silent. Thank you.
Yeah, so the most common organism, staph epidermidis, has an incubation phase like 3 days, so we have time to catch the infection early. The most common confusion in everyone's mind is whether it's a TAS or an end-off when we are talking of the first 48 hours. So everyone knows that we look for the clinical signs along with the time period, that it's within 48 hours, it's TAS, it's more than 48 hours, it's end-off. There's more severe corneal edema, there's a lot of fibrin, there's raised IOP and less posterior segment inflammation in TAS. Also keep in mind, as a retina surgeon, I've kept these 2 points, that a lot of times I get cases where I have not been told there's a retained lens matter. So that also needs to be kept in mind when you're evaluating case for early end-off. Also take a history of past uveitis from the patient, as it could be just a recurrence of uveitis in the post-op period when you're diagnosing for early end-off. Now I would like to ask everyone to take 30 seconds and see the 2 slit lamp photographs. Both the photographs are sent to me on the phone by an anterior segment surgeon at 2 different points of time, 2 different places. So I get a lot of calls like this, Urmil bhai, is there an end-off, is there a TAS, what do you want to do? So it's quite difficult to differentiate which one is TAS, which one is end-off just based on the slit lamp. That drives home the second point, that we want a posterior segment B scan to guide our decision. So corresponding to the slit lamp images, the right hand side image has a very minimal posterior segment inflammation. The left hand side image has a lot of posterior segment involvement, so that's TAS and that's endophthalmitis. Luckily, the incidence of post-op endophthalmitis is quite less. It's not as common as we feel it is. It's for a cataract surgery 0.07 to just 0.12%. For an intravitreal injection, it's 0.05%. In fact, the maximum end-off is with filtration surgeries and drainage devices. So, when we are looking or thinking of post-op endophthalmitis, obviously, when we are catching it early, the main thing is who are we dealing with, the organism. So if it's fulminant, mostly gram-negative, then comes the staph and step. If it's chronic, it's P. acnes or fungal, just to keep in mind. So this was a very nice article which said that rapid intravitreal antibiotic administration is associated with final better visual acuity when receiving treatment within the first 2 hours of presentation. So this is a note that needs to be kept in mind, that if you have a suspicion of your post-op end-off, don't hesitate to give an intravitreal antibiotic at your place alone. Then you call the posterior segment surgeon and refer it to him. Patients with severe vision loss and presentation benefit the most with improved final visual acuity when given an intravitreal in the first 2 hours. These are the dictums that needs to be kept in mind. High level of suspicion, don't ignore post-op symptom, and all inflammations are infections unless proved otherwise. This does not need to be reiterated. The current regime is the recommendation of vancomycin for a gram-positive and a ceftazidime from a gram-negative, as we are giving an empirical first dose. My empirical first approach would be vancomycin with piperacillin tazobactam, because we have a lot of cases of ceftazidime resistance. So when you give a ceftazidime, you don't know what organism you're dealing with. Is it gram positive, gram negative? The culture takes 48 hours to come back. The sensitivity, you're losing precious time. So I give piperacillin tazobactam. This is just the list of drugs. Now, these are the uncommon ones, the imipenem, colistin. I have pretty much given all of them in resistant cases to other drugs. When we are thinking of early end-off, a lot of times we also need to keep in mind that it could be a late presentation. Just keep in mind fungal needs to be differentiated and steroids needs to be avoided in cases of suspected or confirmed fungal infections. Otherwise, steroids have to be given in a bacterial infection to reduce the endotoxin damage, inflammatory damage. I'll skip this video for the want of time. It is just that when we are giving multiple injections, the same 30 gauge needle should be kept in place to avoid repeated punctures. Now comes the main core thing where a retinal surgeon is needed, is the vitreous biopsy. Never ever ever take a tap with a 24 gauge needle. Never do that. It will just cause vitreous traction and a lot of other damages. As an anterior segment surgeon, take a AC tap, an anterior chamber tap, or just have a retinal surgeon take a vitreous biopsy. So when we take a vitreous biopsy, what is our aim? Our aim is to plate the organism. We want the organism to be plated as soon as possible, because a vitreous sample will have a culture positivity rate of around 88% if done right. Okay, so ideally you plate it in the OT. If not, store it at 4 degrees, send it to the lab, make sure it reaches in 30 minutes. The culture plates that I use are blood agar, chocolate agar, and Sabron dextrose agar. I do a lawn plating. Okay, now I'll skip this and just dictate here that what we are going through. This is the biopsy which is followed using the ECRS guidelines, that you have the 3 ports made. Don't turn on the infusion. You want an undilated biopsy. Have a syringe attached to the aspiration line, and as soon as you start cutting, have your assistant aspirate the syringe. So you get a undiluted vitreous sample. As you see here, I am now cutting and I'm asking my assistant to aspirate in a 5 cc syringe. So I get around 0.5 ml of biopsy, which are directly plated onto the plates. In few cases, I've had a pan-bacterial PCR done, which has given me a clue what am I dealing with. PCR along with the biopsy gives a yield of 92%. It cannot replace the conventional biopsies, but it can, yes, add on to it. So this is my last case, how to approach doubtful cases, and this is by the IGO, where they had a survey by the retinal surgeons, obtain a vitreous biopsy, inject empirical antibiotics, monitor the clinical course, and do an early vitrectomy. We'll be talking more on early vitrectomy by the later speakers. To conclude, better to be cautious than to be caught unaware. The incidence of any complication happening after an intravitreal injection of biopsy is minimal, 0.013%. And don't hesitate to consult your friendly neighborhood VR surgeon for cases where you are in doubt. Thank you.
Thank you, Dr. Urmil, for being on time. So I would like Dr. Ale Bankar sir to hand over the memento to Dr. Urmil for his talk. Meanwhile, I will invite Dr. Mehul Shah sir for his talk on Beyond the Culture Plate. So Dr. Mehul Shah sir is a very senior retina specialist at Drashti Netralaya Dahod, and we are fortunate to have him for his recent research which he is going to share with us today.
Thank you, Chair and AGOS, for allowing me to be here to share our experience of Drashti Netralaya treating post-operative endophthalmitis. So when next day we see this picture, I think whole medical staff is puzzled what to do and how it has happened. It is a doomed day. We take certain actions immediately: patient counseling, plan, document collection, sample collection, and plan of the management or referral. So I raised the query for collection of material in contrast to my previous speaker. There is a ray of hope. We are going back into 1995 by EVS, endophthalmitis vitrectomy study, which says about the management of endophthalmitis based on presenting visual acuity. And we have our experience. We published these articles to treat the post-operative as well as post-trauma endophthalmitis. So we done a study at our center that all post-operative endophthalmitis were treated without any microbial workup, and then later on being endorsed by the Ophthalmology Retina article, which is published in just 2025. And there are certain pros and cons which we are going to discuss. The endophthalmitis rate varies from 0.05 to 0.17%, which makes the large quantum in our country, as large number of surgeries are being performed at our country. This was the retrospective study, entry segment examination done using slit lamp, and specific documentation done about the incision side port, and this study was involving also SICS and PACO both. Posterior segment examination performed if fundus was visible, all vitreous opacities were graded, and if vitreous, if posterior segment was not visible, then USG was the guidelines. And this was the treatment protocol which were applied. Like if it is HM or more, the intravitreal injection immediately. If it is less than PL, then PL or less than PL, vitrectomy was the substituted. So medical treatment, as we know, as already has been discussed, intravitreal antibiotic, while like EVS, vancomycin and ceftazidime was given, systemic antibiotic was not given. Topical corticosteroid and systemic corticosteroid query. We all know how to prepare. So these are the end result of pre and post injection of few cases. So we see that if early instituted, the post-operative outcomes are better. Out of medical management, we have done in 51 cases, and this was the result. More than 33% cases regained 660 within 1 month. We are not going into surgical management. It is going to be discussed by next speaker. So management of comorbidities also was done: wound management, side port management, IOL management. These are the controversies which we We are dealing with implant removal is mandatory, microbial workup is to be done, systemic antibiotic is to be given, repeat and intravitreal vein is to be given, topical or systemic corticosteroid, monitoring with the clinical findings, and USG was important tool to monitor. Patients undergoing surgery by pars plana using 2320 gauge vitrectomy with wide angle viewing system, data collection done. This is overall picture of our endophthalmitis picture. These are the, out of 299, we had a 147 was the traumatic post-trauma endophthalmitis and 137 was the post-operative endophthalmitis. These are the demographic details and these are the clinical findings. Main wound infiltration and side port infiltration was prominent and membrane over IOL was prominent finding in all these cases. These are the endophthalmitis amongst the different type of surgery, SICS, phacoemulsification, cataract and vitrectomy, trabeculectomies with post-vitrectomy, penetrating keratoplasty and anti-VEGF injection. These are the, when we did the pre and post visual acuity comparative study, we found a significant difference and these are the heat map chart of the same. And when we did the comparative study, pre and post treatment was highly significant. There is no significant difference when SICS versus phaco, cataract versus other surgery or capsular complication or without capsular complication. When patient we treated patient with medical and surgical treatment, there was no difference we found. So most important finding where the significant difference was found, the corneal, central corneal infiltrates and ring infiltrates causing significant difference where visual outcome was not improved. So phaco versus SICS also did not have any significant difference. So conclusions are that when we have followed the guidelines of EVS, we could achieve, we have done vitrectomy in 62% cases and patient regained 660 in more than 32% cases. There is no significant difference in medical and surgical treatment in SICS and phaco. But coming to this era, this was started in 1995 and this is in 2025. Ophthalmology Retina has published this article, RCT, where the microbial workup was done and not done. There is no significant difference in visual outcome when microbial workup done or not done. But in contrast, out of 252, 20 patients developed the retinal detachment following one year of management of endophthalmitis. So that microbial workup delays the treatment and it causes more retinal detachment. So RCT has shown there is no significant difference in visual outcome and more incidence of retinal detachment. So there is a question, early intervention is important or microbial workup? We have to think about this. Thank you.
Thank you, sir, for a wonderful talk. So I would like to invite Dr. Mudit Bansal to felicitate Mehul Shah, sir. Meanwhile, I would invite Dr. Raleigh Banker, sir, for his talk in surgical management of endophthalmitis. Due to shortage of time, we would like to keep the discussion at the end of the session if time permits.
Sorry, coming in between. I had already declared our national faculties who are contesting in the AIOS election 2026. So few members were not present at that time. So I would like to request, come in front, Dr. Sarad Lakhotia, who is contesting for the joint treasurer post. Dr. Tinku Bali, please come in front. She is contesting for the post of member ARC North Zone. And Dr. Arvind Moria for member ARC South Zone. So being a round of applause for all these national faculties. Thank you. Thank you very much.
Morning, everybody. I would like to thank the AGOS for inviting me to give this talk on surgical management
of endophthalmitis, and I'll straight away show a few videos. This was the case that presented to us. It was one of the first case in a series of 9 cases which we operated as part of the cluster endophthalmitis. And I'm showing this deliberately because you can see there's hardly thing that is visible, but no case of endophthalmitis is a lost eye. And then we just cleared the anterior chamber and see a very faint glow, but even in that glow, we do a relatively good core vitrectomy and given the antibiotic injections. 10 days later, the patient had in hypopion, which was clear. Now you can see that the view much better than the surgery, and we were able to do also vitrectomy followed by oil. And later on, the oil removal surgery along with the epithelial membrane surgery was performed 6 months down the line. So you can see that even in worst of the scenarios in endophthalmitis cases, if you have pains and if you do a good vitrectomy, you can achieve a very good outcome. And these are the serial photographs of the same patient, and you can see how it started and how it has ended. And you can achieve a good visual acuity. What has changed now is in severe we have changed strategy to complete surgery, and by meaning complete is we induce the posterior hyaloidal dissection, and you can see here I'm inducing the posterior hyaloidal dissection from the optic disc, and this actually allows us to do a complete vitrectomy and a base this gives us acuity, and most importantly, it also reduces the chances of formation of post-operative epiretinal membrane formation. Coming to another kind of, as Zurvil was mentioning, there is a very high incidence of bleb-associated endophthalmitis, and you can see most of these are associated with severe reaction in the anterior chamber. So you begin with clearing of the anterior chamber fibrin, and then you switch on to your posterior segment. And here also you have to be extremely careful not to be very aggressive. Most of these bleb and they are very prominent, and they might have a lot of necrotic retina. So while doing your excision, you have to be careful. Don't be over aggressive in doing section, because you might end up in creating an iatrogenic giant retinal tear. The most important thing is, while removing these superficial exudates on the surface of the retina, you don't have to be very, very aggressive. Just try and see if it comes out easily with the suction, or you can use a proportional reflex mode to kind of blow away the superficial exudates. If they are stuck to the retina and leave them behind, it's not necessary to remove all these superficial retinal exudates. Again, this is another case, a very, very severe case of bleb-associated endophthalmitis. But if done meticulously, almost all these cases end up with excellent visual acuity. And most importantly, these cases have to be operated primarily. Don't wait for giving intravitreal injections and then operate. As soon as the patient presents to you, particularly the bleb-associated endophthalmitis, they have to be operated upon early, and aggressive vitrectomy is done. So you can see here, I'm just trying gently to remove the exudates, but they're not coming. So you don't touch them, leave it aside, and then we just close the case by doing a fluid gas exchange and giving the intravitreal antibiotic injections. And you might be surprised that even the next day, most of these exudates completely disappear. So this is a very good teaching tool. You don't have to go on doing the dissections. This is a case of post-Eylea endophthalmitis. Again, post-anti-VEGF endophthalmitis, they are slightly different than our routine post-surgery. These are highly, and after the clearing of the vitreous, usually find a dense membrane, which was seen in this case, and we end up removing the retinal removal of the membrane. The looks healthy, and if
usually they end up with excellent visuality, almost the same way you have the injection. This was a case of Pagenek endophthalmitis, a very severe case, and you can see how thick the vitreous was, and it's mainly white and not yellow as compared to your infective endophthalmitis, and as I said, it's very highly toxic. This patient actually had a very severe injection vasculitis, as we call HORV, post-Pagenek injection, and once we cleared all the vitreous debris, you see that the retina was highly necrotic. You can see these membrane-like structures were present on the surface of the retina. The entire fibrin or the exudates had transformed into a thick membrane, and you had to be very, very careful in removing the membrane by the fluid gas injection and the antibiotics. So to conclude, what's endophthalmitis? I would like to differ from our previous speaker, Dr. Mehul. I do not follow the EBRS. Particularly in India, we have a very high incidence of gram-negative endophthalmitis. So I do not wait for your less than hand movement or greater than hand movement criteria. I think doing a primary aggressive vitrectomy gives you excellent visual and anatomic outcomes. And as I mentioned, doing a complete vitrectomy, including inducing PVD in certain cases, is being performed early. Also, using primary silicone oil is very important if there is a severe necrotic retina, and repeat surgery should be done. Also, as Urmil said, we have a high incidence of gram-negative endophthalmitis, and amikacin is still a preferred drug than ceftazidime, unlike the Western world. And prompt vitrectomy, even in cluster endophthalmitis, can give you excellent results. Thank you very much.
Thank you, sir, for such a wonderful video-based teaching and sharing your thoughts.
Yeah, one question here. You said you retain the certain exudates which you did not remove, and you get a surprise next day.
Yes.
But you may not get a surprise the other way, right?
Usually not. If you've done a good vitrectomy, usually not.
But you are retaining the exudates. Those don't get reactivated.
No, you've given the intravitreal injection, so that takes care of the exudates.
Okay. Secondly, I don't know whether you are present or not, but Prashant Bhavlankarji presented that silicone oil leading to glaucoma can be treated with pupilloplasty.
Yes, but why is it concerning endophthalmitis?
No, I'm talking about silicone oil injection. It routinely leads to glaucoma.
No, not at all.
We do post patients on anti-glaucoma treatment.
No, it's not a routine. It can cause glaucoma, but not as a routine.
Okay, whenever it causes glaucoma, you remove the silicone oil. Then also it is not relieved. So Prashant Bhavlankar said that you do pupilloplasty, which relieves it. Is it so?
I have no personal experience.
We have Kitsi Singh madam here to glaucoma.
I have no experience in that.
I think we misunderstood Dr. Prashant. He was talking about iris repairs post-pupilless thing. But definitely silicone oil, if it's causing glaucoma, unless you remove the cause, you cannot treat the glaucoma, period. So you have to remove the silicone oil. What happens, sir, is even after silicone oil removal, you may still have bubbles forming which will emulsify and come in the anterior chamber and cause glaucoma. So the only way to remove glaucoma that time is post-silicone oil removal is to do a definitive surgery. Tube also can get blocked by the silicone oils, as can the trabeculectomy. This is where the silicone oil bubbles come from the trabeculectomy in the conjugal space. So the aim is to remove all the silicone oil and put back the tube surgery. To answer your question.
We'll have to conclude this discussion. We can take it on later. I would like to invite Mehul sir to felicitate Dr. Alay Banker sir.
Ek minute, Prashant Sahib nu, Sasank Sahib nu comment. Sasank Sahib.
Meanwhile, I would like to invite Dr. Deepak Bhojwani for his talk on controversies and recent updates in management of post-ophthalmitis.
Good morning, everyone. At the onset, I would like to thank the scientific committee for giving me an opportunity. I think we had a discussion on this, so I can with the controversies. So we know the gold standard in the management of endophthalmitis was given by the 1990s, but the modern technology is challenging its mandate. So briefly, I'll be talking about these common questions which arise in your mind while managing the endophthalmitis. The first and the most important one, the clinical question. Are we dealing with infection or are we dealing with inflammation only? Basically, is it a TAS case or is it an endophthalmitis case? I think the further speakers are going to tell you more about the TAS and how to distinguish from endophthalmitis. A word of wisdom, usually whenever you're in doubt, do a B scan and see the vitreous. If you see the classical double layer sign, the vitreous exudates, you know you are dealing with endophthalmitis and it's not a TAS. Coming to the second question, what are the intravitreal antibiotics which should we give? So some people are telling I use tazobactam, some people are telling me I do vancomycin. So before coming to that, we must all understand whatever you do, if you're doing any intervention, the primary principles of management of endophthalmitis should always be in your mind, which are control of infection, suppression, and preventing eyes from undergoing phthisis and evacuation sufficiently. So whatever concession which you do, even today, the standard vancomycin for positive, ceftazidime for gram-negative, and dexamethasones, all these combinations, they still primarily the common concern is these are still holding on good for the management of acute post-operative endophthalmitis. It's important to know that the addition of dexamethasone, it reduces the elimination time of vancomycin so that it stays in the vitreous for a longer period of time and it acts for a more period of time. So whenever you are choosing this antibiotic, sometimes we are forced because there is not availability of the standard drugs, Vanco, and so in such cases, or when you have a culture report which are resistant to a common scenarios like ceftazidime resistant cases, in such scenarios you can use alternative antibiotics like moxifloxacin, linezolid, imipenem, meropenem. However, a clinician's discretion is advised whenever you are giving any additional antibiotics. The biggest controversy, why are we using steroids? So we use steroids to suppress the inflammation. The inflammatory response is not only driven by the infective organism, it's also by the host immune response. So steroids are able to take care of inflammatory response, especially in bacterial endophthalmitis. Steroids do not have a role if you are dealing with the fungal endophthalmitis cases. Also, overall, the study told us core vitrectomy is essential. Now, 2013 guidelines are all the guidelines, they are to tell you should perform early and attempt to perform near total or total vitrectomy on the premise that vitrectomy will facilitate removal of all the infectious agents and the inflammatory mediators, which overall which will help you to improve the visual outcome and reduce the rate of these phthisis and evisceration cases. So why do we need this near and total vitrectomy? Because it will reduce not only the infective agent, but the host response. It will reduce the toxicity on the retina. It will give you better visual outcomes. Role of silicone oil injection, it is controversial. Overall, most of the people, they do not recommend injecting silicone oil, especially if your retina is attached. Silicone oil is recommended only if you are detached retina and you are dealing with very severe cases. But one must exercise caution. Silicone oil has overall no gross beneficial effect in managing acute post-operative endophthalmitis if your retina is attached. When to re-inject or re-perform surgery? Re-injection, if you are planning for intravitreal antibiotics, you should see the clinical response and re-inject after second day. If you are doing a vitrectomy, reassess the patient after 5 to 7 days and take a further call to do a further intervention. So situations, EVS told us there is no role of systemic antibiotics. However, when you are dealing with fungal endophthalmitis or endogenous endophthalmitis, there is definite role of systemic antibiotics or antifungal agents when you are dealing with them. Whenever you are performing any intervention, you must counsel the patient. That is why you should be aware of the prognostic factors. The most important one when you are dealing with endophthalmitis, you should be aware of the etiology, whether it's bacterial, fungal, the timing of onset of treatment, the intervention, the bad prognostic phases. If you delay your intervention after a week or the onset of endophthalmitis is beyond a week, it's a bad prognostic case. If the infection is with a virulent pathogens like pseudomonas is a bad case. Pre-existing retinal disease or a corneal disease is a bad case. High intraocular pressure suggesting the exudates are clogging the angles is a bad case. The core summary, whatever you do, whenever you are managing the post-endophthalmitis, it should be guided by your clinical signs and disease severity rather than waiting for microbiological cultural results. So now I'll shift my thing from overall controversies to the updates. Updates, the diagnostic updates. Traditionally, we used to do culture. our trend to non-culture based. So non-culture based, in the interest of time, I'll just highlight the PCR. PCR, as Dr. Umil told us, now it's coming up with more role. Next generation sequencing. The only problem is whenever you do these things, you will get a polymicrobial growth. You won't get a single specific organism. So you would need to use your clinical discretion when you're using these things. Other exciting thing which is happening in the field of endocrinology is biomarkers. Biomarkers like D-lactate, prolactin, they are associated with bacterial endophthalmitis. Other things are associated with fungal endophthalmitis. So in such cases, your biomarkers, they also have a role. Coming to a surgical upfront, whenever you're dealing with severe cases which involve cornea and you do not have a view, combined surgery with corneal graft, keratosis, or doing an endoscopic vitrectomy, these are upcoming things. They usually help to control the infection and they reduce the incidence of evisceration in these severe cases. So overall, I would like to end my talk by telling you EVS was just a guide. It's not a rule. Now things are changing. So whenever you are dealing with a case of endophthalmitis, consider early and total vitrectomy for aggressive treatment of NFL. PCR, we need to more focus on culture, independent diagnostic test to get these results more effective. You must always remember prevention is always better than cure. Providone iodine is always outweighs the post-operative drops whenever you are performing any cataract surgery or any other intraocular surgery. Thank you very much.
Thank you, Dr. Deepak, for this excellent talk. I would like to invite Dr. Mudit Bansal to present memento to Dr. Deepak. Just to add one more point, which the last slide of Dr. Deepak mentioned, that we can also use povidone iodine in the infusion also for the vitrectomy surgeries, and it has proven to be very significant in the final outcomes. So now I would like to invite Dr. Rekha Singhal for a talk on medico-legal aspects in managing post-operative endophthalmitis.
Good morning, everyone. I would like to thank AOC for providing me the platform to speak on managing the medico-legal aspects of endophthalmitis. So, medical negligence is doing something which is a prudent man will not do in a similar situation, or not to do something which a prudent man will do in a similar situation. So who is that prudent man? He is a person with a similar qualification like one of us who will be working in a government medical college or to a expert or a well-known tertiary care eye hospital who will be called in a court of law as an expert witness. So the standard of care as described by the previous speakers will be expected different according to the qualification, the area where the person is working. So if a person is working in a CHC, he won't be expected to give an intravitreal, and a simple ophthalmologist is not expected to do a vitrectomy. So a primary referral is more important here. Once you have taken care of the endophthalmitis, what you need to do is you need to take your own that day and call back all the patients for the follow-up, and specifically at the different time. Why? To prevent the chaos in the waiting area and to have a gossip there. Block your OT list till the source is confirmed, which is a different session altogether. Do have a very good communication with your OPD staff and the reception, who is going to call back the patients and will receive multiple calls. Tell them about all the RSVP factors of endophthalmitis, so they don't miss out the communication with the patients. Inform the higher authorities of your institute, retina surgeon, your management team, also the AIS cell regarding the endophthalmitis. Document all the pre and post surgery records. Your vision, IOP, past history, systemic history, your clinical records, the post-op documentation of the vision, the clinical findings, the USG findings, everything has to be documented very well. We as the doctors during residency used to write our OT notes of 1 page. Now we write FACO done, IOL done. That is the difference. That is the documentation what we do nowadays. There's a lot of importance of OT sterilization registers and the OT patient register, which should have the entries of the type of the fluids, the type of the injections which have been used with the batch number. The consent form which has to be taken has to be informed and should be signed actually before the procedure by the doctor, by the patient, and the two witnesses. The witness can be your own staff even, that is valid. The consent form should include all the uncommon dangerous complications and even the milder, smaller complications inside it. So this was a case between the doctor where the eye was not mentioned. It was treated for endophthalmitis. Patient got better, but patient in the court of law there was loss of some vision, and the doctor said in the court of law that the patient was hypertensive and alcoholic, and therefore he was not cooperative for the vision. And even this history was not mentioned anywhere in the documents. And for this lack of proper documentation, the compensation of 1 lakh was given. Then comes the time level. This is the patient of endophthalmitis. You have a concern, then you should be referring the patient of time. Like in the discussion between the contrast versus V surgery, the study was done in Trust Hospital. Still, the patient has complaint of a pain. The patient was managed there by giving antibiotics, painkillers, and topical antibiotics, and was referred to for 3 days. The vitrectomy was done there. The organism was isolated. The applicant had a good data on the OT ASAP status, and there was uncomplicated cases on the same day. But there was a delay in the referral of 3 days to the higher center, which has amounted to the negligence of 4 lakhs. So, if you get a notice, if you have to go to a ball dance, you will have a specific attire. So, if you get a legal notice, you need a medical legal expert rather than a routine lawyer for handling your case. And you should not be giving any reply to the police or any statement without having an advice from your lawyer. We should be knowing the CAM cases are not exempt from the Consumer Protection Act. Whenever there is a filing of a case, you need to understand you don't have to prove the negligence, the patient has to. Your documentation is the biggest safeguard regarding everything what happens there. In each case, the court will be calling an expert lawyer, what I called as a prudent man, who will be there from a medical college or from a tertiary hospital, who will be telling whether you have done the right thing or not, whether it is according to the standard textbooks or not. And do remember, the bad outcome of a surgery is not a surgeon's fault. Few things and don't panic, don't manipulate with documents. What you have done. Whatever you say, whatever you have documented will be truthful. But if you manipulate with the documents, the judge will know there is a tampering with the documents. Don't neglect the treatment while completing the legal formalities, especially the serious and emergency situations, and inform the police whenever needed. Furnish the copies of the records to the police, to the court, or to the relatives whenever demanded. When you have a written, documented, you get a notice from them, and do take a consent from the patient before giving these documents to the police or to the court. Preserve the documents and a copy with you always, and always have an adequate indemnity cover. Thank you.
Thank you, Dr. Rekha, for this crisp talk. I would like to present memento to Dr. Rekha Singhal. Meanwhile, I would like to invite Dr. Chaitanya Shukla for his talk on Stitch in Time Saves 9.
A very good morning to respected seniors and dear colleagues. At the onset, I would like to thank the scientific committee for this opportunity. My talk is more of an extension of what Dr. Alay Banker sir and what Dr. Deepak Bhojwani have already said. I'll be discussing the emphasis of early vitrectomy surgery in the management of endophthalmitis. We know that the load of pathogens tends to increase logarithmically, that is, the load tends to double every few minutes. Thus, in the management of endophthalmitis intervention, timing is considered one of the most important parameters. Early vitrectomy surgery offers benefits such as the identification of pathogen as well as removal of the infected vitreous, toxins, and the means of inflammation. Here I aim to review the pathophysiology relevant to surgical decision making and discuss the evidence for early vitrectomy as well as define indications in the context of modern era as well as expected outcomes. Timing matters in the management of endophthalmitis because rapid intraocular inflammatory cascade has the propensity to cause a lot of retinal toxicity, and any delay in the control of the source does correlate with a direct poor visual prognosis. We know that there are various pathogens with variable virulence, and the virulence influences the urgency as well as the extent of vitrectomy. The rationale for vitreous removal is that a high vitreous load of pathogens acts as an inflammatory reservoir as well as a barrier to the penetration of any antibiotics or medicines that we inject. Toxins and cytokines tend to cause irreversible damage, and here early vitrectomy may present as a savior by reducing the bioburden and the mediators of the inflammation. Visual acuity at presentation is one of the strongest prognostic indicators along with the signs and symptoms of vitritis, hypopyon, the fundus view, as well as the findings of B-scan ultrasound. The vitrectomy surgery is instrumental in debulking of the organisms and the debris, along with facilitation of better oxygenation and penetration of antibiotics. Additionally, it allows a better sampling of the vitreous. No discussion of the management of endophthalmitis is complete without the mention of the EVS. The endophthalmitis vitrectomy study already mentioned strongly influenced the management of the post-op endoff since the release of its findings in 1995. As we have already discussed, the pitfalls were that it did not address certain forms like bleb-related post-trauma or endogenous endoff. Also, there were some discrepancies in the estimation of the visual acuity, and it was characterized by a predominance of coagulase negative staphylococci. Also, the EVS was done in an era predominated by 20 gauge vitrectomy, contrasting to the present day where smaller gauges vitrectomy have improved safety with better visualization and higher speed cutters. Many studies and retrospective and meta-analytic data have suggested benefits of early vitrectomy in patients having vision even better than PL or even hand movements vision. Earlier vitrectomy has been linked to faster infection control and a trend towards improved visual outcome in severe cases. Studies have also shown the efficacy or benefits of early vitrectomy in patients presenting with causes of endoff other than post-cataract surgery, such as post-injection, post-bleb-related, endogenous, and post-trauma. Techniques, as already discussed, involve early core vitrectomy with or without the induction of PVD, which may be customized lens timing, and early vitrectomy has shown to improve globe survival. For example, another patient of a reliable study that has guided us for years, and it has been the main inspiration for vitrectomy in endophthalmitis. But the point to be drawn here is that the decision to perform a vitrectomy should not just be limited to the patient's presenting vision. And one of the most significant advantages of early vitrectomy over tap and inject is the reduction of bacterial load, which is more effective. And regardless of the susceptibility to antibiotics, vitrectomy is effective and also against the highly virulent organisms. So it should be considered in severe cases. Of course, the complications of detachment, recurrent infection, phthisis do occur, but they cannot be attributed to the surgery, and hence it should be customized from patient to patient. Thank you all, and I'm open for comments.
Thank you very much, Dr. Chaitanya, for your wonderful talk. I would like to invite Dr. Alpesh to present the memento to Dr. Chaitanya for his talk. Next, meanwhile, I would like to invite Dr. Bhavik Jala for his talk on TAS and its management.
Good afternoon, everyone. I would like to thank our scientific committee chairman, Dr. Sandeep Arora and Dr. Kushal, to give me an opportunity to talk between the retinal surgeons, anterior segment surgeon, something about not a cataract. Usually, we perform the surgery, and every surgeon's wishes to a good outcome for their patients. No one wants their patients to be infected or inflamed after the surgery. But we are dependent on so many things for the surgery that we do not have control of them. So what things should we take care, and how to diagnose and how to manage the toxic anterior segment syndrome. It is a purely inflammation in the eye, post-surgery, mainly the post-cataract. I'll be discussing on that. So it is an acute severe intraocular inflammation accompanied by the diffuse corneal edema within first or second day of anterior segment surgery. on the contrary to the endophthalmitis, which has been noticed after 48 to 72 hours. It is a sterile, non-infectious endophthalmitis with or without any pain. A marked decrease in the vision with a diffuse corneal edema that extends limbus to limbus with severe photophobia and severe anterior chamber reaction, and occasionally with also hypopyon due to the inflammation. It presents within 12 to 24 hours after the surgery, whereas the infectious endophthalmitis typically present after 2 to 7 days of surgery. TAS is a representative to topical steroids in most of the cases. What is the common etiology? We use so many things during the surgery. We rely on the company and the sterilization part, and so we have to depend on them only. So the etiology basically is bacterial endotoxins or particulate contamination of BSS, intraocular irrigation solution with abnormal pH, the osmolarity and ionic compositions, the denatured ophthalmic viscosurgical devices, intraocular medications like antibiotics, overuse of antibiotics, topical ointments, inadequate sterilization of surgical instruments, inadequate flushing of the instrument between the cases resulting in buildup of ophthalmic viscosurgical devices blockage, preservatives used during the surgery, and precipitates. The pathophysiology inflammatory reaction in the response to the contamination, toxins, imbalanced solutions, medications, or preservatives in the medication. This is a sterile anterior segment reaction. There is no any bacterial or fungal infection, although potential inflammatory reaction is secondary to the bacterial endotoxins. TAS is an activation of inflammatory cascades in anterior chamber in response to external material or improper solution during the cataract surgery. The response is typically apparent and symptomatic within 12 to 24 hours. What is the primary prevention? How we can prevent the TAS or inflammation post-surgery? We have to use the proper balance or solution with correct pH, osmolarity and ionic compositions. Good filtration of the BSS, the manufacturing site eliminates the particulate contamination and endotoxins. We have to avoid the preservatives in the intraocular solutions. Use fresh ophthalmic viscosurgical devices, adequate sterilization of the instrument and tubing according to the manufacturer's protocol. Standard and clear operative and instrument processing procedures, SOPs should be maintained. Every small healthcare unit, small eye hospital can go for an early MBH certification. So you will have some specific guidelines for your hospital. Your staff will also know the seriousness of the sterilization and everything, and you can have a good SOP, and your every procedure is observed by some of your staff. So they get also know the seriousness about the sterilization, disinfection, use of the sterile equipment, instruments and everything. We have to switch to a single-use cannula. So we are using so many cannulated instruments, so it is advisable to use a disposable cannulas. Do not reuse single-use devices. Use preservative-free medications. Keep use instrument moist until the processing. Inspect your instruments regularly for any debris or any use of viscoelastic stick on the instrument. Use an ultrasonic cleaner to clean your instruments. Rising and copious irrigation cannulated instruments are after ultrasonic cleaning will remove any detergent or lubricating used during the ultrasound cleaner. Do not compromise when you sterilize. Irrigate your cannulated instruments so there is no any chalking or material stick in the cannula. Put fewer instruments in your tray. Allow time processing. These are some signs and symptoms. I will skip this. Everyone is vision loss, pain, photophobia, acute severe inflammation, corneal edema. This is the clinical diagnosis. How can diagnose? On first or second day, the inflammation is there. Laboratory tests, generally it is negative for any bacterial or fungal growth. The differential diagnosis is infectious endophthalmitis, retained lens material, uveitis. The management is usually patient respond with the topical steroids, oral steroids and cycloplegic. So these patients need to get follow-up every day, so you get to know, differentiate between the infectious endophthalmitis and TAS. If the patient are responding with the topical steroids, oral steroids and cycloplegic, so no need to worry, and it is TAS and it will go away, and the patient's vision get improved day by day after the treatment. What are the complications? It may the severe inflammation, make their pain, vision loss. In few of the cases, not many of the cases, with the task we have seen iris atrophy, either talented people or irregular people. The prognosis in most of the cases are good with a response with oral or topical steroids. Thank you so much.
Thank you, Dr. Bhavik, for your talk. I would like to invite Dr. Mehul, sir, to present memento to Dr. Bhavik Jala. And meanwhile, I would like to invite our national faculty from Delhi, Dr. Tinku Bali. She will be speaking on management of endophthalmitis in 2026.
Laser pointer.
Good afternoon, everyone. Thank you so much to the Gujarat Ophthalmological Society for inviting me here, and it's my pleasure and privilege to be here before all of you. So I would be talking on the management of ENDOF in 2026. So most of the aspects have already been covered by previous speakers, so I'll just be reiterating and re-emphasizing some of those key takeaway points. Now, as you know, in endophthalmitis, an early diagnosis is extremely important to guide our therapy, and if possible, to get an etiological diagnosis is extremely important. Today, we have antibiotics even for very resistant cases, and as the previous speakers have already told you, that early and complete vitrectomy is the way to go forward. So as far as the etiology goes, the commonest organisms in the country is or a staph aureus. If you go down south, the most common organism would be the gram-negative bacteria. So these are the two organisms, especially Pseudomonas is very common in our country, and these are the species that we have to know about when we are thinking of the etiology in our minds. Again, I would like to emphasize that time is retina, because the vitreous growth rates of the bacteria are in the first 24 hours. In fact, there is a 10-fold increase in the first 3 hours itself. So this just shows us how urgent it is the eye. As if the intradermals is one, they are expensive. Just need 0.1 ml of the sample. The sample goes to their lab in Bangalore, and it was a young patient who had 6/6 vision to begin with. We immediately sent the sample to Bangalore. Within I think 18 hours, we got the result that it was Pseudomonas. So I had just come back home in the evening. I went back again to the clinic, injected the patient. Colistin injection was given. After 2 injections, again antibiotics go. We all cocktail of vancomycin, for instance, that has built up to ceftazidime. There have been multiple studies that have shown the amount of resistance that has come. So in my practice now, I have switched to vancomycin plus imipenem. I have done away with ceftazidime. Of resistance that is there. So, just giving the old cocktail to colistin, called ciprofloxacin, levofloxacin, and then piperacillin and tazobactam. So in this patient, I opted for piperacillin. Ciprofloxacin has a very short life in the half-life in the vitreous cavity, just 6 hours. So you would have to keep giving BD injections. So in this patient, a sensitivity report is extremely important, a culture and sensitivity, because you do not know what this organism is going to be sensitive to. Voriconazole injection hours. So like I showed you, 26 injections, sometimes 10, 12, 20 injections before you can actually get away, with killing the fungus. Steroid therapy has already been talked about. You do need to give oral and topical steroids. With bacterial, you need to give intravitreal steroids as well. Oral antibiotics should always be given in a bacterial end-off. They have excellent penetration in the posterior segment. You take the patient up for an early vitrectomy, and nowadays we are seeing a lot of post-intravitreal injection end-offs. So these cases are extremely fulminant. The end-off progresses very fast. So if you have end-off following anti-VEGF injections, do take the patient up for a primary vitrectomy itself. It's going to progress very fast. So again, no role of co-vitrectomy. We do as which look so bad like this, But generally, these are exudates in the anterior chamber. And once you've cleared these exudates, sometimes you'll see that the posterior segment is not bad at all. So once these exudates are membranes and exudates in the AC, and the posterior segment may not be so bad. The hyaloid, because they are stuck between the hyaloid and the retina. So again, it's important to do a PVD induction. Now your PVD induction has to be very gentle, only till the and actually lift off all these colonies of persistent infections. And in conclusion, a beta which give us better result. Vitrectomy, there's an instic modalities should be used as a talk, and I request your support and your best wishes. I'm contesting for the member Academics and Research Committee, and I need your support, best wishes and guidance. Thank you so much.
Thank you, Dr. Tinku, for your wonderful talk. We conclude, subsequently invite the dais chairholders for the next session.
Good afternoon, everyone. Now we are moving. Good afternoon, everyone. Now we are moving to the next session. That's on diabetic retinopathy update. First, would like to invite Chairman Dr. Prashant Bavankule sir, Dr. Parth Rana, Dr. Vinita Ramnani, and Chaitanya Shukla. Sinha will be presenting. Actually, she has got a flight to take. So we start this session. First, I would like to invite Dr. Vaibhavi to present her presentation on OCT biomarkers and diabetic macular edema. We keep seeing her WhatsApp messages, very motivational messages.
They're really nice. Thank you, madam, for that. It starts the day on a good note.
Thank you. Good morning, everyone. Thank you, AGOS, for having me. Why OCT? Because it's a neuroretinal disease, and early detection helps us with knowing the microstructural damage. It also helps in prognosis and monitoring. Fundus tells you what you see, and OCT tells you what is happening. So we all know the normal OCT. What key features are: preserved foveal depression, ellipsoid zoid, well-defined retinal layers, and no cystic spaces. According to the ETDRS classification, mild NPDR, when we see OCT correlation will be EZ irregularity. Moderate NPDR, we can see hyperreflective foci. In severe NPDR, we can see ischemic markers like drill. In PDR, we can see vicromacular traction. In diabetic macular edema, we can see cystoid phenotypes. So OCT biomarkers can be categorized neurological, that is drill and EZ loss, inflammatory, that is hyperreflective foci, and vitreoretinal interface, that is traction. So early DR markers will be EZ irregularity, disorganization of retinal inner layers. Its significance is high HRF predicts good response to the steroids. Prognostic values of the biomarkers. If drill is there, the poor visual recovery can be said. EZ loss limits the final BCVA. Hyperreflective foci shows good response. Active PDR with DME. Steroid is preferred when we have hyperreflective foci, chronic refractory DME, and pseudophakic patients. In case of traction, we will like to go up as well. In the primary section, is an enlargement and we can see that vessel density is less and it causes higher risk of progress to central involved DME. In severe and see non-perfusion areas and vessel density loss. It will be used for early pediatric. You can see the neovascularization result. It predicts better response to anti-VEGF. It is loss of DP will show that the so we are supposed to look at avasal area, vessel density, and foveal perfusion. So artifact awareness to ensure the segmentation is correct before calling it fluid avoids. So the fundus is for and Opta is for progress and risk. Thank you.
Yeah, thank you, Dr. Vaibhavi. Now we move on to the next talk by Dr. Pooja Sinha on PES.
Sorry to come in between again. So I would like to declare the two contestants. Name already I have declared before. They are now here and they are contesting for the post of Member Scientific Committee, Dr. Harshul Tak from Rajasthan. And my dear friend, Dr. Ankur Singh. So please vote and canvass for both of them. Thank you. Thank you very much.
Good afternoon, everyone. At the outset, I would really like to thank the Gujarat Ophthalmological Society for this opportunity. And my apologies for speaking out of turn because we have a flight actually. So I'll be sharing with you a challenging case of IPCV which I recently encountered. So this was a 68-year male patient who complained of diminution of vision in the left eye for 1 month. He was a diabetic since 5 years and glycosylated was 6.8%. There was no other significant systemic history. On examination, vision in the right eye was 6/12 and left eye was 6/24. And there was grade 2 NS in both eyes. So this was the fundus picture of the right eye. You can see multiple drusen in the posterior, microaneurysms responding to the diabetic retinopathy changes. And this was the left eye, which had few microaneurysms and a large hemorrhage in the macula. There was also a massive dome-like peripheral hemorrhagic subretinal lesion in the inferotemporal quadrant, as you can see here. The FFA showed leaking microaneurysms. There was blocked fluorescence corresponding to the blot hemorrhage, and blockage of choroidal fluorescence below the hemorrhagic mass was also present. There were surrounding window defects from atrophic RPE changes. So since there was an element of PCV along with diabetic retinopathy changes, I injected the patient with ranibizumab 0.05 ml given followed by laser around the hemorrhagic mass because it was extramacular after a week in November 2024. The injection was repeated monthly in intervals over 3 months. So this was the fundus picture after the second injection. You can see that the hemorrhage had significantly decreased. And the vision had improved from 6/24 to 6/12 after the third injection. All along, this patient was lucky because there was no macular involvement because this was a peripheral PCV. Patient again reported in March 2025, but he was complaining of and surrounding the previous lesion. At this point, 2 more injections of ranibizumab were given in March and April. There was a lot of VEGF load in this eye. So this was following injections. And at the end of 2 months, vision had improved 6/9 and hemorrhage had subsided with subretinal fibrosis. And this was the FFA picture. However, the patient was in July 2025 with sudden diminution of vision in the left eye. And there was vitreous hemorrhage. At this point, since he had the cataract had also progressed, we did a phaco IOL and along with vitrectomy, the peripheral endolaser. So this was finally post-vitrectomy and vision had improved to 6/9 and there was complete regression lesion with RP, hyperplasia, and atrophy. So the key points why I wanted to present this case was, though the lesion was extramacular, it can become it is very aggressive, especially PCV lesions are known to be very aggressive, and when there is breakthrough vitreous hemorrhage, the vision can subsequently aggressively drop. So coming to conclusion, the peripheral exudative hemorrhagic choroidoretinopathy, or PEHCR, is an uncommon degenerative process of the retina with subretinal or sub-RP hemorrhage and exudative mass outside of the macular region. This was first described by Rees and Jones in 1962, and TuCL claimed that PEHCR is actually a peripheral counterpart of ARMD. But drusen, a hallmark of ARMD, is absent in PEHCR. Visual loss, as I said, could be due to subretinal fluid or fibrosis or a breakthrough vitreous hemorrhage, which happened in my case. OCT is not necessary to assess PEHCR, which is too far in the periphery. However, it is useful to assess the extent and exudation in the fovea and the subretinal fluid. The ultrasound is important in these cases to differentiate PEHCR from a choroidal melanoma, as we know that has a clot retraction cleft. In PEHCR, there is no intrinsic double circulation and no choroidal excavation, which is actually seen in choroidal melanoma cases. And a regular and continuous follow-up is required owing to the aggressive nature of this disease. Thank you so much for your patient hearing.
Thank you. It was a wonderful presentation. So now we move on to the next presentation.
Thank you so much.
Yeah, thank you, ma'am. And request Bavankule sir to present memento to Dr. Vaibhavi.
Wait. उनका नहीं है, उनका नेक्स्ट सेशन में तो मैडम ने हाँ
for national faculty it was given yesterday, so
Good afternoon, everyone. Thank you very much, AGOS, for giving me this opportunity. So today we are going to talk something about what we see in everyday patient scenarios. So just a quick recap. The WHO figures say that 830 million people are diabetic. Diabetic retinopathy prevalence is 30 to 40%. Prevalence of PDR or sight-threatening retinopathy globally is 3 to 8%, and sight-threatening retinopathy, including maculopathy, is 10%. But in India, there is some difference in figures, which still is 12.5% of diabetic retinopathy and about 3 to 5% of sight-threatening retinopathy. So we've been faced with some clinical scenarios in which we do get into this confusion whether DRCR net protocol can be applied in our Indian population. So in this, basically, there's a controversy, or say there's a treatment dilemma, whether to use intravitreal injection first or PRP for diabetic retinopathy, proliferative diabetic retinopathy. So here we have first patient who is a 60-year-old male, diabetic since 2002, having hyperlipidemia, heart disease, history of Ozurdex taken elsewhere. He presented to us in September 2025 with dimness of vision since 1 month. BCVA was 636 in each eye. IOP was normal, anterior segment was normal, phakic patient. This was the first presentation. In fact, there are some laser marks because I don't have the picture before giving first laser. So after first laser, we had this clinical picture. dense pre-retinal hemorrhage in the right eye. Fortunately, the patient had that foveal center preserved so that his vision was still 636 partial. This was 1 week later after 3 sessions of PRP. Right eye vision was 624 and left eye 618. This was after 3 sessions of PRP and first injection of aflibercept in both eyes. And after 3 injections of aflibercept, there will be next slide which shows the importance of aflibercept here. So the final vision after 2.5 months of treatment was 612 in each eye. This is the OCT of the patient when he first presented to us. Severe diabetic macular edema in both eyes when the vision was 636. So after the first aflibercept, the vision already came down to 618. By that time, 3 PRP sessions were given in both the eyes. And after the second aflibercept, 1 month later, the macular edema further went down, giving us the vision of 612. Coming to patient 2, he is again a 60-year-old male, diabetic since 22 years, hypertensive, just detected 1 year ago, and complained of right eye dimness of vision, sudden onset 10 days earlier. Wherever he went initially, he was advised intravitreal injection. When I saw the patient first, the vision was 624 partial in right eye, 66 partial in left eye. This was the clinical picture. So the patient was again treated with 3 sessions of PRP, which is my primary line of treatment. First, I do give 3 sessions of PRP within 1 week and then inject the intravitreal anti-VEGF if needed. So in this patient, there was no macular edema on OCT. So I did not give any injection. It was just with PRP. The patient was much better and then vision recovered to 6.6. Although right eye, because of the clinical fundus, what we can see, he did need 2 further more sessions of PRP after the 3 initial sessions. Coming to patient 3, she was a young patient of IDDM, coming with dimness of vision since 2 weeks in right eye. Right eye intravitreal Avastin taken elsewhere. And the vision at presentation was 612, in left eye was 6.6 partial. This is the clinical photo. Right eye had mild vitreous hemorrhage. Therefore, the image, fundus image, is slightly hazier. Vision in right eye was 612, left eye 6.9 partial. She had already taken 1 session of PRP earlier elsewhere. So again, in this patient, I just gave her PRP because macula was absolutely normal, no edema, and she did very well after that, 6.6 partial vision in both eyes. After this episode, she did have a vitreous hemorrhage on and off, very mild vitreous hemorrhage, which would just encourage me to do little more PRP, and she is very stable right now. Coming to patient number 4, 58-year-old female. She was just detected to have diabetes in January 2024, dimness of vision since few weeks. First ophthalmic consultation done with us in June 2024. Right eye BCVA was 618 partial, left eye 6.6, and anterior segment was unremarkable, phakic. Now this was her OCT image. Right eye severe macular edema. Right vision was 618 partial. Left eye was 6.6, no macular edema. So below there we can see the post Razumab. She just wanted to go for Razumab injection, so that did improve her vision. And further on, I continued with Razumab 1 month later. The vision was 6.9. Then she just defaulted. So she took 3 injections initially. Vision was 6.9, and then she defaulted. So she presented again in 8 months later with severe macular edema, just like the initial presentation. So I would like to ask all of you and even the panelists, what would be your first line of treatment, PRP of anti-VEGF? what is frequent occurrence, and then one more important thing that many physicians do not advise the patient for ophthalmic checkup. So somehow I think we have to convey to physicians that at first check of diabetes, they should recommend eye checkup to the patients. Thank you for your patient hearing.
Thank you. Very well presented, ma'am. And even for proliferative diabetic retinopathy, as on date, the gold standard is pan-retinal photocoagulation. And once you have a well-anchored retina, and if you see one of the bleeder or small polyp bleeding in the periphery on and off, there we can use any of the anti-VEGFs. That is what I would suggest. In the presence of DME, yes, of course, it is the anti-VEGF that goes unsaid. Well presented. Nice.
We request Dr. Arvind Moria to present the memento to Rita, madam.
Would like to also invite the next speaker, Dr. Mudit Bansal, to present our VR interface changes in anti-VEGF treatment.
Thank you. I thank the committee for giving me a chance to be here. So it starts with the male patient who presented to us with superior temporal BRB, or classic presentation with a dense cystoid macular edema, and as would be expected, he was advised anti-VEGF treatment, and he went ahead with Avastin. So this was the picture that we saw after 2 injections of Avastin. It was a little horrifying, worrisome picture. Since there was this macular edema still at the edges of the holes, we still tried to go in with a 3rd dose along with steroids. The edema did reduce, but the hole still persisted. So the last option was, of course, to go ahead with pars plana vitrectomy. Fortunately for this patient, the outcome was good enough. So anti-VEGF related macular holes have been reported in the literature. They have been reported for all cases like CNV, VMs, venous occlusions, least of them with the diabetic macular edema. And they have been associated with any type of anti-VEGF injection, whether it is bevacizumab, ranibizumab, or aflibercept. The pathological factors, the responsible factors have been different depending upon the condition. For CNVMs, it's more in the RP factors, the contracture of the CNVM tissue. And for the other conditions of venous occlusion or DMEs, that would be also with retinal surface or the VR interface issues with the presence of vitreomacular adhesion or vitreomacular traction. So it's a known entity, vitreomacular interface abnormalities associated with anti-VEGF. And the pathophysiology basically is you're disturbing the vitreous in any way. So the ocrioplasmin injection that used to be, was there previously, was on the same concept. So basically what is happening is induction because of the chemicals being injected in the vitreous cavity and structural modification, reorganization of the vitreous body. The process of giving the injection, this is minute micro millimeters of globe deformation, vitreous incarceration, which is an innocuous the injection site. Whenever we are giving the intravitreal injection, we do see at times a bleb coming out. And apart from that, those tangential reaction with the pre-existing epiretinal membranes. So just a few of those cases of vitreomacular traction post-anti-VEGF. This was again another patient who presented with cystoid macular edema. Again, as would be expected, since a fresh BR view. So he was treated with the anti-VEGF injections. Numerous injections were given, starting with Avastin, ranibizumab. On the top corner that you see, it was about a year has eventually developed vitreomacular traction. The adhesion, the vitreomacular adhesion at start, he was again treated with intravitreal anti-VEGF injection, which is the primary choice that we would do. Again, this patient was a little less on the compliance side and would come in and would get lost to follow-ups in between, and there were numerous injections given over a period of 1.5 to 2 years. And the last bottom figure, the image that you see, macular traction, the adhesion VMA had started developing studies which influence of vitreomacular interface on anti-VEGF therapy outcomes for CNVM cases, where they found that these cases who had a pre-existing VMT would require more intensive treatment and a decreased efficacy outcome post anti-VEGF treatment. Similar to one of the cases that we saw, this was a CNVM case with a vitreomacular adhesion, we would say. with a partial PVD, was treated with the anti-VEGF injection, again multiple ranibizumab injections. These were about, I think, 5 or 6 injections, and at the end of the follow-up, where you see it's an exaggeration of vitromacular traction with elevation and impending, probably a lamellar macular hole impending to develop. So again, in the literatures, there is the association of vitromacular traction issue. A lot of literature, if we search for it. One of these studies which showed that there were about 20 to 25% of the cases who would develop VMIA, vitromacular interface abnormalities, over the period of 3 years. These would be mainly vitromacular tractions or epiretinal veins. And another case, the plus side of this is, of course, they can exaggerate the vitromacular traction, but the plus side is at times in some of the studies what they've seen, we haven't encountered it yet, but in some of those studies, there can be a release of this, have a favorable prognosis. One of our cases, analysis where they studied the pre-existing vitromacular interface would have a poorer outcome and would require much more recurrent anti-VEGF therapy. Just 2 slides. So this is one of the cases who had a pre-existing vitromacular adhesion, again I would say not typically a traction, in a DME eye, again was treated. Initially it responded, but then this was again after say, 3 or 4 injections, they keep on coming back. So maybe in these there is a pre-existing vitromacular traction, not as the primary therapy, but switching to maybe a vitrectomy option, who were later on operated for vitrectomy with PVD induction membrane peeling. So they at times may give a finite end to the treatment. So to conclude, these VNT issues or the VMA issues are a certain probability that can be seen with anti-VEGF treatments, and they're more so seen in the initial injections rather than over the subsequent period of time. And they may be associated, pre-existing may be associated with poorer outcomes and extensive treatment. Thank you.
Mudit, your presentation scared, badane darai dida je log ko medical retina practice kar rahe.
So kya
Comment.
Sorry?
Your presentation scared those practicing medical retina.
There's always a plus and minus to everything. So we need to, the people do, medical retina is a specific branch, of course, but it has to be studied well, sir. If you can read the OCTs and all, then you would not land up in troubles. But again, in retina, there is a plus side and there's always a minus side. So when you're looking at the OCT and the fundus picture, you need to sort of predict how these eyes may go. There's always
Sir, thank you. We are running short of time. We can take it outside. Mudit sir, your moment, please. I request sir to present the moment on Mudit sir. We in next speaker, Dr. Nilesh Kanjani sir, to please come and give on intercept imaging DME. Please, sir.
I would also like to thank the organizers of scientific to allow me to present this thing. So now I'm going to talk about the diabetes. He knows it's a hot topic. Monitoring and injection frequency can become a burden for patients and their caregivers. This is believed to be the main cause of undertreatment in patients with DME. Patients with DME often need to attend many other appointments, management of systemic disease. This, coupled with the fact that vision may deteriorate slowly, means that patients with DME have tendency to miss appointments. We are seeing often in our practice. So now, okay, is having a color binding capacity. Now, of course, I don't want to go into the depth, but yeah, because of neovascularization and all the that we have. So a lot of clinical trials have been started. We started with a laser, then steroid and anti-VEGF combination going on. Now here, let me discuss a few things about the phase 3 trials which in the VP study. 87% of the median screen at 1 year had been after 5 monthly doses of the aflibercept. 93% of the mean letters gained at 1 year had been gained after 5 monthly doses of aflibercept. Protocol T, significantly greater vision gains, which were seen with the aflibercept compared to bevacizumab and ranibizumab at year 1, and they were maintained year 2, which required fewer injections than year 1. So multiple studies you can see here where we see gains in the aflibercept in patients with DME in a real world setting were almost consistent with vivid trials. Now, here study was that aflibercept was associated with meaningful vision gains and also vision loss in the patients with DME. In the past, when we used to give lasers, we had a lot of vision loss, but able to maintain vision, giving more anti-VEGFs. Now, this is which shows that patients with the base vision of less than 6 letters had significantly greater vision gains with aflibercept than with ranibizumab over 12 months. This was a common meta-analysis which had the conclusion that at 1 year, all effective outcomes significantly favored aflibercept over ranibizumab and bevacizumab, and patients were up to 30% more likely to get more than 3 lines with aflibercept than ranibizumab or bevacizumab at year 1. The Retina guidelines recommend aflibercept as a drug of choice whenever the baseline is less than 69 letters. In Asia, with anti-VEGF is the first line of choice for treatment of DME. Now, let me go to the cases. One of the cases, a known case of diabetes since more than 15 to 20 years, had came to me with vision of 618. You can see the fundus photo, and the OC showed macular edema averaging to 570 microns. I do angiography routinely in my majority of the cases. The post-ILIA injection, almost 5 ILIA injection. In my practice, I give 1 injection every month for 3 months, and then I try to extend the duration of visit and the injection. So this is after 5 ILIA given almost over 8 to 9 months. This is case you can see here the vision was 3 meters, finger counting. You can see the macular edema. I don't want to go into the details or the OCD biomarkers. You can see angiography here. Angiography helps a lot to see the progression of retinopathy. This is post-ILIA injection. You can see that the macular edema is reduced almost after 4 ILIA injections. This is fundus, you can see a severe macular edema, and of course see the angiography picture. Now, angiography plays a very important role in deciding in number of the anti-VEGFs in my practice. In post-ILIA injection, you can see here the vision is almost 6 almost 5 ILIA injections. This is one of the interesting case. Multiple lasers elsewhere, multiple injections given elsewhere. On if I would have just seen the fundus photo picture and OCT, I would have given a little few injections. But when you see the angiography, you are able to see leakage on the angiography. Post-ILIA injection, we gave almost this patient 3 to 4 injections, and you see the near normalization of the angiography. So angiography, in my practice, I do a lot many times to make sure that I am coming to the near endpoint of the disease. Of course, systemic parameters play a very important role. So PET survey you can see here, which was wherein according to that, of course, come out with the patient support program, and thanks to the Bayer team for helping in that. So now, having outcomes of our patients, data from pulsar and photon suggested aflibercept 8 mg has a greater sustained disease control. So, drug of choice in the management of new onset DME and DME not responding to anti-VEGF agents gives excellent drying effect with extended interval. Stabilized vision is majority of diabetic patients control system parameters. ILIA future will reduce number of injections and cost burden to patient. Patient support program helps lot of patients to continue treatment for a very long time. Thank you very much.
For the very interesting talk. We ask Dr. Path Rana to felicitate and give the moment to Nilesh Kanjani, sir. Sir, please. We ask the next speaker, my co-moderator, Dr. Navneet Mehta, to give a talk on vitrectomy.
Good afternoon, everyone. First, I would like to thank the organizers to give me an opportunity to present my work on diabetic vitrectomy. Starting with because a lot of anterior segment specialists are there, it's important we stick to some of the basic thing and lot discuss in diabetic vitrectomy. Are non-clearing vitreous hemorrhage tractional detachments, which is affecting the macula, and progressive fibrovascular proliferation, anterior hyaloid fibrovascular proliferation, which is just behind the lens, or diabetic macular edema without macular traction. This is a lot to discuss in this. In which diabetic macular edema we need to operate, which we need not operate, because there are some cases in which we can have some good results, but cases in which it's been reported like not responding to, then we can take it. But even the visual notion we explain to the patient. Macular hole may be due to because of traction, macular retinosis, glaucoma with anterior vitreous hemorrhage. Evaluation is important in these cases to evaluate for anterior segment ischemia, pressures. At many times we have to take combined cataract and visual surgery. We need to remove epiretinal membrane if there is a significant vitreosis posteriorly. I don't do in all the cases, but there is a significant vitreosis just to confirm that there is a removal of all the membranes is there, and then remove LM2, old macular attachments, and preoperative ultrasound in the case of is important. Then preoperative anti-VEGF is very important in a lot of these because it was a quick regression of active neovascularization. So have to be told before surgery, like we have to take these patients 3 to 5 days after injections. There are less intraoperative bleeding, improved visibility, reduced reliance on endothermy, and we have to do fewer instrumental changes and less postoperative bleeding. Surgical techniques, there are not go detail in each and everything because it's long to discuss all those things. Scleroderma is very important. Now we have moved to 25 and 27 gauge, so our surgical fluidics and all, because of those, our surgical results have improved a lot. Use of chroma-assisted vitrectomy, use of triamcinolone, use of induction, and this vitreosis is very important because that's the key of diabetic vitreous and this vitreosis. So we need to confirm that we have to stain with triamcinolone, relieve all the anterior posterior traction and tangential traction. And for relieving the tangential traction, the most common techniques are segmentation, delamination. That was how it was after clearing the vitreous, and with the small gauge these cutters, more end of the cutters, and also the opening time has increased, so we can do a good cutting. And even I use the cutter many times to act like a pick and remove all those, separate those membranes, and we can go very close to the retina and cut these. This is what is segmentation and multiple segmentation, and then we can just see how we can easily reduce a lot of bimanual because of these segmentation, delamination. We can lift, shave, so a lot of control is now with all these cutters. So this is how it was at the end of surgery, and what after laser, this was how it was after 1 month after surgery. Patient gained clean vision. This is another case of similar kind of proliferation, and after clearing the vitreous hemorrhage, these we can see. And many times I just go inside and do all cutter technique, just go inside and separate everything with the cutter. Now these with these cutters, just lift, shape it, separate the under the retina, and space, segment it again, and then with vacuum and just finish the surgery with the. So this was just last. Another case of vitrectomy. It was difficult in the planes just inward, and previously used to go with the weaken incision and then cut now become easier with this cutter and just with the all cutter technique. Because of these newer cutters, we can just finish these surgeries and do laser photocoagulation. That's the last case with just segmented and just do the segmentation and just lift and shave these proliferations, and this becomes very easy with these modernization of our instrumentation and fluidics and all. Thank you very much.
Thank you, Navneet Bhai. I would request Dr. Mudit Bansal to please come and give the memento to Dr. Navneet Malhotra. Our next speaker is Dr. Ophthalmic who will be talking on recent advances in diabetic management.
Good afternoon, everyone. I am discussing today recent management of diabetic retinopathy. As we know, it's a victim of the preventable blindness all over the world, and we just try to find out the advance in imaging that will lead to early diagnosis and proper treatment of the diabetic retinopathy. Find the clear-cut pharmacotherapy and surgery to transform the better vision to our near and dear patients. So what are the screening and diagnostic imaging we have found out is, as of now, we are on the ultra-wide field fundus imaging, but still it is not capable to take by all of the retina surgeons. So we should find out the cheaper option for the ultra-wide field fundus imaging, which will be very, very useful to find out the peripheral neovascularization, which is happening after the peripheral capillary non-perfusion. OCT nowadays we are using most of the time to find out the macular edema and vitreomacular traction. The one more tool is very, very excellent that is non-invasive, is OCT angiography, in which we are not injecting any kind of dye, and we can find out the capillary non-perfusion and the enlargement of the foveal avascular zone, which is very, 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 very useful for the treatment of the diabetic retinopathy. This is one of the few cases we are still finding difficult, even after injecting the multiple anti-VEGF, whether it is a Avastin or any kind of Eylea, or even the newer one, the Faricimab. This patient went under with the more than 8 DEXA implant and 2 times of the focal laser. Still you can find the below OCT is not that much convincing to our treatment. So still there are a lot of patients lying with our OPD, coming with the same OCT reports, which we can label it as a suboptimal response with the maximum effort pharmacotherapy and laser treatment. We need to find out what next we can do. This is what we can see is as a recent advances in diabetic retinopathy management. So there are couple of the trials, phase 1, phase 2 and phase 3 trials are going on. It can be the first one are the phase 3. So dexamethasone eye drops has been also tried, and they have started recruiting for the study. One is Tarcocimab, which is used as a intravitreal injection. It is anti-VEGF antibody biopolymer conjugate, just supposed to act longer than the anti-VEGF which we are using right now. And third one is MK3000, which is again an intravitreal injection. It is also under the mode. This is how many times we are seeing patients are having no diabetic retinopathy till they live. Few of our patients are not getting single microaneurysm till the age of 20, 25, 30 years or till they die. So we have to find out these are the persons who are the very, very, very extreme phenotypes which never develop the diabetic retinopathy. If we can find out that thing, which person has this kind of phenotype, so it will be helpful and we can do the research and we can do the treatment for that. develop mild NPDR, and out of that, 30% will develop into clinical significant macular edema, which is labeled as a vision threatening, which need the treatment. Most commonly, type 1 diabetics, type 1 DM patients develop the PDR cases, that is involving the macula and without the macula. These are the few genotypes we can clearly see in PDR and extreme DR phenotype, which are not getting single changes of the diabetic retinopathy. This is the OCT. You can see the enlargement of the foveal area gradually as the NPDR progress to PDR, and later on in the PDR, dilated telangiectasia vessels, which can easily see without doing any dye, PDR case in an early case. You can see the significant ischemia. We can plan the thorough PRP, and SOS, if macular edema is there, we can give the anti-VEGF injections. Pathological advances, we are still using the 4 drugs, ranibizumab, aflibercept, bevacizumab, and faricimab, and sometimes steroid implant. Diabetic retinopathy. If giving the, we can reduce the PRP load, or we can delay the PRP in a few selected cases. Because the treatment algorithm, most of the time we all are following according to DRCR. If vision is consistent, 6/9 and no macular edema, we can just wait and watch. And like this, if there is a DME, we can inject the anti-VEGF. If there is a PDR, there is a protocol in the DRCR, we can straight away give the multiple injection of the anti-VEGF without pan-retinal photocoagulation. So there are 2 arms in the DRCR and that. Even though we are with the giving the anti-VEGF, PDR progression can be regress. Coming to the laser therapy, we should by the OCT, and we can do the targeted PRP laser and avoiding the retinal damage. And this is called as a sometimes sub-threshold micropulse lasers, which is very, very useful in the DME cases, because these lasers we are giving around the fovea, around the macula. So we have to prevent the retinal collateral damage also. So this is very, very useful in recent cases. A few indications of the diabetic retinopathy, vitrectomy. It is very well told by the. These are the few indications. What I found, we should do the small gauge, either 27 or 25 gauge, because it's a high-speed cutter, improve the fluidics, chances of are very, very less. The memory and delamination. First, retinal break in most of the pediatric surgery. These are the few cases. Why do think early, not the late? If you give chance to have angioplasty, try to do as early as you can salvage the eye, and as well as anatomical and functional outcome is the better if you get operated early in the pediatric case. This is after the vitrectomy surgery. You can see one more thing I was just want to tell is limited membranectomy. Most of the cases in PDR, we just try to remove whatever membrane we are seeing over the retina. But nowadays, we can just withhold some membrane which is from the arcade and not threatening the macula, and just do the complete PRP. We can salvage the eye without doing any iatrogenic break or without doing higher complication which is related to, and we can remove the silicone oil and we can get the best vision. This is how only PRP.
To conclude.
Yeah. So visual outcome is very good if you do the modern techniques, vitrectomy, anti-VEGF. Future direction, we will find out the longer acting anti-VEGF agents. This is also in the pipeline. Gene therapy and sustained drug delivery systems are also there for the few drugs. But management of DR is rapidly evolving. Combination of the laser and surgical advances improve the outcome. And first and most, early vitrectomy is definitely going to save the site many of the PDR cases. Thank you.
Thanks, Dr. Nice presentation. Now request to present a memento to Dr. Alpesh. Would like to invite next speaker, Dr. Kushal Dariwala, to present on OCTA artifacts and tips to obtain better images.
Very good afternoon to all, and I would like to thank AGOC for this opportunity. So I have been using OCT angiography in my routine practice. It's a non-invasive technique, and it has got a faster acquisition time and has also got a repeatability. But the only limitation right now which we are still facing despite all the advances is the artifacts which occur during either acquisition or processing or analysis, and it can lead to variable interpretations. So in a major paper they showed that at least around 97.3% chances are there that the image acquired may present with the artifacts on the OCT angio. So these artifacts can be divided into patient-related artifacts, image acquisition-related artifacts, operator-related, and the display strategies. Let us look at the patient-related artifacts. So obviously, a lot of times because of lack of fixation, the patients may present with the saccadic motions of the eye, and that can lead to this type of artifacts where we can see that the vessels are slightly misplaced in the final outcomes. So here we can see the real world artifacts, the white lines which we are seeing in the central part. These are the artifacts related to the saccadic motions of the eyes. And sometimes the blink artifact can lead to this type of black lines horizontally, which can lead to the missing of the important data. So these are another variable motion artifacts where we can see that FAZ is now looking distorted, but actually it is related to the artifact and not the correct FAZ distortion. Again, another type of artifact related to the patient saccadic eye motions is the banding artifact, where you can see the gray and white alternate bands here on the OCT angio images, and that can lead to variable interpretations. Now this is a real world patient who has presented with a floater, and we can see here there is an NVD here. So this was an old vitreous hemorrhage. Now this has caused another type of artifact which is called the shadowing artifact or the masking, where we can see here that actually the presence of this vitreous hemorrhage old band has caused this type of appearance. So here we presume it to be a non-perfusion zone, but actually it is the artifact here which causes a shadowing over here. And on the other side, if we see this type of patients where there is an outer retinal atrophy, that is called an unmasking artifact, where there will be a hypertransmission. So actually we are here able to see this type of choroidal vessels here on the OCT angio. So this is not a CNV. So a lot of times patient might present with this, and we actually mistaken it to be a CNV, and we start treating with the intravitreal anti-VEGFs. Another ones are the false positive artifacts, which can actually alter the vessel densities and flow measurements, which may be related to the hard exudates presentation or the pigment accumulations over the macula or the retinal hemorrhages. Here is an example of the false positive artifact where we can see there is a hyperreflectivity at the fovea, and if we pass an OCT angio through this hyperreflectivity, which we may see something like this. So this is called a false positive artifact, because actually the OCT angio is based on the principle of the blood vessel flow, but actually here it is representing this blood vessel flow, which is not an actual blood vessel flow, but it is because of the pigment accumulation. Another false negative artifacts may be that there is an actual flow, but because if it's too slow or below detection threshold of the machine, it can lead to a false negative. So actually flow might be there, but it presents as there is no flow. Another software related artifacts which are there inbuilt, and it varies from the machine to machine. There may be some vessel doubling here, we can see here. There may be some sort of stretching of the vessels here, or this can be a crisscross artifacts, which is also called as a quilling artifact. Operator related, obviously our optometrist or the person who is after the machine has to be very well trained, otherwise which can lead to a defocusing of the images, which can lead to an altered presentation, or sometimes can be a decentration. Now here we can see that TDS grid is centralized very well on the fovea, so it is giving this interpretation of the values actually come out further. Another important for segmentation artifacts. So now we know that the angles are divided into superficial and are actually so we machine are this is the different machines. So here is the machine which we are using at the swab source machine. Here the normal OCT slabs which we get in this machine. Now we can look at this segmentation artifact. Here is a patient with diabetic macular edema. If we look at the deep slab is going through the actual slab should have in. So if we look at this presentation, the slab, you can see drastically this FAZ distortion reduces in this. So hypertransmission manually with me correct the slabs. Important one is the projection artifact. A lot of times the superficial vessel will give projection of the repressor. So a lot of times that this is the actual slab. It needs to be also corrected. So projection artifacts can be inbuilt, removed with the help of machines which actually give the algorithm to remove these projection artifacts. So here we can see this projection artifact. This is a superficial layer. If I look at the outer retina, it appears like this. But the moment I select this projection artifact removal algorithm, you can see that the same outer retinal slab behaves. So this is actually needed for interpretation. As mentioned, we can see severity of parts may be influenced by the type of machines, and we can see that superficial segmentation artifacts are more dependent on the type of device, and the frequency can vary in various layers. So there was an important study while done by this paper where they showed that the angio machine provided highest vessel visibility and fewer motion artifacts, and angio machine from these eyes achieved the shortest acquisition time. So tips to reduce artifact, these are last two slides. Patient preparation is very important. We need to see whether the ocular surface should be proper. Adequate pupil dilatation is what I would interpret, and undilated ones, but a lot of times it creates an artifacts. Fixation target should be optimized. Operator needs to be trained properly, and alignment and action of the OCT beam may be judged by checking the retinal B scans. So we have to take the images, then we have to evaluate all the automated segmented layers and correct them manually if required. Usually I use the thin slab to localize the lesion and increase the slab width to incorporate the more data subsequently. So this is the flowchart of how one should take the OCT angio interpret or correct interpretation for that. Thank you very much.
Thanks, Sushan. Nice overview about the OCT angio and artifacts. Would request Dr. Parth to give a moment to
We conclude this session, and we request all speakers to come on the stage for the session.
Good afternoon, everyone. It's nice to see at least few people in the hall, and I welcome all the panelists of the session to be there. Dr. Madhav Solani, Dr. Ashish Patwa, Dr. Mohak Shah, Dr. Mohit Asharma, Dr. Dhaval Modi, Dr. Alpesh Shah. Dr. Ashish, sir, and Dr. Mukesh. I think we can get the sir if we can. Yes, sir. Thank you, sir. We'll start with the first, which is
Welcome.
So, I would thank all Gujarat Ophthalmic Society, and Dr. Path Rana, Dr. Jagdish Rana sir, and Dr. Ramanus sir to give this opportunity. So, this is the case of a patient who presented with artisan lens, which is not very common nowadays. Looking back into the history, it is originally known as West Fechner Claw lens. Definitely, you have known this as a primary career. Invented in 1978 by Dutch ophthalmologist Jan West. He invested iris fixated lens after witnessing poor rural patients in Pakistan who were left aphakic and not even given any rehabilitation. Medical PMMA is attached in mid-peripheral iris via enclavation. So what is the thing which made those lenses to come back again? So these lenses made their again appearance into field of ophthalmology as a anterior chamber phakic lenses. FDA approval for myopia models were granted in way back in 2006, and it was the first phakic IOL which was used in USA. And mainly used for high myopia, keeping into the fact that they have the bigger AC depth, and this lens, though it is made up of PMMA and will not disturb the endothelium. That was the whole logic about it. So I'll show you the video. I'm just muting it, and let's go through the video. There was a patient who came into the OPD way back from Mombasa, and he wanted, to check what can be done in his eyes. He had iris flow lens and cataract. There is a large PI we can see. There was a degeneration in the macula which was associated with myopia. There was a lot of bumpiness. It was glaucoma, but it was well managed. There was OCT evidence of the weak retina. When we did biometry, this was a minus IL power calculation which was coming. So, looking at the picture intraoperatively, this is the lens which is very much sticking to the iris since many years. So when we have to do phaco, it is always better to use this lens as a scapegoat rather than removing it, because this is the 5.5 mm lens. Lateral tunnel prior to the phaco, you'll be able to. Under this lens, we are doing the rexis, and visibility is very, very important. This patient had a grade 2 vertical component of the cataract, so we question of the small pupil or very, very dense brown cataract here. So minimal hydrodissection, and these pupils will not dilate that great. Reason being that iris is irritated since many years, and so slow phaco, we get a lot of use of the cohesive and dispersive viscoelastic, mix of every viscoelastic available in the is the key thing for this. Keeping the fluidics bit low so that you don't create the intraoperative syndrome, because that is again expected in this patient. There is a large PI which can also not be very much favorable with the very fast usage of the low level education aspiration, and making it customizable as per the type of the lens matter which we remove. Now once INA is you can see that pupil size is going down and down, and there is some of the epinucleus which is here and there behind the iris. So somehow we have managed to, remove this lens without creating any complications. And I am putting the intraocular posterior chamber lens below this artisan lens so that when we remove it, it does not damage the posterior capsule. So now comes to the, after the removal of the remaining lens matter, now comes to the question of how do we remove this. We had two choices. We could have made the tunnel and opened it later, but I opted for not doing that, considering the...
I thought it is...
No. It is a PMMA lens and it is like a Vers-Daljit IOL only.
Okay.
But the design is modified by Ophthatech USA to make it use for the...
Please, sir. Meanwhile, I would request Dr. Jodani sir to memento to Dr. Neera.
Good afternoon. I am thankful to Gujarat Ophthalmological Society and Scientific Committee Chairman for giving me this opportunity. Today I am going to speak a presbyopia correction by in focus in cataract or refractive surgery. As we all know, presbyopia correction is gaining momentum. So as patient expectations are also rising, and we are also making much comfort to offer the best to our patients. So clear vision over varied range of distance, that is what we and patient want. Looking to the presbyopia correcting IOL, we all know that multifocal and trifocal lens has answered most of the things. But halos and glare and dysphotopsia has raised the concern. Accommodative IOL are not much in practice, and there comes the EDOF IOL, which is I am going to talk, and that is in focus lens, which is an EDOF lens, which is designed for providing distance and near vision. It is a new generation yellow chromophore. It gives elongated focal point, which gives functional visual range with distinct distance vision and near vision. So what is EDOF? It is an extended depth of focus IOL, and most of these EDOF are giving distance and intermediate vision clearly, and you require some near correction. Here, a small aperture is kept on the IOL in the center, and the width of this elongated channel will decide the image sharpness, whereas the length of this channel will decide the range of distance which patient can have a good vision. There is a small aperture of a refractive element forms an EDOF channel, which increases the depth of focus. They claim that it gives up to plus 3.5 addition. So what we get is a range of vision, crystal clear distance and near with good intermediate vision that improves functional visual ability. With bilateral implantation, it works cohesively, works with neurological adaptation to brain, which results in much better vision distance, intermediate and near. As showed here, the defocus curve answer that the defocus curve of the suprafocal in-focus IOL demonstrate a crystal clear distance and near with functional intermediate vision. It is from Appaswamy. I don't have any financial interest in that, and they claim that each and every supraphobe IOL is individually tested to have a fixed and correct power and quality. Looking to the MTF graph, this supraphobe in focus delivers 30% better image contrast, which usually we lose in EDOF or any multifocal IOL, even in scotopic conditions, while offering low incidence of dysphotopsia. With the newer model, it is almost none. As far as haptic design is concerned, it is a flexi-fit haptic design and has excellent resistance against bank compression and maximizing the shrink wrap effect post-surgery, thereby reducing the chance of PCO. it can adapt various bag size in our day-to-day practice. The unfolding is very easy and not that slowly or not that even fast. It has a very good centration. This is an aspheric lens, so it gives an aberration-free image. Suprafob in focus has a negative spherical aberration of 0.23, which takes care of corneal positive aberration, which we all have. As you all know, 360 square edge, which prevents the posterior capsule opacification, and this is very important. This is in the optic as well as the haptic. This is a chromophore material, which prevents the, as we quoted, the ARMD formation in the geriatric patients. It has blue light filtering properties, which partially allowing blue light to reach the eye, which helps in maintaining the normal circadian rhythm in individual. Light distribution curves very well show that it blocking the harmful UV rays, while partially lights that compared to a clear lens which does not have much impact on UV filtering or blocking. This is the specification of the lens, but the diopter range which they have a normal reach on the center, which they remove recently, that it gives it doesn't give any glare on halos, and practically there is no complaint of dysphotopsia with these lenses. And when you want to see that where is the central they kept, you have to tilt the lens. Some of my patients, I have just showed the autoref readings. This is a 67-year male patient. He's 6'6", J1, very well satisfied, and you can see the autoref reading also. This is Jaspal Kaur patient with bilateral glaucoma, well controlled. PB prophylactic iridectomy have been also done. She has undergone both eye implantation of these lenses. I kept her minus 0.5 to minus 0.7 deliberately because she is a housewife, and she got a little distance vision, 6'9", but very well near vision. So most of the EDOF lenses which are available, they claim that you need +1, 1 to 1.5 in most of our patients, where in focus hardly needs any correction, and any multifocal or any pressed myopia correction IOL, patient just say that they don't want glasses. I think this IOL fits in all the categories where you have a good near vision and there is no dysphotopsia or glare or halos. Thank you very much for your kind attention.
Thank you so much, sir.
Salvation of intumescence. This is a normal anatomical structure of the eye. When the cataractus changes starts, the nucleus sclerosis occur and the entire lens nucleus swells, which leads to raised intralenticular pressure. Ultimately, it causes forward bulging of the lens and the shallowing of the anterior chamber. Various challenges that we face in an intumescent cataract are shallow anterior chamber, absence of red reflex, egress of the cortical fluid, increased intralenticular pressure, fragile calcified anterior capsule, extension of the capsule which causes Argentinian flex sign. All these leads to a difficult capsulorhexis, and ultimately we'll end up into a situation called Argentinian flex sign, which further complicates our surgery. Commonly adopted precautionary measures are preoperative intravenous mannitol injection, which decreases the vitreous volume, highly coercive viscoelastic substances, which forms the anterior chamber, two-stage rhexis, depressurizing the posterior compartment, and phagocapsulotomy. Despite all these things, the rhexis gets extended. So we further dig into the literature and found that there are basically three types of white cataract. One is without fluid, there is entire nucleus with minimal fluid. Another one is a Morgaggian, where there is a small nucleus and a large fluid-filled bag. And third one is with a nucleus and the fluid. Over here, the nucleus causes equatorial block, and there are two independent
anterior and posterior subcapsular spaces, which are highly pressurized space. So when we open the anterior rhexis, the anterior space is neutralized with the anterior chamber. However, the posterior space the fluid cannot go from the posterior space because of the equatorial block. This pushes the nucleus forward and it causes extension of the capsulorhexis. So we studied the vector forces that are working in a capsulorhexis method. First one is from the force from below, the posterior of the lens. Another one is in the direction of the zonules, and third is in the direction of the tear. We cannot touch the second and the third force, but the force which is coming from behind can be neutralized. So we tried to act against this force and devise a technique called inverted flap rhexis. So the video. Normally in a capsular rhexis, the capsular flap is raised and the direction of tear is in upward and in a curvilinear direction. However, in inverted flap rhexis, we invert the flap under the capsular margin and the direction of tear is downwards and in a curvilinear direction towards the center. So here are the case in which preoperative intravenous mannitol injection has been given, side ports and the main port are been done, capsule is stained with a trypan blue dye, and then capsular flap is raised with the help of a cystitome needle. Then with the help of McPherson forceps, we make a small rhexis, and then the entire rhexis is not completed and we leave behind some part before ending the rhexis. After that, we invert the flap under the rhexis margin. We invert the flap and the direction of the tear is curvilinear and downwards towards the center. We have to grasp the flap at a smaller junction to get the better hold of the technique. At each step, the direction of the force is downwards and towards the center in a curvilinear direction, keeping the flap inverted under the rhexis margin. Another case where a small flap has been left after doing a small CCC, the flap is inverted under the rhexis margin and then the direction of tear is downwards and towards the center in a curvilinear direction. Grasp the flap at smaller junction to get the better hold over the rhexis. This leads to successful achievement of a round rhexis in a case of intumescent cataract. It can even be used to enlarge the rhexis in certain cases. So it's a novel technique for performing safe rhexis in the intumescent cataract. It provides a new domain for exploring the vector forces that are acting during the additional instruments, and it is relatively easy to master. I have published this technique in Indian Journal of Ophthalmology, and the video can be accessed from the site of the journal. Thank you.
Thank you, Aarti. I would request Dr. Neera to present memento to Dr. Aarti. And now next speaker, Dr. Ravish Kinkapwala, very young and dynamic surgeon of Ahmedabad, and he will be speaking on satisfying patient need by choosing the best PCIOL.
Good afternoon, everyone. I'm Dr. Ravish Kinkapwala, cataract and refractive surgeon, and I'm going to speak on satisfying the patient needs by choosing the best PCIOL for the patient. I'm going to be very brief. The mandate is for 6 minutes, so I'll just cover the basics of the concept. 6 points. The first point is the art and science of consultation. We understand the optics of the patient's eye and the optics of the IOL. 2 concepts, the trade-off and the plus or minus 0.5 blur. And finally, implementing these principles into some of the interesting cases and the use of the premium IOLs. For all of us as cataract surgeons, the holy grail is one type of IOL should fit or meet all the patient's needs and the expectations. We are yet to achieve that, and that's why we have this presentation. The first principle is a consultation. Get the basics right. Address the primary 4 points of successful consultation. The patient needs. Does patient actually need the presbyopia correction? The second, expectations. Under promise and over deliver, we all know. Set the right expectations. Does the patient have any other concerns? And of course, the hidden agenda, especially if the patient is looking for second opinion, right? This patient just has come for the second opinion. Just look for those hidden agenda as well. Patient may be knowing about all the types of dysphotopsias as well. Chair time is important. As we all know, the more the chair time, the better the trust that patient develops for us. Document the discussion, choice of IOLs, and the expected outcomes. Give the patient information leaflets to the patient, consent forms, and the IOL details. Summarize your consultations, and give the option to the patient if further consultation with respect to the choice of IOL is needed. More the patient knowledgeable and aware preoperatively, the better patient-related outcomes from. That is 20 by happy patients and not just 20 by 20. The second optics of the patient's eye. We need to understand the optics. We have so many topics. I'll just brief the headings. Whether the patient has undergone refractive surgery, the dry eye, the most important refractive power of the eye, that is the tear film, ocular comorbidities, astigmatism, whether it's regular, irregular, with the rule, against the rule, calculated SIA, very important. We should know whether we are checking the PCA or not, predicted or the measured, either way. Binocular patient or uniocular. Binocular summation always helps the patient. Check for angle alpha, kappa, chord length, corneal topography, higher order aberrations, pupil size, both the mesopic and the scotopic. We should understand the optics of the IOL as well, because we need to match both the optics of the patient as well as the optics of the IOL as well. The first thing is as the sir mentioned, the modulation transfer function for the distance, intermediate, and near. Especially check for all the graphs, the parameters such as the cycles per degree and the aperture size. The IOL designs, the lens that you are going to use, you should know thoroughly about the lens design as well. The diameter of the central part of the IOL optics. The A constant. Standardize your own procedure, get your own A constant, that will give you better results. We are talking about plus or minus 0.5 blur. And finally, when the neo lens comes, they come up with a study design. The devil lies in the details. Understand the nitty-gritty, what they are comparing with. Are they comparing the uniocular vision, binocular vision, the contrast settings, the cycles per degree, the pupil size, the corrected distance visual acuity, the uncorrected, and all that stuff. Just go into details of all the parameters. I'm going to discuss a couple of lenses that I have interesting. So we are going to implement all these principles into some of the interesting cases. So two lenses I've been presenting, I'm going to present. One is the VVT and another is the panoptics. This is the VVT design, the wavefront shaping technology. Very nicely mentioned in the second slide. As you can see, it's nothing but the shape of the wavefront has been changed. The optical path difference, especially for the central 2.2 mm. And ultimately, that causes a delayed wavefront and an advanced wavefront. And that gives a depth of focus, a continuous range of focus, of course, with a slight loss of contrast as well. Similarly, we have a panoptics, a diffractive type with enlightened technology, 3 focal points, infinity, intermediate, and the near. 50% light distributed for the distance, 25 for the intermediate and the near. So basic idea you should have about how the lens works, and then we superimpose that particular details with the optics of the patient as well. Understand the trade-off concept, because every lens, it has its limitations. So it's important for the surgeon to explain the trade-off and ensure the patient understands the limitation of the lens, not the advantages. And remember the 4 M's. Male, moderate myope, middle age, in 40s. They appreciate the loss of contrast much better. And always aim for ametropia. Sometimes the MTF is slightly better on a hyperopic side in some cases. Just check for those particular graphs. Visual degradation is highest for lower order. Just check for the correct the lower order aberrations first, and then look for the higher order aberrations. Applying those principles into some of the very tricky cases. This is the case one where I used the Alcon panoptics in previously hyperopic LASIK, a 70-year-old male patient, very active, still plays cricket, wants spectacle independence, hyperopic LASIK done, known diabetic, but having no other cochlear diseases. And as grade 2, these are the patient's findings preoperatively. The flap was okay, preoperative reflections, LASIK, prior to LASIK, and then now, right now, after the LASIK, this is the refraction. Patient underwent the toric trifocal. This was against the rule astigmatism. I've gone through all the pentacam reports and all, went for the toric, even though it was 0.5, against the rule astigmatism, to go for the toric lenses. The toric panoptics in both the eyes, and this is the both eyes, 6x6 aided and 6 unaided. Patient is pretty happy. Reasons: patient's personality, not a type A personality, easygoing. Even after probably a year, I asked the patient, what's this photopixel light? Patient says, I can see 3 or 4 lines, halos around the light. That's perfectly fine. But then the patient came 3 years down the line, the new adaptation set in. The patient says, I hardly appreciate that. The second, what worked in this way? There are a couple of slides for that. I think I'll just go through it. Another case of alconvivity lens in the, again, previously operated RK. What's interesting? 47, male patient, again, 2 M's into this. Obsessive compulsive disorder. It has a compulsion to get rid of near glasses. This patient went all the way to Delhi as well, went to all the hospitals. He wanted to get rid of glasses. Everyone told he has to go for a This is a previously preoperative data, and the patient has 3 RK marks, not significant, 4 and 5 RK in the other marks. We went for the non-toric VVT in the left eye and the toric VVT in the right eye. And most operatively, if you see 6x unaided, both the eyes, and 8 parts at 40 centimeters, and N10 in the left eye. But when you see binocularly, you can appreciate it is unaided 6x4 and N6. And the AR shows -1 because of the central optic. Thank you.
Dr. Bhomik, please accept memento from Dr. Bhomik. So now we are ending the session, and thank you all for your patience.
Invite the next session's panelist and chairperson to come on the dais, and we can have one group photo with all the speakers, please.
I'd like to invite our next session Chairperson Dr. Santosh Sonawar sir, Dr. Jagdish Rana, Dr. Darshan Bhavasi, Dr. Rupesh Shah, Dr. Mukesh Patel, Dr. Ashish Saxena. Dr. Patrana, you can come on the stage for the panel. Devang sir, please. Dr. Rakesh Patel sir, please join the stage. And Dr. Mukesh Chaudhary, you can also come. Doctor.
I invite Dr. Chotale sir to deliver lecture on the decent, discipline, and dignified retirement.
Good afternoon to all. First of all, I would like to thank organizing committee as well as the executive body of AGOS, especially scientific committee chairman, Dr. Sandeep, Dr. Jagdish, Dr. Brahmbhatt, and all. First of all, I would declare that I am not an authorized advisor for investments. My attempt is to make all colleagues, especially youngsters, aware of ups and downs of life without affecting our lifestyle with adequate family and social obligations. And there is no any intention to boast about myself. These three legends, my teacher, Dr. Mathur, late Dr. Mathur sir, and then Dr. Nagpal sir, late Dr. R.S. Kazi, all this have inspired me how to begin earning career, how to maintain it with dignity without stress, and how to be prepared for pleasant retirement. Shall we retire? If yes, then when, why, how, and where? It is not the age, but income is more important. It shall be planned after having sufficient financial securities to combat for spending the rest of the life with the same lifestyle. It should be progressive and no abrupt. It shall be neither impulsive nor compulsive. After working for so many years, we get physically as well as mentally tired to do the things that we have always wanted to do but couldn't do due to so many responsibilities. That's why we should retire. And how? Retirement has to be happy, healthy, and wealthy. We shall use this time to enjoy ourselves and experience what life has to offer outside the office. And where? It should be preferably at a place where we have social associations and attachments, maybe native place or where children have settled. What is retirement? It is the time that is all of our own, when responsibilities are minimized. I will not say nil. As until retirement, we are either under the control of parents or a boss, or we are responsible for our children, employees. What to do during retirement? We might have spent majority of our years in planning, saving, and making money by working hard in our career. Our job might have been our passion, but it is now the opportunity to find new passions that leave us with contentness without a paycheck. We shall create stronger bonds with the people around us, challenge our body and mind with new and exciting activities, which can be a vacation somewhere with the friends and family, maybe relaxing with grandkids or adopting back a long-lost hobby. What did I do for my retirement? Preparation for the old age shall be, it should begin not later than our youth. Life which is purposeless until 60 will not be suddenly becoming fulfilled upon retirement. So I started enjoying vacations with my family, of course within my reach. From my earlier years of private practice, even though many of my friends were considering me fool for wasting earning potential period in spending to roam here and there. I started in those days monthly recurring deposits, which were tax-free and were yielding good interest in those years, before 40 years, what I am talking. So I have opened some saving account that was pygmy account in Nationalized Bank. Also started recurring deposits and all these things. And I also opened PPF for 30 years. Then I started purchasing this, investing in SIPs before 20 years. And I repeat that this is the best option and safest option for the newcomer, the SIP, and it will be yielding after few years a lot. I started applying for IPOs, which was not as cumbersome as now. And then I invested in purchasing a great company shares after introduction of Demat account on regular basis. I started purchasing 5 Reliance shares every month, and say before 25 years or so. So I can say openly, because you are my own, that I have 5,000 Reliance shares now. I'm an investor, never daily trader. One of the biggest and common mistakes people commit in capital market is daily trading. Of course, I booked profit at certain levels, but I followed the reliable advisor whom I used to pay their fees. I didn't think of investing in lands due to fear of indulgence of antisocial elements occupying our land and extracting our profits in getting rid of them. When we do not make our goal to run after money always, we have opportunity to enjoy our lives simultaneously. Otherwise, money that you make might remain just unused or may create unnecessary expectations among your offsprings. I always spend my most of the time laughing with my friends, colleagues, family, and hence remain stress-free always and to have quality life. I am intending to follow the same lifestyle for the rest of my life so as to live without stress or illness. Always invest in health policies from the beginning of the earning career, as health services have become quite costlier. One should be a member of FBS scheme without failing. Over and above, we should have our LIC policies. Of course, I have not retired fully. I have converted myself into medical ophthalmologist ever since we faced COVID. And I have discontinued doing any surgery. But by the grace of God, I am still comfortable with 40%. Few suggestions. Retire from the work, but not from the life. Start thinking about retirement before boss does. Start thinking about where to invest money and how to get good returns as soon as our earning career starts. Find your hidden passion before you retire and do things that you always have wanted to do. Do not simply retire from something, but do have something to retire. Person can't retire from his experience. One must use it. Experience one can achieve more with less energy and time. Retirement is the end of one inning of the life and beginning of the next one. First, before I conclude, I will say that I decided to retire from the beginning of my private before 42 years because I was the 6th ophthalmologist in Junagadh at that time, and Dr. Kazi, he was the senior most ophthalmologist. And his practice was so much that I used to tell him that, Sahib, ek baju gam ne ek baju ram evi paristhiti hai. And he was very clever because he could afford. He selected, in those days there were no IULs. So he was choosing the simplest, most mature cataract, and he operated them only, and otherwise he used to refer either to Rajkot or Ahmedabad or somewhere. But those type of patients came to me, and by the grace of God, I learned all this complicated management of all these complicated cases, and I did operate, and the patients were comfortable. Then what, they said me, કે સાહેબ આમ તો અમે છે ને કાજી સાહેબ પાસે જતા પણ સાહેબનો હાથ ધ્રુજે ને એટલે તમારી પાસે આવ્યા. એટલે મને ત્યારે જ વિચાર આવ્યો, I had a click in my mind કે either these people or their hair will talk the same about me after 40 years. So before they start talking like that, I should get retired. So one is never too old to set a goal or new dream. There is whole new kind of life ahead, full of new adventures, experiences just waiting to happen. It is a bliss rather than a retirement. Retirement is wonderful if you have two essential things: much more to live on, or much to live more. It is an easy and relaxing time of our life. We shall retire wealthy no matter where we are in our life. Good health, good relations, good virtues, adequate wealth are important for peace of mind during retirement. Plan well, no fear, no tears, year must life with cheers. I wish you all happy retirement whenever you decide to go. Last thing, I have kept this, because I like these words of Dalai Lama, so I have kept in my consulting room since 40 years. A person asked God, what surprises you most about mankind? God answered, they lose their health to earn money. They lose their money to restore health. And that by thinking anxiously about the future, they forget the present such that they live neither for the present nor the future. that they live as if they will never die, and they die as if they had never lived. So thank you all for patient hearing, and that too without after postprandial snoring. Thank you.
થેન્ક યુ ચોટાલા સાહેબ, બહુ સરસ છે, બહુ આનંદ થયો સાહેબ. એસઆઈપી આટલા વહેલા સ્ટાર્ટ કરી આવજે, અમે લોકો એક શરૂ કરવાની જરૂર છે સાહેબ. અત્યારે કયો સાહેબ લઈએ સાહેબ? બોલો. I invite Dr. Parth to give the talk on re-imaging relief with the cyclosporine. I invite Dr. Jagdish Rana to come on the stage.
A very good afternoon, everyone. I hope I'm not kind of bothering everyone before the lucky draw. I'll just quickly finish my presentation. So nowadays, everyone sees dry eyes. Like even like whatever happens, like at least 50% of the patient, either they are for retina or not. But I am also seeing dry eye cases every day. So whether I'm treating them for anti-VEGFs or I am treating them for something else, but they always have issues for dry eyes because they the screen usage no one can avoid nowadays. So like if a patient comes to me and if I am prescribing only one lubricant drop, which has already been prescribed by a just pharmacy store or a GP, then what is the difference? Here is a new drug which really affects in dry eyes, and actually it works for a longer period, not only for 4 to 6 hours, which standard lubricant works. So here I'm going to talk about the cyclosporine A 0.5%. It significantly increases the tear production. It can increase the tear production in patients with suppressed tear production due to ocular inflammation associated with the keratoconjunctivitis sicca. So main benefits, if we see, the symptom severity decreases by 30% after 30 and 60 days of use, and the onset relief was observed within 1 week in 32% of the patient, within 3 weeks in 73%. So the real world setting showed the cyclosporine A 0.05% is an effective treatment for KCS in patients with relief onset potentially faster than the reported in other studies. So if we see shimmer test and the tear breakup time, the baseline month 4, 8 and 12, this chart shows there was a significant improvement in that. And if we start the early treatment, like if a patient is coming for first time and the symptoms have started, by that time if you start the treatment, the effect is really good. So here are some case reports. I won't bore you with that, but the basic is for adenoviral keratoconjunctivitis related subepithelial infiltrates. In this kind of cases, this drug works wonders. Similarly, if we see early neurotropic keratopathy, the similar thing is there. Cyclosporine A 0.05%. The ophthalmic solution specific nanoemulsification twice a day works wonders. So the recent evidence of the efficacy of cyclosporine A in different forms of dry eyes. We'll discuss here about the primary Sjogren syndrome associated dry eye. At 2, 4 and 12 weeks, the cyclosporine A significantly reduces the OS-DI scores, decreases the OSS and increases the tear breakup time and shimmers also. So basically, in smile procedure or the LASIK procedure, the results are same. Post LASIK procedure or smile, usually we prescribe only lubricant drops. But if we prescribe with cyclosporine, it works wonder in that. So cyclosporine helps reduce the inflammation underlying the dry eye disease and stimulates the tear production and reduces the need of artificial tears. It can reduce the blurred and poor vision and significantly improve the day-to-day visual functions. The occurrence of AEs is lower in patients treated with cyclosporine compared to the treated with cyclosporine 0.1%. And cyclosporine can alleviate signs and symptoms of dry eye disease at all severity levels. It can improve tear film stability, shimmer score, corneal staining, and conjunctival goblet cell density. It is effective and safe treating patients with KCS and primary Sjogren treatment-associated dry eye. And early treatment with cyclosporin may lead to improvement outcomes and has been found to be most effective commercial formulation for reducing the OSDI. Thank you.
I invite Dr. Labdi Shah. Is there Labdi is there? Dr. Manisha Devani. Dr. Mauli Shah. Yes, come on stage. Dr. Neha is there? Neha, yes.
Good afternoon, everyone. Thank you, Gujarat Ophthalmological Society and Scientific Committee, for giving me this opportunity to present on this stage. I would like to start with the topic, approach to a case of pediatric uveitis. So we all know that pediatric uveitis is a silent threat, and treating it is like a maze of roads. It needs a systemic stepwise approach based on clinical and scientific evidence. Now let's say, what makes children so vulnerable? They have poor symptoms reporting, they lack vocabulary to describe visual symptoms, a gradual adaptation, so slow progression allows neural adaptation, suppression of the affected eye hides vision loss, and that is amblyopia masking. And usually uveitis is a bilateral disease, no comparison point when both the eyes are affected. So I have divided this presentation into 4 main points. First is pattern recognition, second is examination, third is investigation, and the fourth checkpoint is treatment part. Starting with the pattern recognition, this was 8-year-old female presented to a rheumatologist with complaint of joint pain and swelling in right knee. She did not have any pain or redness in the eye, and she was referred to us by a rheumatologist. On examination, we could see that she was suffering from non-granulomatous anterior uveitis and she was having posterior synechiae. Posterior segment was quiet. So she was diagnosed with JIA-related anterior uveitis. As we all know that JIA is one of the most common cause of non-infectious uveitis in children. So risk of developing JIA-related uveitis depends on the main 4 points. Category of arthritis, ANA positivity, JIA onset, and duration of JIA. For example, if a female patient is presenting, less than 4-year-old, presenting with oligoarthritis and she is having ANA positivity, JIA onset less than 6 years, then chances of developing JIA-related uveitis will be more compared to polyarthritic patient. So screening is important every 2 months for the first 6 months in JIA patients, and then every 3 to 4 months till recommended. This was another case of 5-year-old male presented with diminution of vision in both eye for 1 week. So he had both eye granulomatous keratic precipitates over the endothelium, also angular capes and posterior synechiae. Posterior segment was quiet in both the eyes. And on systemic examination, we found out that the child had swelling in the small joints of the hands, and there was maculopapular rash over the chest. On investigation, he was RANM onto negative, and then turned out to be, this was a Blau syndrome. So it is a classical triad of granulomatous anterior uveitis with arthritis and skin rash. This was another case. 13-year-old girl presented with diminution of vision in left eye for 8 days. She gave history of contact with pets. And on examination, right eye, there was, both eye disc was fine. And right eye, there was scar supratemporal to the macula. And in left eye, we could see that fog light in head appearance. There was retinitis involving the macula. And with the help of OCT, we could see that it was retinochoroiditis involving the retina and inner layer. So this was a case of toxoplasma retinochoroiditis. The pattern recognition also gives us clue in pediatric cases. And now always think about masquerade. If a child has atypical presentation or he has poor response to conventional therapy or worsening despite treatment, because masquerades are also can present as uveitis in children. Coming to examination part, I have made mnemonic vision to remember each step. So first verify comfort. Do interaction with the child and make he or she comfortable first. Then inspect. Always do examination with dilatation and check both the eyes. Even if a patient is having uveitis in single eye, always check for both the eyes. Always take help of scan if a child is not cooperative for clinical examination. Nowadays, optos or any wide field imaging systems are there, so we can also take advantage of that. Always check IOP in each visit. Please offer steroid sparing plan. Though acute inflammation is always controlled by steroids, but always go for steroid sparing plan in future. And encourage child and as well as parents to never miss the follow-ups. Coming to the investigation part, we have divided into two parts, ocular multimodal imaging and systemic examination. So with the multimodal imaging like wide field FFA, photograph, B-scan, we can reach to the diagnosis. And with systemic investigation, we can confirm the diagnosis. I'll just run the slides. Coming to the investigation part, mainly with non-infectious uveitis, plus see that uveitis is anterior, intermediate, posterior, or pan-uveitis. This is a very good flow chart from an article by Nugent et al. And let's say if a child is having anterior uveitis and that is non-granulomatous, then think about most common diagnoses like GIA, then enthesitis-related uveitis, and then think about Behçet's or other things. And coming to the treatment part, all the pediatric uveitis acute phases are treated with topical and oral steroids, but please keep your aim to stop by 3 months minimum. Prefer IV bolus instead of oral in case of recurrence, and IOP monitoring on each visit, because child can become steroid responder in later stage. So I'll just skip this. This is the important thing, that start with the steroid. When it is very severe and sight-threatening disease, always shift to immunomodulatory therapies and biologics. And we should take help of rheumatologist and pediatrician dermatologist. It should have multidisciplinary approach and consider family education and support. So monitoring and follow-ups are the most important part in pediatric uveitis. And with this, I would like to end that screen systemically, examine thoroughly, test smartly, treat early, and monitor lifelong. Thank you.
Thank you so much for the wonderful presentation. Now I have to invite Dr. Pooja for the next talk. Dr. Neha Agarwal for corneal karma.
Good afternoon, everyone. Thank you, Scientific Committee, for giving this opportunity. And it's good to see so many listeners for this penultimate presentation. This is a short video. It has a pre-recorded audio as well. It's a case presentation about a patient who underwent a phacoemulsification surgery, and the patient had a history of refractive surgery. Let's see the video. Please play the video. Please play the audio of the video.
That was suboptimal. Post-hyperopic LASIK base that reminded us that the most powerful diagnostic tool in medicine is not a machine. It's history. A 50-year-old Irish woman walked into our clinic with a simple request. I don't want to wear glasses anymore. She is active, independent, and very clear about one thing. She wants freedom from glasses for both distance and near.
So as we can see, the patient had a mixed astigmatism and presbyopia. She is a 50-year-old lady.
refraction, she shows mixed astigmatism, a plus spherical component with a minus cylinder, along with a near add of +2 diopters. She gives a history of LASIK done 20 years ago. No reports, no records, just memory. Considering her age and presbyopic status, corneal refractive surgery was not ideal. After detailed counseling, we advised refractive lens exchange. Given her astigmatism and desire for spectacle independence, we planned implantation of a refractive presbyopia correcting toric IOL, aiming to address distance, astigmatism, and functional near vision. The surgery was uneventful. On post-operative day 1, the toric component performed exactly as planned. The cylindrical error was fully neutralized. However, there was a refractive surprise, which was clinically meaningful. We revisited the history. During a more detailed discussion, the patient mentioned something she had not said earlier. After her LASIK surgery years ago, she had been told that the effect would last only a few years, and that she would eventually need glasses again. That statement raised an important red flag, because this pattern is not typical of myopic LASIK. For the first eye, IOL power calculation had been done assuming prior myopic LASIK, using the ASCRS IOL calculator by Warren Hill et al. And Barrett's formula. For the fellow eye, we reassessed. We factored in the refractive surprise and recalculated IOL power assuming prior hypermetropic LASIK. A modified IOL power was selected for left eye. The result, 20/30ths distance vision on day 1 in left eye and a satisfied patient for near vision. We asked her to use glasses for right eye vision while driving as she was leaving for Ireland soon. 3 months later, she returned from Ireland for a week. The interocular difference was now evident because she could not adapt to the imbalance. The first eye had significant residual refractive error. The second eye was doing well, but she did not want to use glasses all the time. So we discussed with her and proceeded with surface ablation to correct the residual refractive error in right eye under guarded prognosis, while preserving a degree of functional monovision. She adapted well and returned back satisfied. So what was the reason behind all this? At this visit, she had brought something with her. Her original surgical records from 2006. The diagnosis? Mixed astigmatism with a plus spherical and minus cylindrical component. In other words, she had undergone hypermetropic LASIK with cylinder correction. The surprise we saw was bound to happen. Presbyopia correction after refractive surgery remains highly challenging. A thorough preoperative history is of utmost importance. Assessment of ocular dominance is essential. Unfortunately, in this case, the patient experienced a myopic surprise in her dominant eye, which significantly affected her satisfaction. Intraocular lens selection after hypermetropic LASIK must be approached with extreme caution. We implanted an IOL with negative asphericity of -0.27 micrometers, which in retrospect was suboptimal. Post-hyperopic LASIK corneas already exhibit negative spherical aberration, and the addition of a negatively aspheric IOL can exacerbate optical imbalance. Equally important is patient counseling. Adequate chair time spent explaining prognosis, understanding patient expectations, and aligning them with achievable outcomes is invaluable. Patients should be clearly informed about the inherent limitations of IOL power calculation methods and currently available diagnostic devices in post-refractive surgery eyes. It is essential to emphasize that a secondary refractive enhancement on the cornea may be required. In conclusion, this case reinforced several key lessons. Presbyopia correction in post-refractive surgery eyes remains unpredictable. When historical refractive records are unavailable, sometimes the best decision is to wait. This is a case that reminded it.
Yeah, so I did not purposefully show any surgical step because it was a textbook surgery. The main key point is that even if a surgery is well performed, there can be surprises, and that is why we need to focus on all the other factors, especially on a post-refractive surgery patient. The correct biometry is important, but till date we do not have an ideal biometry for ideal IOL formula, calculation formula for a case with mixed astigmatism, or with the history of refractive surgery performed for mixed astigmatism. Checking ocular dominance is very important, especially if you are planning for a monovision or a micromonovision. And we got away with this case because we had thoroughly counseled the patient what to expect and to expect surprises, in fact. And if you noticed, even if we changed the formula to post-hypermetropic LASIK, there was not a significant difference in the IOL power that the formula was suggesting. So we had to kind of titrate the formula, titrate the IOL power based on our clinical expertise. So all of these factors need to be considered post-refractive surgery patient when they present for a refractive lens exchange.
Thank you. Thank you so much for the nice presentation. Now I would like to invite Dr. Jagdish Rana sir for his talk and the last talk of the last session of the last day, my innovated and patented double tooth phaco chopper.
Okay.
All the speaker of this session, please remain in the hall only. We'll be having this felicitation and memento presentation after the event, and we'll be having a group photograph also.
So, good afternoon, friends. This is the last lecture after 2 tiring academic sessions of 2 days. This is basically a video presentation. My innovative double tooth phaco chopper. It's not moving. Okay.
Innovative 2-point fixation complete phaco chopper. We have no financial interest whatsoever. Introducing a cutting-edge mechanism that will simplify the course of phaco surgery. Here is announcing the next generation 2-point fixation, a complete phaco chopper. The success of this innovative new product is such that it has acquired the status of a design patent, number 255048, July 2013. Thinking of an ideal chopper, what qualities do expert surgeons expect it to have? Which has all the characteristics of an ideal chopper, coupled with more features that makes it a hands-on equipment perfect for phaco surgeries. This chopper has been designed keeping ergonomics in mind. It has serrations on the handle of a stronger grip, a blunt neck to hold the eyeball supported by a blunt curve to stretch the pupil, and the USP of the next generation 2-point fixation, a complete phaco chopper that has a double tooth, unlike the regularly used single tooth choppers. A simple example can abridge all that has been said above. Take a look.
This small funny video, how it has been innovated.
Funny but true, a minute miss can cause an error of a lifetime. Putting this into real-life context, in the next generation 2-point fixation, a complete phaco chopper is useful in the following ways. Cracking the nucleus.
maybe hypermature or mature brown cataract. It easily crack the nucleus because of its double tooth, which are basically blunt at the tip. So there is no chance of damaging posterior capsule or delicate structure.
Chopping the nucleus and nucleus rotation. In a single tooth chopper, we have often seen that in hard cataracts, sometimes chopped hard and leathery pieces get locked with each other and are very difficult to separate. While in double tooth chopper, because of chopping done at 2 points, simultaneously, chopped pieces get widely separated, and there are less chances of getting it locked with each other.
This video I have presented in so many states in last 3 months. It was really a hot topic and it's a point of discussion to everyone regarding this double tooth phaco chopper. So you can easily chop, rechop and stuff the nucleus into the
removal of nucleus pieces, its rotation, stuffing and rechopping. Epinuclear rotation.
Even a soft epinucleus can be easily rotated. The same principle applies to the soft cataract also. By the single tooth chopper cuts to the soft lens matter, we can easily rotate and chop the soft nucleus also because of its double tooth. The principle is broad area of contact because of a double tooth.
Holding the eyeball.
Because a broader area at the tip, we can hold the eyeball and it does not come out easily. This phaco chopper. According to the Dr. Ronaldo from Singapore, it is here to cook this grooved nucleus into the two halves due to its broader area of double tooth phaco chopper that is used to push other separate and easy to chop when the two chopping tips are in line with a primary groove or a phaco tip, or we can say sculpt area. Our own Dr. Suhas Aljipurkar is also using in his each and every OT double tooth phaco chopper. This is a Dr. Toshihiko Uta from Japan. He has presented about this phaco chopper in multinational conferences very often. It has been also published in an ophthalmic surgical instrument book. So it's available in India as a double tooth phaco chopper by Epsilon and Apasami. And Dr. Ota from Japan has modified this double tooth phaco chopper and added one small projection at the base of a double tooth. It is known as a Rana Ota phaco chopper, and it's available globally without any royalty fee as a Rana Ota nucleus dividing hook by Duquette and Kent Limited, England, in titanium. Thank you. Thank you very much. Thank you.
Thank you so much, sir, for a wonderful presentation. Now I would like to invite all the speakers of this session to come on the stage for a group photograph and memento.
A couple of humorous things came in my mind just now. That extra thanks to Dr. Jagdish for keeping the bumper door at the end of this session so that I could have this much big learned audience. And another thing is that I told that during retirement, people should play with their grandchildren. You know, grandparents and grandchildren have great affinity for each other. Why? Because they have got common enemies.
Neha Agrawal. No. Thank you so much, everyone. Now we'll move forward with the most excited part of the event, bumper lucky draw. Within a couple of minutes, we are ready for the draw. We will be having trade partners draw also. So all the colleagues in the hall, call your other trade partners to join the draw for the trade partners also.
There are around total 50 prizes. I think 1 out of 2 will get the prize. Before we start lucky draw, there's one important announcement that હેલો ડૉક્ટર મોહક, ડૉક્ટર રૂપેશભાઈ, એક ઇમ્પોર્ટન્ટ અનાઉન્સ ઇલેક્શન માટે કરવાની છે. The date will be approximately in a third week of this month, and it will be done through the laptop or a mobile. So you will get a email regarding the election. Then you will proceed for a voting. You will get an OTP in your mobile, rather as a text message. So you have to fill that OTP in your email while voting, and then you will be able to vote. So both will work. Mobile is also needed and laptop is also needed. So email and text message both will be working during this voting. So you have to do online voting. That will be in the last week of this month.
અને એક રિક્વેસ્ટ હતી, આપણે ગુજરાતના 3 કેન્ડિડેટ છે. ડૉક્ટર જગદીશ રાણા છે, મેમ્બર સાયન્ટિફિક કમિટીમાં છે. ડૉક્ટર જીતેન્દ્ર જેઠાણી છે, મેમ્બર ARC વેસ્ટ ઝોન. અને માયસેલ્ફ ડૉક્ટર બ્રહ્મભટ્ટ દિવ્યાંગ, વાઇસ પ્રેસિડેન્ટ. 3ને 100% વોટ મળે એવી રિક્વેસ્ટ છે એસોસિએશન તરફથી, અને મારી પર્સનલ રિક્વેસ્ટ છે. અને ડૉક્ટર રાણાએ કીધું એ પ્રમાણે ઈમેલ આવશે. ઈમેલની અંદર તમારે જ્યારે લિંક ઓપન કરશો તો OTP આવશે તમારા મોબાઈલ નંબર ઉપર, એટલે SMS માં આવશે. એ નાખશો તો વોટિંગ થઈ શકશે. આ 2 સ્ટેપ મેથડ છે. પણ એ લોકો એક ડિવાઇસ કરી રહ્યા છે, કદાચ એકલા ઈમેલથી થાય એવું પણ કરી રહ્યા છે. એટલે પણ આપણે બંને વસ્તુ આપણી પાસે હાથ વગું હોવું જોઈએ. ઈમેલ એકાઉન્ટ આપણી જોડે હોવો જોઈએ અને આપણો મોબાઈલ જોડે હોય તો 100% વોટિંગ થાય. અને એક બીજી રિક્વેસ્ટ હતી કે અત્યારે આપણે આવેલા છે બધા આપણા ગુજરાતમાં 2000 વોટર્સ છે. આપણે અત્યારે હાજર છીએ ઓછા છીએ, તો રિક્વેસ્ટ હતી કે આપણે જે પણ સિટી કે આપણા ફ્રેન્ડ સર્કલ હોય એ બધાને 100% વોટિંગ કરે એના માટે રિક્વેસ્ટ કરી. તમે વધારે પ્રેશરાઇઝ કરી અને 100% વોટિંગ થાય એવી મારા રિક્વેસ્ટ છે આપને. થેન્ક યુ.
આપણે ગુજરાતમાં 2000 રજિસ્ટર્ડ AIS મેમ્બર છે. ઇન સ્પાઇટ ઓફ દેટ દરેક વખતે વોટિંગમાં 400 કે 500 વોટ જ થાય છે ગુજરાતમાંથી. દેટ ઇઝ ધ રીઝન કે ગુજરાતને ઓલ ઇન્ડિયા ઇલેક્શનમાં પોલિટિકલી વેઇટેજ મળતું નથી, અને આપણે ત્યાંથી કોઈ ચૂંટાઈને બી જતું નથી અને લડતું પણ નથી, રાધર કોન્ટેસ્ટ કરતું નથી. એટલે આ વખતે આપણે પૂરું જોર લગાવીને આપણે અને આપણા સર્કલમાં બધાને મોટિવેટ કરીએ કે બને એટલું મેક્સિમમ વોટિંગ થાય. તો એક રસ્તો ખુલશે, તો પાછળથી બી બધા યંગ જનરેશન છે એ બી આના માટે ગુજરાતમાં જતા છે. બાકી આપણે જોઈએ અત્યાર સુધીમાં ગુજરાતમાંથી આ રીતે ઓનલાઈન વોટિંગ થયા પછી કોઈ ઇલેક્શન ઊભું રહ્યું હોય જીત્યું બન્યું નથી. અને ધીસ ઇઝ ધ ફર્સ્ટ ટાઈમ કોઈ VPની પોસ્ટ ઉપર આપણે ત્યાં ગુજરાતમાંથી ઊભું છે. આપણે ત્યાં ગુજરાતમાં ત્યાં સુધી કોઈ પ્રેસિડેન્ટ બન્યું જ નથી. એટલે આ વખતે ઓનલાઈન વોટિંગમાં યંગર જનરેશન એઝ વેલ એઝ અવર સિનિયર જનરેશન બધાએ પોતપોતાની મહેનત કરી અને આપણા સર્કલમાં આપણા ગ્રુપમાં બધાને મોટિવેટ કરીએ કે મેક્સિમમ વોટ થાય એવું કરીએ. થેન્ક યુ. I will invite Dr. Hitesh Ramanu, Chair's President, to do a first cheat.
Yes, it is there for Portronics Keylink 4-in-1 multi-charging cable. 340.
340. Swati Ravani.
Dr. Swati Ravani.
Dr. Swati Ravani is here.
Not available.
The registered number is below your QR code. There are 3 digits. The last 2 or 3 digits is the registration number. So kindly
બધા પોતપોતાના બેચમાં જોઈ લેજો પોતાનો નંબર. 93.
Kishore Chaudhary.
Dr. Kishore Chaudhary. છે?
Not present.
Not present.
જલ્દી સર.
380.
380. પટેલ કૃણાલ
મુકેશભાઈ.
બધા જોવે છે મારું નામ
નથી. રેસિડેન્ટ
અમદાવાદને જવું જોઈએ. 91.
91.
sir, please.
Dr. Jayant Doshi.
બીજી ઉપાધિ છે
Next is 413. Same.
413.
Dr. Vora Sanketi Nimeshbhai. Is she here? નથી.
No, sir.
289.
289. 289.
હું છું.
ચલો સસ્તામ બધું. સાહેબ આવો ને પ્લીઝ.
જોડાણી સાહેબ પ્લીઝ સ્ટેજ ઉપર આવો.
બરાબર.
કોંગ્રેચ્યુલેશન.
For the same. 3 more. કાઢો કાઢો કાઢો.
અલગ અલગ કાઢો. નીચેથી છક અંદર હાથ નાખીને કાઢો ને.
223. 223.
સચિન મહેતા.
સચિન મહેતા.
223.
417.
411 છે.
અલા ભાઈ. એ ભાઈ.
448.
417 448.
Number 417 is Ruchi Ben Mayur Kumar.
ડોક્ટર રુચિ
અને બીજું કયું બીજું
નથી.
રુચિ કાબરા.
કાબરા નથી.
448.
448. ખુશી શાહ.
ખુશી શાહ.
ખુશી રાકેશ શાહ.
ખુશી રાકેશ શાહ.
સર બીજા બે ઉપર
સરખા પ્રાઇઝ
નીચે જવા દો.
બધા નહીં આવે. 262. 262.
નેહા મહેતા.
નેહા મહેતા.
ડોક્ટર નેહા મહેતા.
191.
191.
યશવી પટેલ.
યશવી પટેલ. યશવી હતી અહીંયા.
હા યશવી બન હતા.
યશવી. આકાશ.
યસ.
યશવી છે અહીંયા. સવારે હતા એ લોકો.
લખી દો. હા
જયંતિ લખીને.
ચલો એક લાસ્ટ.
નામ
2121.
લકી નંબર.
અરે વાહ આશીષભાઈ સાહેબ કોંગ્રેચ્યુલેશન સાહેબ. દર વખતે કહેતા હોય છે કે મારું નામ નથી. જો રાખીએ છીએ તમારું. આ વખતે તમે લકી બન્યા. લકીએસ્ટ પર્સન. કોંગ્રેચ્યુલેશન.
આટલું ચીયરિંગ કોઈના માટે ના થાય સાહેબ.
સર આવતા વર્ષથી મળશે આનાથી વધારે. સ્ટાર્ટ થયું છે ને એટલે.
નિલેશ સર આવી જાઓ.
છોટા સાહેબ.
ચાર્જ મેટ ટ્રાયો.
વાયરલેસ ચાર્જિંગ પેડ છે.
We have 7 charge mate trio wireless charging pad. 6.
31.
દીપાલી સતાની.
Dr. Deepali Satani.
છોટા સાહેબ.
97.
97.
પરેશ ઠક્કર.
Dr. Paresh Thakkar.
એક સાહેબ પડે કે હા વાંધો નહીં. એક તમે પડે એક તમે પડે.
327. 327.
327.
વિષ્ણુ પટેલ.
વિષ્ણુભાઈ સાહેબ. અરે વાહ કોંગ્રેચ્યુલેશન.
લકી
નામ લખી.
થેન્ક યુ.
આમાં 16 નંબર કઈ બાજુ રાખ્યો?
અંદર છેક નીચે છે. છેક નીચે છે.
કરો સાહેબ લાવજે છે.
342.
342. 342.
ફાલ્ગુની મહેતા.
ડોક્ટર ફાલ્ગુની મહેતા છે હાજર.
ક્યાં છે બધા?
80.
80.
નિખિલેશ બદિયાણી, અતુલ બદિયાણી.
ડોક્ટર અતુલ બરિયાણી.
આયા હતા. લો.
અતુલ સર હતા.
હા હતા.
લો.
રૂપેશ શાહ.
8 નંબર
ડોક્ટર રૂપેશ શાહ.
એક ઘરમાં 2 ગિફ્ટ જાય છે ભાઈઓ. બરાબર ગિફ્ટ આપી દે સર.
382 382. અચ્છા
અતુલ બરિયાણી.
ફોટો
કેવલ ગાંધી.
ડોક્ટર કેવલ ગાંધી, કેવલ આર ગાંધી.
સાહેબ બીજું
આ નામ બોલાવીને કોઈ આવેલા હોય તો કહેજો, આજુબાજુમાં ઓળખતા હોય તો.
272
શૈલજા શાહ. શૈલજા.
શૈલજા
શાહ.
શૈલજા સુરેશભાઈ શાહ.
317
317 ટોકન નંબર સાહેબ બોલાય તો થોડું.
મોહકભાઈ.
બીના જોશી. ડોક્ટર બીના પી જોશી.
ડોક્ટર બીના જોશી. 129
ભરત ગોડાદરા.
ડોક્ટર ભરત ગોડાદરા. ભરત સર આયા હતા. ભરત સર.
ભરત સાહેબનું. ભરત ગોડાદરા. ભરત ગોડાદરા સાહેબ.
98
સત્યપાલ કથુરિયા.
ડોક્ટર સત્યપાલ કથુરિયા.
નથી હવે
બોલો બીજા કોક છે.
ઉપાડો સર ને જીવ 391
અમિત શાહ.
ડોક્ટર અમિત શાહ.
અરે વાહ વાહ. આગળ જાઓ.
પહેલા આપી દો.
હાય.
7 લકી નંબર 7
અર્ચના શાહ.
ડોક્ટર અર્ચના
અવની શોટ.
ડોક્ટર અવની સોની. અવની 308
પટેલ રાધિકા ઉરંગ.
રાધિકા પટેલ. ડોક્ટર પટેલ રાધિકા.
90
નવીન પટેલ.
ડોક્ટર
નવીન પટેલ. 184
હર્ષદ આગજા.
ડોક્ટર હર્ષદ આગજા. આગજા સાહેબ હતા. અરે વાહ.
It is for Petron one Bluetooth 6 watt mini Bluetooth pocket Bluetooth.
You have 10.
Also no good.
પછી આ
સંતોષ શાહ.
ડોક્ટર સંતોષ શાહ. ઊંચું કર. નંબર તો રિપીટ ના થાય. નંબર માં
249
જૂનું છે.
મીના શેઠ.
ડોક્ટર મીના શેઠ.
397
સલોની શાહ.
ડોક્ટર સનોલી. હા યસ. ના બરાબર.
ફ્રીડમ ટુ ફ્રીડમ જોવા પડે પેલા
એક ના 172 172 ડોક્ટર પૂજા શેઠ. 256
रुचि मेहता.
डॉक्टर रुचि मेहता. रुचिर मेहता. 4 64.
કમલેશ સૈની.
Dr. Kamlesh Saini.
કમલેશ સાહેબ સાઈન હમણાં સુધી હતા સવાર સુધી
હતા. લખી
નાખો
લખી નાખી દો. 298.
કમલેશ સાઈની કમલેશ સાઈની
298.
અરે વાહ ત્રિવેદી સાહેબ કોંગ્રેચ્યુલેશન. નેક્સ્ટ ચીઠી તમે ઉપાડજો હવે મેડમ. ચિઠ્ઠી
સર બ્લૂટૂથ સ્પીકર પોકેટ બ્લૂટૂથ સ્પીકર છે સર આ ફોટો પડાવવો પડશે. સાહેબ બહાર પડી જશે.
188.
યોગેન્દ્ર ધ્રુવ.
ડોક્ટર યોગેન્દ્ર ધ્રુવ.
188.
આવો ફટાફટ આવો બદલાઈ જશે.
177.
મીતા ચૌહાણ. મીતા ચૌહાણ.
177.
લે મીતા ચૌહાણ. મીતા ચૌહાણ.
ક્યાં આગળ છે રેસિડેન્ટ? રેસિડેન્ટ
258. મુકેશ પટેલ. ડોક્ટર મુકેશ પટેલ. મુકેશ પટેલ સાહેબ મહેસાણા. 285. નીરા મમદાની. ડોક્ટર નીરા મેમ. દાખું ફેરવી નાખ્યું. મેડમ સ્પીકર આવે એ તો આવી ગયું ને 285 તો આ વાંધો હા બે બાકી છે. લો મેડમ ટુ 230. શિરીષ પટેલ. ડોક્ટર શિરીષ પટેલ સાહેબ. 71. હેતવી ગાંધી. 271. નીચે જવા દો. હા સર ના આપી દો. સરનું આ છે. હેતવી બેનનું છે. લખી નાખો નામ ઉપર સર નામ.
271.
એ છે તો હેતવી બેન. 13 નંબર. લકી અનલકી.
વેરી લકી નંબર 13.
અનલકી. સ્નેહલ શાહ.
ડોક્ટર સ્નેહલ શાહ.
છે સ્નેહલ શાહ. યસ છે. જ્યાંથી લેવું છે.
87.
87. 87 is ઉર્મિલ શાહ. ઉર્મિલ શાહ. ઉર્મિલ શાહ અહીંયા જતા ક્યાં ગયા? ના મળે. લખી નાખ. કેવું છે? ઉર્મિલ શાહ. 127. રાકેશ પટેલ.
ડોક્ટર રાકેશ પટેલ.
રાકેશભાઈ આવી જાઓ. આ સાયકલ ઉપર તમારે બ્લૂટૂથ લગાવીને જવાનું એટલે તમારા કાનમાં પેલા
સાહેબ દોડતા દોડતા આવવું પડશે, ચાલતા નહીં ચાલે.
આ બોટ
આ રનિંગ કાઉન્ટ થશે સર તમારા વોચમાં.
ઓકે સોરી.
454.
454.
મેહુલ શાહ.
ડોક્ટર મેહુલ શાહ. મૂકી દો. 22. 22. અરે ત્યાગી સર.
ત્યાગી સાહેબ. 248. લાજવંતી ભટ્ટ. ડોક્ટર રાજવંતી મેડમ ભટ્ટ.
This is for Bluetooth speaker with mic.
શશાંકભાઈ સાહેબ.
સર આવો ચિઠ્ઠી ઉપર
આ બોલો 162.
સાહેબને લાગ્યું
ધવલ રાજપરા. ધવલ રાજપરા ક્યાં છે? અહીંયા હતા. હા હા. નામ ઓલામાં
આઈ જાઓ નંબર યાદ ગિફ્ટ માટે બોલાતા હું પાડે મેં કીધું કે સાહેબ ગિફ્ટ માટે બોલાતા
દર વખતે કઈક આવે
તો તમને તમારો નંબર યાદ નહોતો ને ધવલભાઈ?
એ બધી ઉપડી ગઈ
ના ના નીચે મેં નીચે નાખી દીધી ઉપર ભેગી ના થઈ ને એટલે પાછી આ મેં કીધું
77
લકી
77
તિલક પ્રજાપતિ. તિલક પ્રજાપતિ હતા હતા અહીંયા જતા હતા. લો તિલક પ્રજાપતિ. તિલકભાઈ મેચમાં અમને જીતવા માટે 337. સ્મિત સાદરિયા. હેમરાજ સાદરિયા. સ્મિત સાદરિયા નથી જવા દો.
73
ડોક્ટર સુનિલ. ડોક્ટર સુનિલ. સુનિલ શાહ. રેખા મેડમ ચીટ ઉપર આવી જાઓ.
34
અભિષેક ચૌહાણ.
ડોક્ટર અભિષેક
ચૌહાણ અહીંયા હતો. અભિષેક હતો. લો અભિષેક નું કયું છે? આ સુનિલ સર નું. આ સુનિલ
પેલો
અભિષેક લે. અભિષેક ઉપર લખીને
ફિલિપ્સ હેડફોન્સ
મને આપી દેજો. હું આપી દઈશ એને.
લાસ્ટ
હજી આ બાકી
7 gifts 8 gifts left
278 હજી આનું ચાલુ છે.
279 279
279 શ્યામલ દ્વિવેદી. શ્યામલ દ્વિવેદી
નથી આયા.
નથી. બોલો મેડમ.
તમે કે દવા પડો નંબર ના લાગ્યો 59 કે ખુલતું નથી
190
હરગુરપ્રીત સિંહ. હરગુરપ્રીત સિંહ.
આજે રેસિડેન્ટ્સ જે છે બધાનું લક સરસ છે.
બધાના રેસિડેન્ટ નામ આવે. 63
એ નહીં મેમ આ છે ના ના 1 નંબર ડોક્ટર ભાવિક ઝાલા. ફોટો આનો ફોટો પ્લીઝ.
કોંગ્રેચ્યુલેશન. અરે વાહ ઓહો સરસ આમ ફોટો રાખો. કોંગ્રેચ્યુલેશન.
59
રેખા બરવાડા.
તમે ઉપાડ્યું ને ચાલો
મેમ લો પ્લીઝ
બાકી છે ભમર સાહેબ. ભમર સાહેબ
પેલું સાઈડમાં મૂકો જે આવ્યું 338
મેઘા બ્રહ્મભટ્ટ.
ડોક્ટર મેઘા બ્રહ્મભટ્ટ 325
સંજય સવાણી.
ડોક્ટર સંજય સવાણી. ડોક્ટર શરદ પ્લીઝ ડू द ऑनर्स. डॉक्टर अंकुर आप भी आ जाइए प्लीज. 435
बिल्कुल.
डॉक्टर आलोक गुप्ता
सर मेरा निकाला ना लैपटॉप पे तो आपको 406 वोट दूंगा मैं।
क्या बात है,
195
दूंगा। वेरी गुड, जरूर मिलेगा। 195 is शालीन शाह।
डॉक्टर शालीन शाह।
बरोडा वाला।
114
डॉक्टर शालीन शाह। 114
डॉक्टर मंथन पटेल। द लास्ट गिफ्ट बिफोर द लैपटॉप।
बिफोर द लैपटॉप।
404 404।
वेरी क्लोज।
નથી है
બીજું મેં એવું છે હજી એક
हाँ ट्रेड 349
मोनिका जेठानी।
डॉक्टर मोनिका जेठानी, शी वाज देयर। चलिए, नाउ द लैपटॉप इज लेफ्ट, और उसके पहले हम ट्राई करेंगे कि सब ट्रेड पार्टनर्स के लिए जो है वो गिफ्ट्स कंप्लीट करें। ट्रेड पार्टनर्स का एक मोबाइल फोन भी है। कहाँ है ट्रेड वाले सब? धवल भाई फ्रॉम ट्रेड आ जाओ। बिल्कुल सर, आप हाँ मैसेज देके
बस आप लोग सब लोगों का बहुत प्यार मिला और लगा जैसे एक ही फैमिली है। हम आप लोगों से अलविदा आप जो कर रहे हैं, एंड सी यू ऑल। दिल्ली में आइएगा और हम लोग आपका स्वागत करेंगे। और हमारे इस बार प्रेसिडेंट हमारा यहाँ से होना चाहिए गुजरात का, ये मैसेज पूरे इंडिया में जाना चाहिए। शरद लखोटिया, अंकुश, थैंक यू। एक शायरी सुना के
ये यही मौके पे दे दीजिए।
मैं डॉक्टर शरद लखोटिया रिक्वेस्ट करूंगा, वो ऐसे शायरी के एक्सपर्ट है, एक शायरी सुना के जाएंगे। आप सब लोग याद रखेंगे आपको। अब ये माहौल अलग तरह का है तो
कल वाली भी चलेगी सर।
मधुशाला वाली भी चलेगी। अच्छा, इनको मधुशाला वाली सुना देता हूँ। कल शाम को हम लोग बैठे थे तो जीवन के मधुबन में जब तक मधु है तेरा मधुबाला, पी लेने दे जब तक तू है मैं यह मधु की शाला। जीवन के मधुबन में जब तक मधु है तेरा मधुबाला, पी लेने जे जब तक तू है मैं हूँ ये मधु की प्याला। कल माटी में मिल जाएगी मस्ती की मोहक बस्ती, तब न रहेगी सुरा सुराही और न यौवन की हाला। तो इतना बढ़िया ये समागम हमारा आप लोगों का ये चलता रहे, दौर चलते रहें, ऐसे होते रहें, और हमारे आपकी प्रेम और प्यार ऐसे ही बढ़ता रहे, उमड़ता रहे। धन्यवाद।
एट दी वेरी ऑन सेट मैं तहे दिल से धन्यवाद देता हूँ सर को एंड पूरी टीम को, जिनकी वजह से हम यहाँ आ पाए, एंड आपका सबका प्यार हमको यहाँ लेके आया। मैं दिल्ली ऑप्थेल्मिक सोसाइटी का एग्जीक्यूटिव हूँ, और आने वाले अप्रैल 24 to 26 हमारी कॉन्फ्रेंस हो रही है डॉस की दिल्ली में। एंड डॉस की कॉन्फ्रेंस का वेन्यू हमने मूव किया है अशोका होटल से भारत मंडपम वही सेंटर है जहाँ पे हमारी जो मोदी साहब ने पूरे कई देशों के साथ मीट कराई थी। तो उस भारत मंडपम को देखने के लिए आइए, हमारी डॉस में आइए, अपने घर आइए, क्योंकि ये हमारा घर है, आपका घर वहाँ है। प्लीज़ आई वेलकम यू ऑल टू आवर डॉस कॉन्फ्रेंस। थैंक यू।
Dhaval bhai, do the honors.
Thank you. Bluetooth
It is for Bluetooth speaker. Biotech.
Biotech people? Anyone from Biotech?
Biju?
Bayer Pharma? Anyone from Bayer?
Smoke Aija.
बोर्ड ब्लूटूथ स्पीकर राकेश भाई राकेश भाई राकेश भाई लकी दो रेमेड ट्रेड वाला बदन बहुत जल्दी है रोश राकेश बेयर now the mobile phone for trade partners
biomedics
कर दी बिल्कुल
काश्मीरी पंडित
ना पढ़ मोबाइल के लिए जो है उनको ही मिलेगा अजंता फार्मा નથી now the trade partners are happy સાચી વાત છે બિલકુલ જે બેઠા છે એમને જ મળવું જોઈએ ડ્રીમ ફાર્મા
बैठा है एक नाम बोल दो
સનવેશ કોણ બેઠું છે એટલું કહી દો તો એ નામ કહી દઈએ સન ફાર્મા
મેં કહ્યું મારામાં આની સાથે સીએમઈ આપી કરવી પડશે
Really deserving because they have arranged all the faculty, transportation, and all the transport facility provided by Sun Pharma. So much deserving.
I'll invite Dr. Nitin Shah to do a cheat. Nitin bhi aao. For the bumper lucky draw of a laptop. The person who is present here only will be able to get it.
જે હાજરો યાર
એવું છે અમારે એવું જોઈએ આપણે બેઠા અમારે એમાં અલાઉ કરું છે બધી છૂટ છે એક નીચેથી ગાળો તો છૂટ છે
રજીસ્ટ્રેશન કરાવી દીધું તારો નંબર
તો તારામાં નીકળે
નંબર બે છે
તો ત્રણ તો નીકળે
389
પ્રોગ્રામ જુઓ
389 ઉભા 389 ને
કેટલા ખર્ચ થયો બધા
જિગ્નેશ જેઠવા
એ ના ચાલે થોડું ચીયર કરો બધા લેપટોપ માટે છે લાસ્ટ ધ મેગા લકી ડ્રો 154 154
પ્રજાપતિ
તો હજુ હાજર નથી
બધા પોતાના જે છે બેચ ફરીથી ચેક કરી લેજો ફરીથી નંબર યાદ રાખી લેજો
હવે નામ બોલવામાં નહીં આવે નંબર ભૂલ્યા તો ક્યાં હા બસ નંબર યાદ રાખો
ઉપાડો સાહેબ તમારા માટે જ વેઇટ કરે છે
નહીં બોલવામાં આવે
288 नहीं चलो नेक्स्ट त्यागी सर आओ साहब This is HP laptop with i5 configuration.
Number 5.
5.
Number 5.
7 नंबर गया 5.
3 नंबर मारो આવતો નથી કે 3 से आगे
તમારો નંબર કયો છે તે
161
ડબલ હવા હું તો
$252. ફરી
348.
348. 348.
બરાબર ભલે ઓછું સાહેબ અમારે 400 છે
જે નંબર રહી ગયા ને એમાં
310
310. અરે
આવું ના હોય
Wait, the person is not here. Wait. The lucky law is still going on. બાકી છે, બેસો.
બાકી છે.
ડોક્ટર હર્ષદભાઈ શાહ આવો ડોર ચીજ કરવા માટે. અરે આવો સાહેબ, આવી જાઓ.
એમના ફ્રેન્ડ જેવું કહેવાય ઇમરજન્સીમાં ગયા છે
ડોક્ટર હર્ષદભાઈ
લકી ડ્રો બાકી છે જી
બાકી છે. બધા બેસી જજો, જતા રહ્યા એમને નહીં મળે ફરીથી.
બેસો નહીં તો નહીં બોલાય.
હજી છેલ્લો ચાન્સ છે. આને કહેવાય રિયલ લકી બમ્પર.
જે ઊભા હશે ને નહીં મળે, બેઠા હશે એને જ મળશે. એટલે બધા
બેસી જાઓ નહીં મળે.
જે ઊભા હશે એને એલિજિબલ નહીં ગણાય.
સાહેબ ઉપાડો 25 નંબર.
તમે જોઈને કહો.
295.
રિયલ લકી મેન.
ઊભા એમને નહીં મળે.
ઊભા થાય એટલે કેન્સલ.
મારા